C'est stress pour moi. Good morning.
Our e-research paper session has been started, and I would like to request our coordinator that please start the presentation. Also, I would invite our chairpersons, Dr. Rekha Solanki. Thank you. Our first participant is Ketki Jindal. I would request coordinator please start the meeting and play her video.
Good morning, everyone.
Good morning.
Should we start the session?
Yeah. So Dr. Rekha Solanki is here with us. She has experience of 25 years in anesthesia. She has been awarded by Dr. T.B. Patel for Young Research Scientist Award, and also awarded by Best Scientific Paper Presentation. Her special achievements are IRC and CPR instructor. She is also researcher in basic course in biomedical research, ICMR, good clinical practice, and up-to-date trainer. So we are going to start the session. Thank you, ma'am, for joining us.
Yes, please. Thank you for the introduction.
Ma'am, Dr. Rekha, should I start?
Yes, please.
Okay, ma'am. Okay.
Good morning. I'm Dr. Ketki Jindal from GMC Jammu. My title is Atraquidone with Tramadol or Ketorolac as an adjuvant to low-dose glucosamine, intravenous regional anesthesia, a comparative study. Introduction. IVRA is a simple and reliable and safe local anesthetic. Being a regional technique, it is devoid of complications of the general anesthesia, especially in patients coming for emergency surgeries as well as patients belonging to AFC grade 3 or 4. Its limitations include slow onset, tourniquet pain, and minimal post-operative anesthesia. Adjuvants to local anesthetic for IVRA are meant to enhance the quality of anesthesia, tourniquet tolerance, and post-operative emergency. Material and method. A randomized clinical trial was done in the Department of Anesthesia, GMC Jammu, for a period of 6 months. 75 patients of AFC grade 1 and 2 posted for elective surgery on forearm and hand in the age group of 18 to 60 years of IL-6 for inclusion. Patients were divided into the below-mentioned groups, 25 patients, and the selection made by using computerized general random numbers, so as to receive one of the three solutions, a double-blind fashion. Group A received 40 ml of 0.5% lignocaine. Group B, 0.25% of lignocaine with 50 ml of tramadol and 2 milligrams of atraquinone diluted in MS to make a volume of 14. Group C, 0.25% of lignocaine and 30 milligrams ketorolac, 2 milligrams of atraquinone diluted in MS to make a volume of 14. Inclusion criteria. Patients posted for elective surgeries on forearm and hand under the regional anesthesia, PSA grade 1 and 2 in April 18 to 60. Exclusion criteria. Patients below the age of 50 and above 65. Patients in age patients with tracheostomy, patients with septic heart failure, cognition
Hello,
disorder,
voice is not clear. So much disturbance is there.
patients suffering from diabetes,
नहीं 4 मिनट नहीं ज्यादा क्या लेना भाई
Hello,
मैंने आपके
Rohit sir, can you please mute yourself?
Mr. Rohit, Mr. Rohit, mute yourself.
Underway tonic with
अरे रोहित जी आपका माइक ऑन था
operating reducing the tonic pain. Attenuation of the limb function by application of other limb elevation of pain. Proximal tonic was infused 100 milligrams. 40 ml of the study drug was then given over a period of 1 week. Once the patient felt uneasiness of proximal tonic after 20 minutes, whichever was needed, the distal tonic was inflated at the same pressure the proximal cuff was inflated. The surgery was allowed to proceed once the block was complete. In case of incomplete or partial block, supplement GA was given and the tourniquet was used only after 40 minutes. The patient was excluded from the constant sensory block assessment. Response to zero being sharp, 1 to touch only, and 2 cannot feel pain. Score 2 was taken as onset of complete sensory block. Onset of motor block was assessed by the following scale. 0, able to move arm against resistance. 1, inability to move wrist against resistance. 2, inability to move wrist and elbow against resistance. And 3, being inability to move the arm against resistance. Score of 3 was taken as the onset of complete motor block. Intraoperative degree of analgesia was evaluated by VAS of 0 to 10 centimeter scale. Complications, if any, was reported intraoperatively and postoperatively. Ethical clearance was taken from the ethical committee, and statistical analysis was used during using ANOVA test on MS Excel 2010 software, and t-test was performed for intergroup comparison. Result: there was no statistically significant demographic data of the patients. All were significant in age, weight, and gender. There were also the duration of surgery was found to be statistically insignificant. However, a statistical significance was seen in among the groups in the time of onset of block as well as in the time of onset of. Also, the VAS score was found to be statistically insignificant amongst group 1 and 2 at 10, 20, 30, and 40 and 50 minutes, and it was found to be of statistical significance between group 1 and 3 and 2 and 3 among the different groups. There was no known complication was reported in any of the cases. So we can now conclude that addition of atraquinone and ketorolac to a smaller dose of lignocaine IVRA provided improved tonic tolerance, prolonged analgesia in the form of sensory and motor block during and after the medical procedure with diminished needs for analgesic requirements. Thank you.
Hello, Dr. Ketki. Hello.
Good morning, ma'am.
Yes, good morning, Dr. Ketki.
Good morning, ma'am.
This was a very nice presentation.
Thank you, ma'am.
I have one question that how did you calculate sample size?
Ma'am, it was done by computerized generated. The sample size was, I have just gone to the statistician, and this was roughly.
We're asking about sample size and all, how you calculated sample size. I'm not actually that best to know.
Mentioned this size, so I just accepted that.
Hello.
Hello.
Did you use any formula for sample size calculation?
No, ma'am, I didn't use any formula, but I just went to our statistician in the hospital, and this was what he recommended, so I went ahead with that.
Yes, that's right. We can take help of statistician for sample size calculation, but every anesthesiologist must have basic knowledge of how to calculate sample size, right?
Yes, ma'am. I'll definitely look into that, and I'll definitely improvise on that for my next
Okay.
session.
Otherwise, it was a nice study.
Thank you, ma'am. Thank you so much.
Okay, thank you, Kirti.
Our next participant is Dr. Katrina, and I would like to request the tech team to play her video.
My topic is a comparative study of gum elastic bougie-guided insertion of Proceal LMA with digital technique in anesthetized, spontaneously breathing patients undergoing elective minor gynecological surgeries. Supraglottic airway is a bridge between non-invasive face mask and more invasive ET tube. Nowadays, LMA has been increasingly used to maintain airway instead of endotracheal tube, but it has its own disadvantages like risk of aspiration, gastric distension, etc. Due to its modified cuff properties, Proceal LMA enables adequate ventilation and prevents aspiration. Proceal LMA, when inserted by digital technique, poses a lot of problems leading to inadequate ventilation and misplacement. To overcome these problems, newer methods of insertion has been introduced like bougie-guided technique and introducer tool technique. My study compares gum elastic bougie-guided insertion of Proceal LMA with digital technique in adults with respect to number of attempts to successful placement, effective airway time, hemodynamic response to insertion, airway trauma during insertion, presence of visible blood staining, and postoperative airway morbidity. My study is a prospective randomized comparative study. After obtaining written informed consent and IEC clearance, study was carried out in 60 adult female patients in age group of 21 to 60 years, belong to ASA PS 1 and 2, posted for elective minor gynecological surgeries at Institute of Obstetrics and Gynecology, EGMOR. Sample size was calculated based on the previous studies. An inclusion criteria were female patients belonging to 21 to 60 years, those who are belonging to ASA PS 1 and 2, BMI between 20 to 25 kg per meter square, modified Mallampati score 1 and 2, etc. Exclusion criteria were patients with difficult airway, Mallampati score 3 and 4, patients with risk of aspiration, ASA 3 and 4, obesity, pregnancy, etc. Using closed envelope method, patients were randomized into two study groups. Proceal LMA was inserted using digital or bougie-guided technique according to the study group after induction. In bougie-guided technique, well-lubricated 16 French bougie was inserted into the drain tube, while laryngoscopy 5 to 10 cm of straight end of the bougie was inserted in the esophagus and device was trail-loaded along the bougie. Coming to results, bougie-guided technique had higher first attempt success rate, significantly longer effective airway time, and significantly higher oropharyngeal leak pressure when compared to digital technique. There was no statistically significant hemodynamic response to insertion, airway trauma, visible blood staining in both techniques. Come to discussion, success rate of insertion of Proceal LMA in first attempt was higher for bougie-guided group. The effective airway time was significantly higher for bougie-guided group, and incidence of failed insertion was more with digital technique. And oropharyngeal leak pressure was significantly higher in gum elastic bougie-guided group when compared to digital technique. No significant blood staining was present in both groups. Our study, and there was no significant hemodynamic response to insertion in both techniques. To conclude, gum elastic bougie-guided insertion of Proceal LMA is an excellent alternative to classical digital technique in adults with regard to number of attempts to successful placement, hemodynamic response to insertion, airway trauma during insertion, and presence of visible blood staining. Higher oropharyngeal leak pressure associated with bougie-guided technique makes it a more effective alternative to classical digital technique. These are my references. Thank you.
Hello. Hello.
Hello.
Yes, doctor. Your presentation was very nice. You have chosen
Thank
very
you,
nice
madam.
topic.
Thank you, ma'am.
Yes. Many times students make mistakes. They don't calculate sample size. Hmm. You should
Yes.
focus on some statistical aspect also, because this will reflect your results,
Okay, ma'am.
And in
Ma'am, in
discussion,
my studies sample size, actually I have gone through the previous literature. Sample size was calculated from the previous studies, ma'am.
okay. And which are the other methods by which you can choose your sample size? One is already published literature. Then
Yes, ma'am. I actually I got two references. One is by Brimacom Keller.
yes, that's
And
right, and that's very good. This is
one is
the
Nahid Assad. So based on hello. So
yes,
from there,
yes.
like from their studies, we got an approximate calculation. So based on which I calculated the sample size.
Which
Have
are the
you used?
parameters? Yes, ma'am. Yes, ma'am. Vaishali, ma'am. Good morning.
Yeah, good morning. Have you used any point to be considered for sample size estimation, like success rate, or like using any complications? From the Birmacom reference, you should have used some criteria for the sample size estimation.
Yes, ma'am. I calculated based on the like number of first attempt success rate was one parameter. Another was post-operative airway mobility.
Okay, so that you should have mentioned in your
Faculty session chair kari e-paper.
Okay, ma'am. Okay, ma'am.
And what about the first attempt? Was it after the experience, or was it after? Means you have who has done exactly? Was it you who had done all the cases, or it was very different persons?
But first attempt success rate was calculated from my study only, ma'am.
No. The person who was doing using Proceed. So was it you only, or there were various other
No, ma'am.
different?
I personally I personally did, ma'am.
Okay. So was it
Not
after any doing certain kind of or certain number of cases previously and then attributing other cases into the study? So I
yes,
want
ma'am.
to.
Initially, we conducted a pilot study for 20 patients.
Okay.
So
And then you
based on
included it in study.
yes, ma'am.
Okay. Thank you. Over to other chairperson, please.
No, ma'am. No questions. We can
Okay, we
proceed
can
for
go.
next presentation. Yes, ma'am.
Yeah.
Dr. Vaishali,
Chairperson, call I.
here Dr. Vaishali Chandrasekhar is she is with us. She is a recipient of Maharashtra Medical Council Award in Medical Teacher category for 2026. She is also nominee for BMJ Award in September 2017. She is also Best Young Faculty. She is also received Best Young Faculty Award in July 2018. She has also received a Best Medical Teacher Award by Director Medical Education and Research Government of Maharashtra in September 2018. She is instrumental in setting state-of-art SICU and 600 bedded DCH at IGGMC Nagpur, member of Nagpur District Oxygen Task Force, and also member of Hospital Graduation Project Team IGGMC Nagpur. She is also special anesthesia and critical care, difficult airway management, and theroscopic and mediasonic procedure. Thank you, ma'am. Thanks for being with us and for your important time.
Let's move on to the next presentation.
Hello everyone, I'm Dr. Shrikant Gujja. I am presenting a case study, a prospective randomized double-blind study on the effect of perioperative intravenous lidocaine versus intravenous normal saline on hemodynamic response to intubation, extubation, and postoperative analgesia in laparoscopic cholecystectomy surgeries. Introduction. A current trend is move away from opioids as mainstay of postoperative analgesia and move toward multimodal approach. Laparoscopic cholecystectomy, despite being a minimally surgery, many patients suffer from moderate to severe pain. All the studies so far were taken into consideration only a single parameter of lidocaine utility as either attenuation of hemodynamic changes secondary to intubation and extubation or postoperative analgesia. Objectives of the study: primary objective to evaluate the effect of intravenous lidocaine infusion on postoperative pain-free period. Secondary objective to evaluate the effect of intravenous lidocaine infusion on pulse rate and mean arterial pressure, which responds to intubation and extubation. Material methods: sample size 60 patients in each group, total 120 patients. Sample size calculation based on statistical software G power 3.1.92, and the formula mentioned as here. Randomization done by Chitin box method. Group A received normal saline placebo. Group B received a preservative lidocaine free 2%, which is 1.5 mg per kg. Bolus given over 10 minutes, followed by 1.5 mg per kg per hour till 1 hour post-op. Data collection: hemodynamic assessment done by pulse rate and mean pressure, which taken baseline parameter, then before induction, and then after induction, after intubation, and after extubation at 1 minute, 3 minute, 5 minute, 10 minute interval. And while postoperative anesthesia was assessed by recorded pain-free period. Attending staff nurse recorded VAS course every 50 minutes in initial first hour, then every 2 hours till 24 hours postoperative period. Whenever patient complained of pain during postoperative period. Pain-free period less than VAS score 4 was taken as a period from conclusion of surgery to first requirement of injection of tramadol. The nursing records patients were reviewed at the end of 24 hours to note the VAS scores. Results: during laparoscopy, laryngoscopy, and intubation, and the hemodynamic parameters, pulse rate and BP rose significantly in both groups, though rise in lidocaine group significantly less than group normal saline. Similarly, during extubation, lidocaine group has a less stress response, and the mean pain-free period is more in lidocaine group comparing with the saline group. None of the patient complained of lidocaine toxicity, and you can see here extubation at different times. Similar findings we observed for intubation as well. Stress response is less in lidocaine group comparing with normal saline. Here we can see postoperative pain-free period, which is more in lidocaine group compared with normal saline. And conclusion: IV infusion of lidocaine significantly increases pain-free period postoperatively, so it can be used as a multimodal analysis approach for postoperative anesthesia. Lignocaine IV infusion is safe, cheap, and better alternative for postoperative anesthesia. Administration of lignocaine IV infusion attenuates the rise in pulse rate as well as mean pressure during peri-intubation, peri-extubation period. Recommendation: IV infusion, IV lignocaine infusion have a significant analgesic effect in postoperative period, so it can be used as a multimodal approach for postoperative anesthesia. Lignocaine IV infusion attenuates the rise in pulse rate as well as mean arterial pressure during peri-intubation and peri-extubation period. Thank you.
Yes, doctor. Nice presentation. For how much time you have kept the lignocaine drip? Am I audible?
Yes, ma'am, you are audible. Participant is not audible.
Yeah, actually, my video got muted, now unmuted.
No problem, no problem.
Good morning,
So,
madam. Usually laparoscopic cholecystectomy surgery usually happens for 60 minutes, 1 hour in our institute. So I continued 1 hour more. So 1 hour post-op extra.
So is what that was for all the patients?
Yeah, all the patients. So whoever patient exceeding 1 hour or surgery prolonging, then I exclude that patient.
Okay.
To avoid lignocaine toxicity.
Okay. What was the analgesic used for the intraoperative period?
I used fentanyl 2 mics per kilo, madam.
Yeah, and postoperatively you didn't give anything unless and until the vascular.
I didn't give because I don't want any confounding factors.
Yeah. So 1 hour postoperatively giving lignocaine, and you have received a significant result that the post-op analgesia was good. So
yes.
what must be the cause of that good postoperative analgesia? Reason behind that postoperative analgesia? Is lignocaine a good analgesic? Or which property of lignocaine would you attribute to this?
Usually lignocaine IV, there are certain mechanisms, central and peripheral mechanisms. So prevention of wind-up phenomenon while during surgery, while incision, it prevents wind-up phenomenon, hyperalgesia, and it have a NMDA receptor antagonism as well. Apart from its well-known mechanism, sodium channel blocking property. So there are multiple factors involves lignocaine analgesia effect.
I do agree to the intubation and extubation response. But for analgesia, I would say that in view of patient safety, at least some kind of NSAIDs should be given.
I mentioned. Yes, I agree that because it is considered as a multimodal approach, not a single. I mentioned that.
Okay. Yeah. Thank you. Over to the chairperson, please.
Yes, thank you, ma'am. Dr. Shrikant.
Yes, ma'am.
In discussion part, you should have mentioned or cite some references, you know.
Actually, at the time of submission, there are no guidelines what are all to be kept. So I missed that. Next time I'll keep it. I missed it.
Whatever is the guideline, there was only time constraint. No? Otherwise, you should have been ready with the PPT, and which should include the proper discussion also.
Okay, madam. Next time.
Okay,
sure.
No problem.
Sure.
Second thing, Shrikant, how much total dose of lignocaine was used?
It is a 1.5 mg per kg per hour, madam.
So what was the total amount used?
Total amount I didn't calculate because up to 2 mg per kg it is safe. Okay. I didn't use for not more than 2 hours. So calculating how much drug I gave, it is very less significant. So I didn't calculate the dose, how much drug I gave, because it is very less amount.
Ideally, you should have calculated, because we don't know when we cross the safe dose of lignocaine.
Yeah, 3 mg per kg we should not cross. Yeah. So it always will be less only.
And
because
yes, ma'am. Yes, ma'am. Carry on.
No, you can continue.
And did you find any complication or side effects related to lignocaine?
No, because the duration of infusion I gave only maximum 2 hours. So I didn't get any lignocaine side effects.
So you must not have measured the plasma concentration of lignocaine, right?
Yes, we should measure. We should measure,
Yes.
but that's a costly thing. And our hospital don't have that facility, so I didn't measure. Ideally, we should do.
Okay. Thank you, Shrika. Yes,
Thank
Vaishali ma'am. Yes.
Yeah, we can go for next candidate.
Yes, ma'am.
Thank you.
Did you get it? Next presentation. Start next presentation, please.
Hello everyone, I am Dr. Shrikant Gujja. I am presenting a study, a prospective randomized comparative study to compare the effects of ultrasound-guided adductor canal block versus femoral nerve block on quadricep muscle strength and postoperative pain in patients undergoing unilateral total knee replacement surgery. Background: femoral nerve block is commonly used as an analgesic modality and is considered the standard peripheral nerve block in patients undergoing TKR, total knee replacement. However, femoral nerve block is followed by a significant decrease in quadricep muscle strength, resulting in delayed mobilization, which is associated with potential risk of fall. Adductor canal block that offers almost pure sensory block with minimal motor involvement as a part of multimodal approach to pain control after total knee replacement. Use of ultrasound guidance has become more popular and safe and effective. Introduction. Total knee replacement involves extensive bone resection and soft tissue manipulation, and patients can experience severe pain during the early postoperative period. This surgical population consists primarily of elderly patients, often with significant comorbidity. The postoperative anesthesia regimen should aim to reduce morbidity and enhance functional recovery the minimum side effects. Aims and objective: aim of study is to combine posterior capital infiltration with adductor canal block or femoral nerve block in patients undergoing total knee replacement surgery and compare quadricep muscle strength and analgesic efficacy in postoperative period. Primary objective to compare the quadricep muscle strength in both groups. Secondary objective to compare the postoperative anesthesia and requirement of rescue analysis between two groups. Material method: study design. After obtaining instruction ethics committee approval, written informed consent was obtained from all patients involved in the study. This was a prospective randomized study of 56 cases. Selection of patients was carried out randomly using computer-generated randomized table. Using block randomization technique, 56 patients were put into two groups. Each group 28 patients. Group 1 received adductor canal block. Group 2 received femoral block. Patients in both groups received posterior capsular infiltration by surgeons during surgery before placing the implants. Sample size: 56 patients were randomly allocated into two groups. Patients in group 1 and group 2 femoral block as shown here. Here image you can see ultrasound guided adductor canal block and ultrasound guided femoral block. Here both patients received ultrasound guided 50 ml of 0.18% ropivacaine followed by continuous infusion 0.18% ropivacaine 8 to 10 ml per hour. Here you can see posterior capsular infiltration analysis mixture contains ropivacaine 20 ml, 7.5 mg per ml, ketorolac 30 mg per ml 1 ml, clonidine 1 ml, 0.15 mg per ml, morphine 10 mg per ml 1 ml, and normal science 37 ml, total 60 ml infiltrated into posterior capsular. And next image you can see continuous nerve block infusion. Sample size calculation as you can see here. And the statistical analysis done by SPSS version 21.50. All p-values less than 0.05 considered as a statistically significant. Results: patients in both groups were observed for quadricep muscle strength measured by MRC grading as 24 hours after giving block. After 6 to 8 hours, difference in MRC grading between two groups were not significant, whereas 12 hours and 24 hours, the difference in MRC grading between two groups was statistically significant. Adductor canal block patients having higher grade, which implies that cortisol muscle strength was well preserved in patients receiving adductor canal block compared with the femoral nerve block. Here you can see the MRC grading between adductor canal block and the femoral nerve block. And here you can see vascose and analgesic requirement. Both adductor canal block and femoral nerve block patient having similar vascose and analgesic requirement. Here both groups also observed for vascose and required additional analgesics at 6, 12, 24 hours. And their secondary outcomes, both groups having similar vascose and analgesic requirements. And both variation hemodynamic parameters in both groups are similar. Limitation, we did not compare the cost effectiveness or time required or anesthesiologist learning curve for a satisfactory blockade. Conclusion, adductor canal block is an effective alternative to femoral nerve block to provide a less quadricep muscle weakness, faster recovery, and comparable levels of analgesia with a decreased risk of falls. Recommendation, our finding in this study indicate that adductor canal block is one of the most useful analgesic modality in contemporary perioperative management protocol that focus on rapid recovery after re-surgery. Adductor canal block can be performed safely, easily with the recently introduced high quality portable ultrasound technology for the surgeries around knee joint with high success rates. Thank you.
Hello, doctor.
Yeah.
Yes.
Good morning, madam.
Good morning. It was a good presentation. I want to know what was the primary anesthesia choice? What regional anesthesia? Spinal or epidural?
Spinal. Both patients spinal.
Okay. So what was the drug and volume of drug used in spinal?
3 ml, 0.5% heavy bupivacaine.
Without any analgesic there?
No, madam.
And block was given at what point of time? SCB
immediately.
Or,
immediately after dressing, we have done.
Means post-operatively you have given the block.
Yes, yes.
So what was the analgesia level of spinal at that time? Was it similar or was it different in all the patients? What was that mean analgesia level? Yeah, sensory level.
T10, madam.
So for every patient at T10 you have given. And how the randomization was done?
Usually chit in a box. Usually we do daily 2-3 cases. So randomly we put chits for 2 patients. So it like my consultant will select pick up which patient to give femoral or which patient to give adductor canal. Just like chit in a box method we have done.
So regarding the posterior capsular infiltration, I would say it was a almost cocktail of all the drugs.
Yes, yes.
So, yes, so these drugs are also absorbed systemically in a period of time.
Yes, yes.
And also infusion of ropivacaine given.
Yes, yes.
So can you attribute this solely to the block you have given? The potentiation of analgesia or the quadricep muscle strength.
Yes.
So can you attribute it alone to the block?
No, it is a multimodal, it is a multimodal thing. So analgesia effect in both groups, it is same if you see the statistics. So it is like multimodal, I mean to say.
Okay. So was physiotherapy earlier started in the ACB group?
Usually limb mobilization and next day patient allowed to walk with support.
And what were the complications? Because so many drugs were used. Were there any systemic complication noted?
No, madam. Not a significant.
But what do you expect?
No, with this study, what I wanted to say is femoral nerve block will cause this quadriceps muscle weakness. So giving adductor canal block, we can avoid this quadriceps muscle weakness. So in this TKR, totally replacement surgeries, early mobilization will help early discharge, and we can avoid this DVT. Prolonged immobilization will cause DVT, and and more complication and delay discharge. So giving this adductor canal block provides early mobilization and early discharge and patient satisfaction.
Over to other Jefferson, please.
Yes, thank you. Dr. Shrikant,
Yes, ma'am.
did you take ethical committee approval?
Yes, we have taken, but I think I didn't mention there. Yes, we have taken.
Okay, and was this study registered under CTRI? Because this is
Yes,
a prospective randomized control trial.
Yes, it is registered.
Okay, and you didn't mention its number, no?
Yeah, I didn't mention. Yes. Maybe I registered.
And which are the checklist for randomized control trials that you should follow? Do you have any idea regarding concert chart?
No, madam.
Okay, you should use concert chart as checklist for randomized control trials.
Okay.
And did you find any postoperative complications?
No, madam.
Okay, thank you.
Thank you.
Fourth participant is Anurita Punukar. I would like to request the tech team please play her video.
Respected judges, I, Dr. Anurita, will be presenting paper on effectiveness of granisetron in prevention of hypotension following subarachnoid block in patients undergoing elective cesarean section. I'll be talking under the following headings. Subarachnoid block is the most common technique used for lower segment cesarean section, which is considered to be safe. Adverse effects like hypotension and bradycardia are highest in pregnant patients. To minimize this or prevent, we can use left uterine displacement, preloading or co-loading with crystalloids or colloids, or vasopressors like ephedrine and phenylephrine. My aim is to compare the effectiveness of granisetron versus saline in preventing postspinal hypotension in cesarean section patient. My objective is to prove effectiveness of granisetron in preventing postspinal hypotension. It is a prospective randomized double-blind study conducted after obtaining Institutional Ethical Committee clearance during November 2020 to August 2021 at BG's Global Institute of Medical Science, Bangalore. With 90% statistical power and 5% level of significance, the sample size was 80, that is 40 in each group, with the following formula. I included patients belonging to ASA2 with height of 150 to 160 centimeter, 20 to 30 years of age, who are willing to give consent with normal singleton pregnancy beyond 36 weeks of gestation. I excluded patients with hypersensitivity to study drugs, with significant coagulopathies and other contraindication for spinal anesthesia, with pregnancy-induced hypertension, and with history of any systemic disorders and previous pregnancy. Pre-anesthetic evaluation was done and pre-medicated with injection metoclopramide 10 milligrams IV. Patient was shifted to preoperative room and IV line with 18 gauge was secured and infusion of 500 ml ringalactate started. Non-invasive monitors like pulse ox and NIBP ECG was connected. After shifting the patient to operation theatre, drugs were given depending on the group they belong to. That is, Group G received injection granisetron 1 mg diluted in 9 ml normal saline, and Group S received 10 ml normal saline 10 minutes before subarachnoid block. Subarachnoid block was given in sitting position with 25 gauge quincus spinal needle at L3 L4 space. Heart rate, systolic BP, diastolic BP, mean arterial pressure were recorded every 2 minutes for first 10 minutes and then every 5 minutes for next 10 minutes and every 10 minutes till the end of surgery. Data entered in MS Excel sheet and tabulated with descriptive statistics. Statistical software used, namely SPSS. P-value less than 0.05 was considered statistically significant. The incidence of hypotension in Group S was 69%, whereas it was 37% in Group G. Hence, patient of Group S required significantly lesser amount of ephedrine. Trends of systolic BP showed that there was significant difference between the two groups, but p-values were significant in Group G, and there was non-significant difference between Group G and Group S in case of diastolic BP. And trends of mean arterial pressure showed that there was significant difference between Group G and Group S, but Group G at all points in comparison to Group S maintained MAP significantly. Ahmed Eldaba, Mehegat et al., Abhishek Chatterjee conducted a similar study and concluded that IV granisetron 1 mg if administered before spinal anesthesia can effectively attenuate hypotension in parturients without any adverse effect. But Suraj Laminache conducted a similar study and concluded that it does not reduce spinal-induced hypotension in parturients undergoing elective cesarean section. However, there is a reduction in need of rescue vasopressor. In present study, we used the dose of intravenous ephedrine used was significantly low in group G compared to group S. The Laminacha and Eldaba had used similar dose of granisetron and found reduced requirement of rescue vasopressor in granisetron group, whereas Mohammed et al. Used a higher dose of granisetron and found non-significant difference between the two study group. Baseline systolic BP and diastolic BP mean arterial pressure, there was significant difference, but it was well maintained in granisetron group. So intravenous granisetron 1 mg if administered 10 minutes before subarachnoid block, besides being an effective antiemetic, can also be used to effectively attenuate hypotension in parturients without any adverse event. These are my references. Thank you.
Yes, doctor, what is the pathophysiology of hypotension in subarachnoid block for a parturient? And where do the granisetron act in that in that context?
Dr. Anurita, are you there?
I think she's not there.
She is in the meeting, but there might be some issues with their side.
Okay.
She's saying that I am not able to unmute. You can also reply on the chat box. Dr. Anurita, you can also reply on the chat box if you are having any issues.
Are we audible to Anurita?
Ma'am, you are audible to us also. So maybe, yeah, she is saying yes. Ma'am, you can ask the question again and she will reply in the chat box.
Yeah, Dr. Anurita, what is the pathophysiology of hypotension in parturient patient, and exactly where the granisetron will act to prevent or reduce the incidence?
Ma'am, she replied in the chat box. Please read that.
Over to Dr. Rekha.
Thank you, ma'am. Dr. Arunita, what was the sensory level obtained in each patient? Okay. And what was the drug used for that? For giving subarachnoid block? Okay, thank you, Dr. Arunita.
Ma'am, should we go for the next?
Yes, please.
Our next participant is Dr. Rupesh. I would like to request the team to deliver this video.
My paper title is Comparison of Propofol versus Fentanyl Infusion for Post-Operative Sedation in Mechanically Ventilated Patients Following Head and Neck Oncosurgeries, a retrospective analytic study. Sedation increases tolerance of mechanical ventilation, prevents accidental removal of instrumentation, and reduces metabolic demands. There are limited studies in oncosurgeries. The aim was to determine the efficacy of propofol versus fentanyl infusion for sedation in mechanically ventilated patients following head and neck oncosurgeries. The primary objective was to compare both the drugs with proportion of time at target sedation level, which was measured by the RAS score. Secondary objective was to study adverse events with each drug. The study was done in patients who had undergone head and neck oncosurgeries and required post-operative ventilation at the ICU in Malabar Cancer Center. This was a retrospective analytic study. It was approved by the Institutional Review Board. The patients' data were retrieved from 1st August 2020 to 31st August 2021. Inclusion criteria included age group of 18 to 65 years, requiring overnight mechanical ventilation via nasal or oral intubation, clinical need for light to moderate sedation, and the target score was from 0 to -3. Exclusion criteria, those with a MAP less than 55 mm of mercury despite appropriate intravenous volume replacement and vasopressors on admission, heart rate less than 50 per minute on admission, and tracheostomized patients and patients who had underwent laryngectomy. Patients with high-risk cardiac disorders, patients with liver and renal function impairment, and patients in whom both the drugs were used. The drugs and volatile agents used included fentanyl at a dose of 2 microgram per kg, propofol 2 mg per kg, and meconium was used as a muscle relaxant, 0.1 mg per kg. Isoflurane was used as an inhalational agent intraoperatively. Post-operatively, fentanyl at a dose of 1 to 2 microgram per kilogram per hour, or propofol at 25 to 75 microgram per kilogram per minute was used for sedation using infusion pumps. The RAS score, heart rate, mean arterial pressure at 2nd, 4th, 6th, and 8th hour were assessed. Statistical analysis was done using students' t-test and chi-square test. The RAS score, this target score was from 0 to -3. Coming to the results, demographic data were comparable, that is gender, weight, and age. It was not statistically significant. Fentanyl included 130 patients and propofol 118 patients. Both groups were able to achieve a target RAS between 0 to -3, and the sedation induced by propofol was significantly higher than that induced by fentanyl at 2 hours and 6 hours. There was no significant difference in the map of both groups. Heart rate at every time point was significantly higher in participants administered fentanyl at 2 hours, 4 hours, 6 hours, and 8 hours respectively. However, in both the groups, the parameters were within normal limits. Adverse events, hypotension was seen in 2 patients in the fentanyl group and 2 in the propofol group. Bradycardia 3 in the propofol group and 2 in the fentanyl group, but this was not statistically significant. The limitation was this was a retrospective study. So concluding, both fentanyl and propofol are equally efficacious in post-operative sedation without major hemodynamic fluctuations. These are my references. Thank you.
Since it was a retrospective study, I think the hemodynamic parameters is difficult to assess because the amount of fluid to be given to every patient must not have been standardized. So there can be other confounding factors also for the hemodynamic.
Yes, ma'am. Yes, ma'am. The limitation is it is a retrospective study.
Yeah. Any kind of complications you have faced that you had to stop the infusion because of any other side effect like severe hypotension?
Hypotension and bradycardia was there in few patients, ma'am.
Yeah. So you had mentioned only 2 or 3 patients.
Yes, ma'am. Accordingly, if it was severe hypotension, the infusion was titrated, means decreased, ma'am. The rate was decreased.
So the extubation time, what was the extubation time in both the groups?
Ma'am, extubation time I have not seen, ma'am. That was not calculated. Here, what we used to do was by 9 o'clock in the morning, the sedation will be usually stopped by 5 in the morning, and we'll extubate during the rounds, ma'am, during 9 a.m. in the morning.
Okay, so you have not calculated the time from stopping of the infusion till the patient was extubated.
So that I have not calculated in the data I have, but I have not taken that extubation time. I have not measured.
Okay. Was there any incidence of postoperative cognitive dysfunction in any of the patients, either in fentanyl or in propofol group?
Such events were not. Once they were ready for extubation, means once they were only fully oriented, we used to extubate.
No, that is okay. Extubation criteria is okay. But after 48 hours of that event, was there any abnormal behavior or cognitive dysfunction type of picture in any of the patients using fentanyl drip specifically?
That I have not specifically seen, ma'am. Like after 24 to 48 hours, I have not specifically seen. We have not noted that yet.
Yeah. That can be a next study for you.
Yes, ma'am. Within 48. Yes, ma'am.
Yeah. Over to Dr. Rekha, please.
Yes, thank you, ma'am. Dr. Rupesh?
Yes, ma'am.
What are the types of surgery that you included in your study?
These are only head and neck onco surgeries, ma'am. So I had excluded.
Onco surgeries means only commando or hemiglossectomy
all all surgeries which required post-operative ventilation, bulky flaps. It included tongue, then maxilla surgeries, then neck surgeries, neck dissections, then free flap.
Okay. So how many patients were intubated nasally and how many were intubated orally?
First anniversary. We have missed being together in many of our firsts in this 1 year. Sometimes it's hard to really understand why we are going.
Hello.
Yes, Dr. Rupesh. How many patients were intubated? Hello?
Hello. How many patients were? Yes, ma'am.
Intubated oral route, and by how many patients were intubated by nasal route?
Ma'am, all these patients are, other than thyroid surgeries, all other patients were by nasal intubation, ma'am.
Okay, so most of the patients were intubated nasally. Okay.
Yes, yes, yes.
So you keep patients intubated in thyroid surgeries in all thyroid surgery patients?
No, thyroid, all patients were not ventilated overnight, only those large thyroids and which took duration of time and which they suspected had some nerve involvement. Those patients were ventilated overnight.
Okay, so those patients were intubated by oral for thyroid surgeries or only neck surgeries, right? Otherwise, for bulky flaps, free flaps, commando, tongue surgeries, and maxilla, they were intubated nasally. Okay, right. So, hemodynamic response in post-operative period, that also depends on your route of intubation also. Because nasally intubated patients tolerate tube very well as compared to orally intubated patients. Right? And what was your duration of your study period?
This was 1 year, ma'am, from August 2020 to August 2021.
Okay, that was your study period. And what was your observation period? For how long period did you observe all patients?
Observe means all these patients they had taken the.
Your voice is not clear, Dr. Rupesh.
I had taken the data from the registers kept in the ICU, ma'am.
What I mean to say is you have observed the patients and recorded the data till patients were extubated, or you have taken data from registers only because it is a retrospective study.
Yes, yes, ma'am.
So until patients were extubated, you collected data?
Yes, ma'am, but I have not calculated the extubation time of all patients. Other than that, only till the sedation, at 8 hours of sedation, what is the RAS score, only till that I have currently calculated.
Okay, thank you, Dr. Rupesh.
Our next participant is Dr. Amit Anand. I would request team that play his video.
Good morning, everyone. My name is Dr. Amit Anand, and I'll be presenting my paper on prevalence and type of chest infections in patients on mechanical ventilation with suspected pneumonitis diagnosed using bronchoalveolar lavage. As we know, majority of the patients in ICU are in a critical state, have compromised respiratory systems, and are at a very high chance of respiratory infections. They VAP, which occurs in about 9 to 27% of the patients, contributes to a mortality and morbidity of about 50 to 70%. And thus we need to diagnose it at the earliest and initiated targeted therapy. Bronchoalveolar lavage is a procedure in which we collect the washings of the lower respiratory tract, which are subject to various studies. Thus, the objective of our studies was to estimate the prevalence and type of chest infections, the type of organisms in establishing the role of BAL in diagnosis and treatment of the patients, and to study the outcome and recovery. This was a prospective observational study which was conducted in the ICU of SN Medical College, Agra, over a period of 18 months on a total of 38 patients. The inclusion criteria of the study was patients between 15 to 65 years of age, the patients who were admitted to the ICU with suspected chest infections, who were on mechanical ventilation, and they had no anomaly or obstruction of the bronchial tree. Whereas patients who had head injury, cervical injury, who were already on broad spectrum antibiotics, who were not on mechanical ventilation or immunodeficient, were not included in the study. All the procedure was carried out in the guidelines of the American Thoracic Society. The suspicion of pneumonia was based on a radiological criteria which has new or progressive radiological pulmonary infiltrates, or clinical criteria, that is temperature more than 38, leukocytosis, or purulent respiratory secretions. The baseline clinical parameters were recorded, continuous monitoring was done, chest radiographs were done to identify or localize the site of BAL. The patient was positioned supine, FiO2 was increased to 100%. Slightly before, during, and after the procedure, PEEP was taken off, appropriate sedation or muscle paralysis as needed was done. There was minimal use of local anesthetics. The bronchoscope was lubricated for easy maneuverability. In diffuse diseases, right middle lobe or lingula was used. 20 to 50 ml of saline was instilled with a syringe and then re-aspirated to collect a total of about 100 to 120 ml of saline for the studies, and it was immediately sent to the laboratory for immediate studies. Discussing the results, the primary outcome were culture positivity, identification of the organisms, antibiotic sensitivity, and the secondary outcome was outcome and recovery of the patients in overall. Total 38 patients were included, 21 males and 17 females, mean age of 40.5 years. The culture positivity, the positivity rate of our samples was 78.94%, using a cutoff range of more than 10 to the power 4 colony forming units per ml, and 13.1% cases were inconclusive and 7.89% were negative. The main organism that we identified in our study was E. coli, which was 46.6%, followed by 20% each of Klebsiella pneumoniae, Acinetobacter baumannii, and then Pseudomonas aeruginosa and Staphylococcus aureus. On performing the antibiotic sensitivity, we found out that all the organisms were completely resistant for all the fluoroquinolones, and they were all sensitive to meropenem. The most resistant organism was Staph aureus, which was sensitive only to meropenem, and the most sensitive were Acinetobacter and Pseudomonas, which were sensitive to all the antibiotics. 28.9% patients reached full recovery and 39.4% reached partial recovery. Our studies were in accordance with the previous studies and yielded similar results. The study had some limitations as it was only based in ICU, and further studies may be needed. And thus we conclude that BAL is very informative and should be highly used. Thank you.
Very good study, Dr. Amit.
Thank you, ma'am.
Do your patients were post-operative patients?
No, ma'am. There was no specific criteria as to including only the post-operative patients. Mostly the patients that we included were came to us with the complaint of respiratory infections only.
Yeah. So there were mostly medical patients.
Yes, ma'am. Mostly medical patients.
Okay. What is the antibiotic policy of your ICU? So that what basic antibiotics are started?
Ma'am, basic antibiotics that we all usually start with piperacillin tazobactam as by various studies that were conducted in our ICU for the resident flora. The sensitivity started at piperacillin tazobactam, and the earlier antibiotics were resistant.
So initially you start with only one antibiotic for all the
Yes,
patients.
ma'am. Yes,
Yeah.
ma'am. Initially
And,
we start, yes.
And at the change in the TLC count and other parameters, you go for BAL.
Yes, ma'am. Ma'am, BAL, like if we used to prefer it when we suspected further respiratory infections or we suspected VAP after a period of, like, according to the definition of VAP, when we found out that either there were new or progressive infiltrates or the clinical criteria was met, then we progressed with BAL to identify the organs.
Any specific advantage of doing BAL? Have you done a pilot study taking the secretions just from the suction of an
Ma'am,
endotracheal tube or tracheostomy tube like that?
yes, ma'am. Mostly in the cases when we didn't do BAL previously, then we used to take the endotracheal aspirate from the tube or the tracheostomy tube, and we used to send it for culture and sensitivity to guide our therapy. And then we instituted BAL in our institute.
So after the comparison, that the BAL was more effective.
Yes, ma'am. According to the traditional methods, the sensitivity came to around 50 to 60%, and there were very high chances of contamination compared to BAL, where the sensitivity reached more than 70%, and the chances of contamination from the upper airway secretions were very less, and it was more representative of the actual infection.
Okay, thank you. Over to Dr. Rekha.
Yes, thank you, Vaishali, ma'am. This was a very nice presentation.
Thank you, ma'am.
You included 38 patients.
Yes, ma'am.
And you didn't compare it, no?
No, ma'am. Initially, we thought of comparing, but the amount of patients and the distribution of our ICU was such that we included only a certain group of patients, and we had to restrict it.
Okay. In pilot study, how many patients were included for pilot study?
Ma'am, as such, a pilot study specifically was not done for this study. But initially, the experience of my guide regarding the BAL, which he used to conduct in our ICU, he guided me so that we can progress with the study.
Okay. Thank you, Dr. Amit.
Thank you so much.
I must congratulate that the anesthesiologists are taking lead to doing a BAL.
Thank you, ma'am.
Yes, sir.
Yes, ma'am. It was a great experience because usually anesthesiologists are not included in these kind of procedures, and it was a very great learning experience for me.
Yeah.
Thank you so much, ma'am.
My topic is prevalence of preoperative anxiety and depression in major oncosurgeries. This was a cross-sectional study done at Malabar Cancer Center. So preoperative anxiety was recognized as a potential and preventable risk factor for post-operative complications. And it can lead to various problems such as difficult venous access due to peripheral vasoconstriction, autonomic fluctuations, delayed jaw relaxation, and coughing during anesthesia. Incidence of preoperative anxiety among Indian population is not known. An assessment of anxiety is important as the level of anxiety and patient's fear can complicate management of anesthesia and post-operative period. And if high anxiety and depression level is detected early, patient can be referred to a psychologist for pre-operative preparation. Aim of this study was to know the prevalence of pre-operative anxiety and depression in major oncosurgeries. Primary objective was to estimate the prevalence of pre-operative anxiety and depression among patients who are undergoing major oncosurgeries. Secondary objective was to know the cause of anxiety and to determine patient-related factors associated with anxiety. This study was done in Department of Onco-Anesthesiology at Malabar Cancer Center, and it was a cross-sectional study. Institutional Ethical Committee clearance was taken before starting the study, and it was also registered in the clinical trials registry. Written informed consent was taken from all the patients. This study was done in 100 patients posted for various oncosurgeries in Malabar Cancer Center. A questionnaire in Malayalam language was used as the screening tool to assess the anxiety level. Sample size was calculated using this formula. Statistical analysis, descriptive statistics were expressed as number or mean plus minus standard deviation, and p-value less than 0.05 was considered as significant. All patients who consented to participate were given the questionnaire on the day prior to surgery, and this questionnaire consisted of two parts. Part 1 contained the demographic data of the patient, and Part 2 contained the PHQ score and the Amsterdam Preoperative Anxiety and Information Scale. So this is the PHQ score which was used for anxiety and depression, and this is the Amsterdam Preoperative Anxiety and Information Scale. Inclusion criteria for this study was age more than 18 years and less than or equal to 65 years. ASA grading 1 and 2 patients were included, and those who were undergoing curative surgery were included in this study. Exclusion criteria was patients having any psychiatric illness or who were unable to answer the questionnaire, those who did not give consent, and those undergoing surgery for recurrent cancer or second cancer. So coming to results, prevalence of anxiety was 6% in our study, and there was 37% of the patients required more need for information about the procedure. So this is the gender distribution of the patients. This is the education distribution of the patients in our study, and this is the ASA status of the patients. So coming to discussion, Kinder et al. Studied anxiety in 734 patients. They found that young patients, female patients, and patients with no previous anesthetic experience had higher anxiety scores, and patients worried most about the waiting period. And it also showed in their study that females are more anxious than males, and those who have never had surgery are more anxious than those who have had surgery. Limitation of the study was it was done on a limited population, and it did not compare the APIS and the PHQ score. So conclusion, we got less prevalence of anxiety, maybe due to better psycho-oncology counseling in a hospital, but patients required more need for information. These are my references. Thank you.
Dr. Sonali, is it possible to remove your mask? Thank you, ma'am. Thank you.
Dr. Sonali, you said it is a crossover study. Cross-sectional study.
Yes, ma'am.
Yeah. So, in what respect you said it was a cross-sectional study?
Ma'am, it was done in a prospective manner, means.
Yeah, prospective, it's okay, but by definition, what is the cross-sectional study?
Cross-sectional means it was done on a limited population on 100 patients. So it was done in a prospective manner, ma'am.
Okay. What were the drugs on which the patients were? What any anti-anxiety drugs were started for the patients? At what time you have done the anxiety scoring?
Pre-operatively, when patient will come for a pre-operative visit during PSC time, that time we used to first take consent from the patient, and then we will give this questionnaire that containing this PHQ score and the APIS score, and then we will ask them to fill the questionnaire. And if we had patients who had more anxiety score, those patients we refer to psycho-oncology, and they will only give the necessary treatment.
Okay. So duration of PSA and posting the patient for surgery after assessment or onco analysis, was there any specific period?
Yeah, ma'am. Only on the first visit when patient used to come for PSA. After that, again the surgeons will see, and then only if required we will send to psycho-oncology if patient score was high. And anyway, in our hospital previously also patients are already having psycho-oncology counseling. So if we found that patients have more anxiety score, then we would refer them to psycho-oncologist and they will give the necessary treatment.
From the questionnaire, could you find what are the factors which leads to preoperative anxiety in the patients?
Ma'am, that APAIA score was there, and that we can find out whether it is due to anesthesia or due to surgery related anxiety, or whether patients needed more information. So in our study, we found that there was less anxiety in patients, as only 6% patients had anxiety according to our study. Compared to previous literature, there was less anxiety. But we found that patients required more need for information, as it was 37% in our study. So if we better counsel the patients pre-operatively, then we can help to reduce the anxiety scores.
So what would be your take-home message from this study?
We did this study just to know because there are less studies on pre-operative anxiety. Especially in cancer patients, they are more depressed and anxious. So if we give them proper pre-operative counseling, and anesthetic means anesthesiologist has a role in giving pre-operative counseling. So if we better prepare the patients and tell them about their questions, means what are their queries, if we will solve them to psycho-oncologists, then we can reduce the post-operative complications and other complications which are related to anxiety.
Okay. Over to Dr. Rekha, please.
Thank you, ma'am. For oncosurgery patients, it is possible that patients might have received pre-operatively either radiotherapy or chemotherapy. So does it affect the anxiety level in pre-operative period when after receiving?
Yeah, ma'am, that also we have noted. If patients have received pre-operative chemo or radiation, that also we have noted.
Because then
so that also can
level
affect.
of anxiety, level of anxiety may be different. If patient is directly posted for surgery, he or she has not received chemo or radiotherapy. And patients who have received chemotherapy, radiotherapy, especially for head and neck surgeries, there may be more fibrosis, there may be nutritional deficiencies also. So all these factors can also affect anxiety level, right?
Yes, ma'am. And if patient has previous surgery also, then it can increase the anxiety. So we have excluded those patients who already had surgery for previous.
So patients who had past history of surgery and also received chemo and radiotherapy, you excluded those patients.
Yes, ma'am.
Okay. Thank you, Dr. Sonali.
Thank you.
Our next participant is Dr. Chandra Mohan. I would request team, please play his video.
Good afternoon, everyone. I am Dr. Chandramohan from the Department of Anesthesiology, Sri Devaraja Juras Medical College, Kolar. My topic is patient's perception about anesthesia and anesthetists, a questionnaire study. Introduction: anesthesiology as a specialty has evolved tremendously over the last few decades. Anesthesiologists play a very crucial role in perioperative care, intensive care, labor analysis, and pain clinic. The role of anesthesiology and anesthesiologists has traditionally been viewed as behind the screen specialty, and it is only in the last few decades the specialty has grown beyond the four walls of the OT, and role of anesthesiologists being increased, appreciated in pain clinic, labor analgesia, and in ICU. Anesthesiology is the art and science of relieving pain during surgery, and safety is the most important priority achieved through eternal vigilance. And we play a very important role during and after surgery by protecting the patients from any adverse events during surgery and provide optimum surgical conditions to the surgeon and keep the patient safe. However, despite clearly playing a very crucial role in the perioperative management of patients and in other areas such as pain clinic, labor analgesia, and critical care, it is still felt that anesthesiologist does not get the due he deserves. And the present study was conducted specifically to assess the level of awareness about the role of anesthesia and anesthetists among patients scheduled to undergo elective surgeries in a tertiary care hospital. Aim of the study: to study about the patient's awareness and knowledge about anesthesia and anesthetists. Materials and methods: the study was conducted on patients undergoing elective surgeries at our hospital from the period of July to September 2021. Study design is observation clinical study. Sample size is 95 and sampling method is randomized sampling. Inclusion criteria: adults in the age group of 18 to 65 years with ASA grade 1 and 2. undergoing elective surgeries. Exclusion criteria: patients not willing to take part in the surgery, age 65 years, and grade ASA grade 3 and 4. These are my results. Discussion: in our study, 37% of patients had previous exposure to surgery. Their awareness about anesthesia and different techniques of anesthesia were poor. This could be due to their lack of education, as 33% of participants were illiterate. However, this is in sharp contrast to very high level of awareness about anesthesia and the role of anesthetist among UK population. This reflects the probable higher literacy rate in Western countries. In our study, 60% of the patients were aware that anesthesiologist was a doctor, and 26% knew that anesthesiologist is a specialist. This is in agreement with previous studies, when most of the patients are not even aware that anesthesiologist is a doctor, and most people are not aware that anesthesiologists are specialists. It is disappointing to note that only 9.5% of the patients were aware about the role played by anesthetists outside the OT. Although fear of feeling pain during surgery was the biggest concern among 84% of patients, only 6% knew that it was anesthetist who will provide pain relief during surgery. Overall, it is disappointing that most of the patients in this study had poor knowledge about anesthesia, and the familiar face of anesthetist goes a long way in relieving the anxiety of the patients in an unfamiliar environment of the OT. Conclusion: the study identified deficiencies in patients' knowledge of anesthesia and anesthetists. Most of the patients in our study were not aware of the role of anesthesia, types, and techniques, despite the factors patients having previous surgery. The fraternity of anesthesiologists has a very important responsibility to educate patients and surgeons about the role of anesthesia, types, techniques, benefits, and the role played by anesthesiologists inside and outside OT. These are my references. Thank you.
I think Dr. Chandramohan, you have pointed a very important issue, and
Yes,
we all have to work for this awareness of the role of anesthesiologist. In spite we are doing many things, the society is not recognizing us. So from your study, what is the main issue which you have identified? Why that's means what is the role of anesthesiologist? Why patients are not knowing its importance? What was the main concern from your study?
Ma'am, the thing is, surgeons they will go for from posting the admitting the case till the post-operative care. They will be staying with the patients, ma'am. But the only thing is, we will go before only for pre-anesthetic evaluation. We will go on, ma'am. And after coming to OT, also they will be anesthetized, so they won't be knowing that we are the doctors who are giving anesthesia. And most of them uneducated people doesn't know that anesthesiologist is a doctor, and we have to tell them that we are doctors, ma'am.
Now you have to hold this torch, and I think you should go for more awareness since you have done the study.
Yes, ma'am.
Over to Dr. Rekha, please.
This is a very nice act of increasing the awareness about anesthesia, because you have rightly mentioned that people don't know whether we are doctors or not. So this is a very nice topic. And what is your strategy to increase the awareness about our for our branch?
Ma'am,
Can we improve it?
Yes, ma'am. We have to we have to make a good rapport with the patients and tell them that even surgeons are doing surgeries, that we are the ones who are saving your lives. That it's life and death matters.
Without us, surgeons can't do surgery.
Yes, ma'am.
And
Yeah,
you won't be pain free.
Okay. And post-operatively, we have to do rounds at least for 48 hours so that the patient can recognize us.
Thank you, Dr. Chandra.
Thank you.
Our next participant is Dr. Deepika. I would request team that please play her video.
Good morning. My topic is to compare the effectiveness of subcostal tab block versus port infiltration for postoperative analgesic management in laparoscopic cholecystectomy. Surgical pain is a universal phenomenon which usually affects the patients perioperatively. Apart from the agonizing sensory experience associated with it, acute pain has several deleterious effects on the physiology and also on the psyche of the sufferer. My objectives are to compare the duration of post-operative analgesia between the two groups and to compare the total dose of rescue analgesics used between the two groups and VAS score. The study was conducted in Department of Anesthesiology, WIMS and RC Bangalore. The study was conducted over a period of 18 months from Jan 2020 to June 2021. The patients were randomly allocated according to computer-generated random number table into two groups of 15 each. A prospective randomized intervention study, 30 patients randomly allocated to two groups of 15 each. Comparative study was done. Inclusion criteria were the patients belonging to ASA1, ASA2 of 18 to 60 years of age and undergoing elective laparoscopic cholecystectomy under GA. Exclusion criteria, those patients who are allergic to diclofenac, paracetamol, fentanyl, bupivacaine, conversion to open cholecystectomy, and patients having bronchial asthma. Methodology, it was a prospective randomized parallel group double-blind interventional study which was conducted in WIMS and RC Bangalore. Approval was obtained from Ethics Committee of WIMS and RC. Group A, where bilateral USG guided subcostal tap block was given on each side with 20 ml of 0.25% bupivacaine at the end of surgery. Group D, where port infiltration of 4 ml of 0.125% bupivacaine were given to all 5 ports. The statistical analysis was performed by STATA 11.2. Shapiro-Wilk test has been used to check normality. Student independent sample t-tests were used to find the significant difference between the heart rate, blood pressure, visual analog score, post-operative analgesia used between the treatment groups, and it was expressed as mean and standard deviation, and p-value being less than 0.05, which means the study performed is statistically significant. Here are the results. Group A, the mean and standard deviation of heart rate is lesser when compared to Group D. The mean and standard deviation of the systolic BP of Group A is lesser when compared to Group D. The mean and standard deviation of diastolic BP for Group A patients is lesser when compared to Group D. The VAS score, mean and standard deviation of Group A patients is lesser when compared to Group D. The first dose of analgesic needed, the mean and standard deviation for Group A patients is lesser when compared to Group D. The post-op analgesia, totally, the mean and standard deviation of Group A patients is lesser when compared to Group D. So from this study, we'll get to know that Group A patients have better post-op analgesic effect than Group D patients. Confounding variables were ASA1 and ASA2 category, age and gender of the patients. Limitations were these post-operative analgesic strategies cannot be used beyond 24 hours, but it has huge scope in future because it helps in quicker recovery, early ambulation and discharge of the patients. So hence, it proves that bilateral subcostal tap block provides a better post-operative analgesia than port infiltration at the end of surgery. And also the total dose of rescue analgesia used to those patients who had received tap block is very less when compared to those patients who belonged to Group D, that is who received port infiltration at the end of surgery. These are my references. Thank you.
Dr. Deepika, what
Yes,
are the
ma'am.
different locations where you can give tab block?
Ma'am, I gave tab block using USG guidance, ma'am, subcostally or normal tab block, ma'am, where we usually give, we see the USG guidance and then we give between, we see the external oblique, internal oblique and transverse abdominis, and we infiltrate the drug above transverse abdominis.
So which are the other locations? Here you have given in subcostal area. What are the other? Subcostal is not a usual location, I would say.
Yes,
so where are the other
ma'am.
locations in which the tab block is given?
Ma'am, usually from the umbilicus, just lateral to the umbilicus, also we can give blind technique can be given in right lumbar region or any right or left parambilical region also we can give them based on the type of surgery done.
So any advantage of giving subcostal block for cholecystectomy? If I would say if you are giving in a mid-axillary line, and giving in a subcostal area for laparoscopic surgery. Is it any difference, madam?
Ma'am, more than giving in, ma'am, because lap cholecystectomy, there will be pull of peritoneum and bowels and all. So, and certain time the port will also be inserted near the epigastrium. So subcostal tap was better post-op analgesia when compared to the normal tap block, which usually we give along mid-axillary line below the lower border of the ribs.
Have you done any cases in the mid-axillary line using for laparoscopic surgery? Then only you can say that subcostal route is.
Yes, ma'am, I have done, but compared to normal tab block, the subcostal tab block was found to be effective in lap cholecystectomy patients.
Was the volume of drug used in block in a tab block and port infiltration similar or different?
No, ma'am, it was different. For block, I used 20 ml of 0.25% bupivacaine on each side. For port infiltration, 5 ports were there. It was 4 ml of 0.125% bupivacaine for all the 5 ports.
So it was 20 ml in port infiltration and almost 50 ml in tab block.
Yes, ma'am.
Yeah. Will it? Is it comparable? Can it have overhand for a tab block group?
Ma'am?
The amount of local anesthetic used was almost double in tab block group. So will it make any difference?
Yes, ma'am. Intra-op also with the vitals and also the post-op vitals and analgesia, the duration. There was a lot of variation between the two groups. Those who received the tab block, they had a duration of analgesia for almost 8 to 10 hours. And
naturally,
immediate post-op also
the volume of drug. Naturally, the volume of drug use was more in that group. Huh? Okay, over to Dr. Rekha, please.
Thank you, ma'am. Dr. Deepika.
Yes, ma'am.
What are the causes of post-operative pain after laparoscopic cholecystectomy?
It will be usually because of the pull of the peritoneum, ma'am. And also because of the stretch of the muscle and the pain fibers which are involved in those regions because of them.
Can these patients have shoulder pain post-operative period?
Yes, ma'am, they can have. Yes, ma'am, because the diaphragm also is involved. So the diaphragm innervation, there will be referred pain to shoulder also.
Okay, so can tap block provide visceral analgesia? Because laparoscopic surgeries, somatic pain is less because there are very small incisions. So visceral pain, somatic pain will be less. So do you think that tap block provides effective analgesia and even local infiltration also? So do we need to
no,
use?
ma'am, tap block didn't provide visceral analgesia. Only somatic analgesia was supplemented.
So what was the other analgesic used in post-operative period to counteract shoulder pain?
Ma'am, in post-op period, I used rescue analgesics like tramadol, ma'am, 50 mg.
Okay, so tap block patients need less amount of tramadol. Did you conclude that, no?
Yes, ma'am. Yes, ma'am. Tap block patients required lesser amount of rescue analgesia in post-op period.
Because in both the groups, they provide only somatic analgesia, right? So do you know any other
only somatic analgesia.
Okay. Do you know any other technique that provides visceral analgesia also after laparoscopic surgery? Apart from tap block and local infiltration. Can we use other techniques?
Visceral analgesia.
Can we use local instillation, intraperitoneal instillation of local anesthetic, intraperitoneal nebulization using local anesthetic?
Yes, ma'am.
Can we use that?
Yes, ma'am. I have seen nebulization intraperitoneally in lab coli patients only, and they are also found to be effective.
Yeah, it's
But
very
compared to
effective.
that, yes.
Okay, thank you, Dr. Ripi.
Thank you.
Our next participant is Dr. Praveen Kumar.
Good afternoon. My paper is on comparison effect of dexmedetomidine added to local anesthesia modified PEX block for post-op pain in MRM procedure. Coming to the introduction, breast surgeries is one of the commonest performed surgeries in hospitals, and relatively minor breast surgeries can be associated with significant post-op pain. Nearly 60% of the breast surgery patients experience severe acute post-op pain. Therefore, ultrasound guided PEX block is being given in order to reduce the pain for the patient. In these two blocks, PEX1 and PEX2 block, the PEX1 will be aiming to block the pectoral nerve, intercostobrachial, intercostal, and the long thoracic nerve. Whereas PEX2 block will aim to block the serratus muscle area together with the lateral branches of intercostal nerve that exists at the level of mid-axillary line to innervate the mammary gland and skim from T2 to T6. PEX1 will be given between pectoralis major and pectoralis minor muscle, and PEX2 will be given between pectoralis minor and serratus anterior muscle. So poorly controlled post-op pain has negative physiological and psychological consequences. Furthermore, effective acute pain control preserves the immune function both by suppressing the surgical stress response and decreasing the need for general anesthetics and opioids. So therefore, dexmed, which is a selective alpha-2 agonist, which is 8 times more affinity for alpha-2 adenosine receptor compared to clonidine and possesses all the properties of alpha-2 agonist without respiratory depression. Because of its effects such as sedative, analgesic, and anesthetic sparing properties, it is one of the drug which has been selected. And ketamine is a non-competitive antagonist of N-methyl D aspartate. Because of its central, regional, and local anesthetic and analgesic properties has been reported for ketamine. This is the second drug which has been used. This study aims to compare the analgesic effect and safety of ultrasound-guided PEX block with bupivacaine plus dexmed and bupivacaine plus ketamine in patients undergoing breast cancer surgeries, that is MRM, or post-op pain and stress response. Coming to the method, this randomized double-blind study was started after taking a local ethical committee clearance. 60 patients, ASA 1 and 2, between 50 to 90 kgs. Exclusion criteria is patients with history of bleeding diathesis and patients with prior surgery with supraclavicular or infraclavicular or axial region. Preoperative patients are taught how to evaluate their own pain intensities with the visual analog scale, as well as anesthesia was induced for patients with 2 microgram per kg fentanyl, 2 to 3 milligram per kg propofol, and 1.5 milligram per kg lidocaine. Endotracheal intubation was facilitated with 0.5 mg per kg of atracurium. Later, Group D and Group K. Group D, which 30 ml of 0.25% bupivacaine with 1 microgram per kg of dexmed group is injected between PEX1 and PEX2. PEX1 will be receiving 10 ml and PEX2 will be receiving 20 ml. And in ketamine Group K, same 30 ml of 0.25% bupivacaine with 1 mg per kg of ketamine, 10 ml in PEX1 and 20 ml in PEX2. So following this, at the end of surgery, we'll be giving a reversal and patient will be extubated. So post-op analgesia comprised of patient-controlled analgesia with an initial fentanyl bolus of 1 microgram per kg once pain was expressed by the patient, or if the VAS score was found to be more than 3, followed by 40 microgram bolus with a lockout period of 15 minutes with no background infusion allowed. So all the patients were followed up and baseline and was assessed at baseline 1 hour, 2 hours, 4 hours, 6 hours, 24, 48, and 24 and 48 hours. And they were assessed for opioid consumption, vital signs, and the first rescue of analgesia and vasculature. So statistical significance, our primary endpoint was total dose of intravenous PCM morphine consumption in the first 48 hours post-operatively. The second endpoint was the post-op VASCO, first request of analgesia, level of stress hormone, and safety profile of the study drug. So results, 60 patients were enrolled, consented, and successfully completed the study. Regarding hemodynamic variable measured during the intraoperative period, there was no significant differences. The mean post-op VAS score value showed no significant difference between the two groups. 8 of 30 patients in ketamine group required morphine based on the protocol of the study in comparison, and 5 of the 30 patients in dexmed group require morphine administration to keep VAS score of less than 3. As regard to the analysis of the first request, it was prolonged in the dexmed group in comparison to ketamine group respectively and was found to be statistically significant. And there was a statistical significant difference in the total amount of intravenous PCM morphine consumption in the GD group in comparison to the GK group. Compared to sedation, it was found to be more in GD group at 1 and 24 hours, but the level of serum cortisols and prolactin level when calculated. So discussion, modified PEX block is a novel approach that aims to block the axilla and intercostal nerve, which is necessary for the wide excision and several types of mastectomy. PEX block a peripheral approach based on good anatomical knowledge and on use of ultrasound. It blocks both motor and sensory nerve, where compared with only sensory nerve block in infiltration and no sympathetic blockade as in paravertebral blocks and epidural blockades. So in a study, we found that in patients GD group experienced prolongation of time to first request of analgesia, decrease in total morphine consumption with more attenuation of stress hormone level compared with GB group in the first 48 hours post-operative without serious side effect. So this similar findings were studied in many of the studies as well. Coming to the limitation, the study was limited by small sample size and relatively short follow-up period. Also, the lack of assessment of serum levels of dexmet to explore its analgesic effects with locally only or due to its systemic absorption. Studies with follow-up period of more than 48 hours to explore its effects on chronic post-op pain are needed. Conclusion, the addition of dexmet to modified PEX block prolongs the time of first request of analgesia and reduce total opioid consumption without serious side effects in patients undergoing modified radical mastectomy. These are my references. Thank you.
As you have used, hello.
Hello. Yes, ma'am.
Yes, Dr. Praveen. As you have used ketamine.
Yes, ma'am.
Yeah. What was the ASA classification of patient used?
ASA 1 and 2.
Yeah. So were the patients hypertensive? Any of the patients hypertensive or any other comorbidity like ISD or?
Yes, ma'am. Out of 30 patients selected in ketamine group, around 3 patients were hypertensive but controlled hypertensive. Were on only one antihypertensive. So I had taken those. I mean, I had included even those cases also.
So what was the response after giving block? You had given after general anesthesia, and before start of surgery, was the assessment of block done and how it was done?
Before the assessment of surgery, it is not done because my block has been given free of after induction. That is after intubating the patient. I had selected the block to be given, PEX1 and PEX2. Since because of the various aspects like fentanyl, which we give for the pre-medication, even that might add as an adjuvant to the patient. That is why I had to follow up because the fentanyl's effect might be there for 4 to 6 hours from the starting of the procedure. But since I had calculated for all 28 to 48 hours, I could make out the difference of VAS score because was the patient able to tell was more VAS score after 6 hours of proceeding surgery. Then I would have thought that it was because of fentanyl patient was having less VAS score, and after 6 hours the pain has been increased. So I usually followed up for 48 hours exclusively. I got to know that there was no much of variation in VAS score. That pain intensity was found to be safe till almost up to 48 hours. Only around 6 to 7 patients told that they had a little increase of pain in for 24 hours. So that time I had to use rescue analgesia as fentanyl.
Was there any hypertensive response noted in patients where ketamine was added?
Since it was infiltration, since it was infiltration technique, there was no much variation noted. Only around less than 20% of baseline value was only being fluctuated. It was not beyond 20% of baseline value.
Okay. Post-operatively, was there any complications related to ketamine, like hallucinations or clouding of consciousness still there, like that?
No, ma'am. Hallucination, those complaints were not there, but out 3 patients had complained of nausea and vomiting, for which I had to give anti-emetics, after which it has been reduced.
Any other parameters noted related to MRM, like shoulder pain assessment or shoulder movement score?
Yes, ma'am. I had to. We had done that, but because I had given both PEX1 and PEX2, and it had covered up to T2 to T6 level, Shoulder pain, I actually asked, but they have not got any complaints regarding the shoulder pain also. Because it was a larger volume of infiltration, I got to know that it has been reduced also. Even though it has extended up to axial also, surgery, but it didn't have any sort of pain.
Over to Dr. Rekha. Yes. Thank you, Vaishali ma'am. Dr. Praveen, you gave PAC 1 and PAC 2 block after induction but before surgery, right?
Yes,
I saw yesterday. Surgeons felt any interference because of the local anesthetic injected during PAC block while doing cauterization.
No, ma'am. Actually, I've asked. I mean, I requested surgeons to wait 10 minutes after the completion of drug, ma'am. And during the process of surgery, also, I got a surgeon's feedback. Also, they told that there was a good relaxation, especially after giving the PEX tube.
No, Dr. Praveen, I'm not asking about relaxation. Does cauterize any interference if we provide block before surgery?
Ma'am, actually, literature-wise, it is there, ma'am. But during my study, I didn't find any differences.
Surgeons were comfortable.
Yes,
surgeons were comfortable. Okay. Second thing. Is there any other alternative block that can be used for MRM surgeries for postoperative analgesia?
Yes, serratus anterior plane block can be used.
Yes, very good. Then
then ESP, erectus spinae block.
Okay, which should be the level for erectus spinae plane block?
Ma'am, level T3 to T4, between T3 and T4 level.
At what vertebral what vertebral level will you provide the USG guided ESP block for MRM surgeries?
MRM surgeries and between T3 and T4 transit process level.
What are the complications that you can face after giving ESP block at thoracic level?
You might experience pneumothorax. The puncture of the needle to the pleura, there might be a chances nitrogenic induced pleural damage or like pneumothorax. Chances are there.
Okay, thank you, Dr. Prasad.
Thank you.
My pleasure.
Our next participant is Dr. Arjun B.T.
Good day. My e-paper presentation, effect of preoperative CPAP in patients with OSA in reducing perioperative hypoxic events, a prospective study. My PG guide is Dr. Srinivas, HD. OSA is caused by repetitive partial or complete obstruction of upper airway during sleep and is characterized by episodes of cessation of breathing lasting for more than 10 seconds. It is of particular concern to anesthesiologists because of its increased perioperative morbidity and mortality. Concern in patients with OSA include potent airway obstruction, difficult tracheal intubation, and postoperative respiratory depression and airway obstruction. Many number of patients with OSA doesn't know about the diagnosis, but they can be diagnosed preoperatively by simple screening questionnaires using Berlin questionnaire or stop bank questionnaire. Stop bank questionnaire includes snoring, tiredness, observed sleep apnea, high blood pressure, BMI more than 35, age more than 50, neck circumference more than 40 centimeter, and male gender. CPAP has been known to be beneficial in OSA patients by it maintains the PEEP and decreases the atelectasis, increases the surface area of the alveoli, and hence improves the oxygenation. Aim of my study was to evaluate the efficacy of CPAP administered in the immediate preoperative period in reducing the hypoxic events perioperatively in OSA patients. primary objective was to assess the incidence of hypoxia in CPAP and non-CPAP group and to assess the hemodynamic variations. Study design was prospective single-blinded randomized control study done in JSS Hospital. Clinical trial registry was done. Sample size estimation was done with 30 patients in each group. Score of 3 or more in stop bank questionnaire were included with ASA 1 or 2. ASA 3 and above were excluded, and those patients with OSA and receiving CPAP priorly were excluded. The patients who were chosen for CPAP or given CPAP for 30 minutes had 10 centimeters of water for 30 minutes prior to induction, and both the groups were monitored for SpO2 and vitals perioperatively for up to 24 hours. Results and statistics were done using the SPSS version 22. Demographically, there were no major differences between the two groups regarding the age, gender, ASA status, and stop bank scores and duration of surgery. SpO2 was compared between the two groups, and they were proven significant differences between the two groups while intubating, while before pre-oxygenation, and also after extubation. After extubation, non-CPAP group developed, 5 patients from the non-CPAP group developed hypoxia, while none of the CPAP group developed hypoxia. This was statistically significant. There were no significant hemodynamic differences between the two groups during the study. CPAP has been proven beneficial when used routinely by OSA patients, but when used preoperatively, it can help in reducing the incidence of hypoxic events. Study was done on a small group. Post-operative, there was no CPAP administration during the study. Further studies are needed to consider incorporating preoperative CPAP among OSA patients as a routine plan, as this study showed that preoperative administration of CPAP can help in preventing perioperative hypoxic events. These are my references. Thank you.
Hello, Dr. Arjun.
Good morning, ma'am. Yes.
Good morning. All your patients were already diagnosed with OSA.
The diagnosis basis was only on stop bank, ma'am, not on polysomnography. Okay. Only stop bank questionnaire were used, and anyone with scores 3 or more were utilized.
So in CPAP group, you had given CPAP with a pressure of 10 centimeters of water for 30 minutes.
Yes, ma'am.
Pre-operative.
Yes,
yeah.
ma'am.
So was 10 centimeter pressure directly started, or it was escalated from 3, 5 or like that?
No, ma'am. We started with the 10 centimeters of pressure because we did not want again that to be a confounding factor later. So everyone were given directly. We had explained the patients well about the CPAP, how positive pressure will be coming, and most of them were compliant for 30 minutes.
Okay. So the compliance was well accepted in all the patients?
Yes, ma'am. Yes, ma'am.
Yeah. In non-CPAP group, what was the thing which you had done?
Actually, in non-CPAP group, we had only taken consent that they were about to be considered in a research, but we did not give any CPAP preoperatively. No sham procedures were used.
I think you should have given either some kind of mask, nasal prongs oxygenation, or some kind of oxygen therapy, because you have diagnosed them as OSA. You have diagnosed them as stop bank score more than 3. Yes, so depriving those patients from any kind of therapy would be, I think it's illogical. Though you have to assess the effect of CPAP, but some kind of oxygen therapy should have been given.
We followed the usual hospital protocol, where we were not giving any preoperative oxygen even in OSA patients if saturations were more than 90.
So what was the safe intubation time in both the groups?
Both the groups, it was intubation time was less than 20 seconds, and it was the difference was not significant.
So you didn't found any difference between CPAP and non-CPAP with respect to the intubation time, that is fall in saturation during intubation time?
We did not find significant difference between the time of intubation, ma'am, but saturation was considerably lower in non-CPAP.
Okay, so that means the safe intubation time was more in non-CPAP. Means the incidence of hypoxia was more in non-CPAP.
Non-CPAP, yes, ma'am.
Yeah. What was the position of intubation? Was it similar in both the groups?
Yes, ma'am. There were no differences between the groups, ma'am.
It was conventional. Supine. It was conventional supine or ramp?
No ramped up position, ma'am. Conventional supine with regular laryngoscopy. There were patients who actually needed video laryngoscope for difficult intubation. They were excluded out of the research, ma'am. Both the sides.
Okay. Any post-operative complications in non-CPAP group?
Non-CPAP group, one patient we had to re-intubate because of desaturation, while we did not find any such re-intubations in CPAP group.
Okay. Over to Dr. Rekha, please.
Thank you, Dr. Arjun. Ma'am has asked almost all questions and we are running short of time. Thank you, Dr. Arjun.
Thank you. Thank you.
And Vaishali ma'am. Hello.
Yes, yes.
Vaishali ma'am, I'm leaving this meeting because I have a presentation at 11.
Okay, okay. No issue, madam. Yeah.
Okay, thank you, ma'am. Can you please carry on? Okay.
Yes,
Thanks
yes,
a lot, ma'am. Thank you. Thank you.
Thank you.
Our next participant is Dr. Chandu Korla.
Hello everyone, myself Dr. Chandu Korla. My study is to assess the post-operative analgesic efficacy of intravenous nefopam hydrochloride administered during post-operative period in geriatric patients undergoing lower limb orthopedic surgeries under spinal anesthesia. Post-operative pain is often considered as a significant problem in clinical practice. Elderly undergo surgery 4 times more often than other age groups. Yet for several reasons, pain after surgery in older adults often is not given adequate importance. Adjuvant treatment with agents such as nefopam hydrochloride has shown good post-operative analgesia and reduced opioid-related side effects. Hence, the present study was conducted with the hypothesis that administering nefopam in the post-operative period would improve analgesia and decrease the use of opioids. It's a DCGI-approved non-narcotic analgesic for acute and chronic pain. It's a centrally acting anti-nociceptive compound that inhibits the reuptake of serotonin, norepinephrine, and dopamine and has supraspinal and spinal sites of action. Plasma half-life is 3 to 5 hours. Daily dose for post-operative pain is 20 to 120 mg intravenously. It undergoes extensive metabolism in the liver and has no effect on platelet function and does not increase the risk of respiratory depression. Our aim is to assess the post-operative analgesic efficacy of nefopam in elderly population. Objectives is to evaluate the degree of pain relief and to determine the duration of analgesia. Secondary objectives include assessing the rescue analgesic requirement and studying the hemodynamic parameters and adverse effects of nefopam. This was the formula that we use for sample size estimation. Inclusion and exclusion criteria are as follows. This is basically an observational study conducted in JSS Medical College and Hospital. Using NRS scores, the efficacy of the drug was assessed post-operatively. After a thorough pre-anesthetic evaluation on the day of surgery, spinal anesthesia with 25-gauge quickie spinal needle using injection bupivacaine 2.5 ml was given in sitting posture after connecting the basal parameters. After patient was shifted to post-operative ward, if NRS score was more than or equal to 4, nefopam 20 mg in 100 ml saline was administered over 30 minutes, following which onset, peak, and duration were noted along with any adverse events. In spite of administering nefopam, if patients complained of pain, then tramadol 50 mg IV was given. That was considered as a rescue analgesic in our study. Statistical data was collected in Microsoft Excel format and analyzed using SPSS version 21. Duration of analgesia was found out to be 175.8 plus or minus 33.9 minutes. About 60% of participants required only 100 mg of tramadol over 24 hours of post-operative period. Time for onset is 9.33 plus or minus 2.83 minutes, and for peak it was 24.83 plus or minus 4.1 minutes. Transient tachycardia and hypertension was observed in almost all the patients. Nausea, headache, sweating, vomiting, drowsiness, nervousness, and confusion were other side effects. Good postoperative analgesia is mandatory for patient comfort and postoperative rehabilitation. Though most of the studies concluded that nefopam can be a part of multimodal analgesia and has opioid-sparing effect, there is limited knowledge about it in the elderly as they are challenging group to study. This logical choice of pain medication in this this population would be a drug which is non-opioid and non-steroidal to avoid respiratory depression and renal impairment. In a study done by G. Phillips and T.V. Dickers, nepopam 20 mg was found out to be approximately equivalent to morphine sulfate 7.5 mg. Lou Manier et al. Conducted a study to evaluate the analgesic effect in patients undergoing orthopedic surgeries and concluded that nepopam shows a significant analgesic effect. In a study conducted by DJ Redda of population pharmacokinetics in geriatric population, 3 times lower total clearance and 3 times higher plasma concentration of nepopam was observed. In a study done by Reberand et al. On patients undergoing total hip arthroplasty, nepopam did not provide additional analgesia when added to paracetamol, ketoprofen, and ketamine. Redundancy between nepopam and ketamine effects may explain this finding. The high frequency of tachycardia and hypertension is undesirable in patients with limited cardiac function. Life-threatening adverse effects have been reported with the use of nepopam overdose. Therefore, a fixed dose of 20 mg was used in our study. Adequate sample size was not achieved due to sudden outbreak of COVID-19 pandemic, and no adjuvants were used other than injection nepopam in the post-operative period. These were considered as our limitations. Therefore, IV injection nepopam had shown effective post-operative analgesia in the elderly, but it cannot be used as a sole analgesic because of its short duration of action, incidence of side effects, and need for subsequent analgesia. These are my references. Thank you.
Dr. Chandu.
Yes, ma'am. Good morning.
Yeah, good morning. Have you used any adjuvant for spinal anesthesia in this elderly patients? So, or it was
No,
a
ma'am,
sole
no.
bupivacaine?
Sole bupivacaine, ma'am.
And what was the duration of procedure? You had used only 2.5 ml, I suppose.
Yes, ma'am. Ma'am, it varied between 2 to 3 hours, ma'am, not more than that.
But I think for 2 to 3 hours, and that too for orthopedic procedure, 2.5 ml bupivacaine would have been insufficient.
Ma'am, as like we didn't face much problems, ma'am. Procedures got over actually in that like 2 hours, 2.5 hours. Short procedures only we took, ma'am.
Okay. And one more point I would like to raise that you had given nepopam at VAS score of more than 4, more than or equal to 4.
Equal to 4, yes, ma'am.
Yeah. So if we are trying to give comfort to the patient, why we are allowing the patient to have pain? More than 4 means patient was already having pain.
Yes, ma'am.
So I think this is a big ethical issue. Whenever we are considering a postoperative analgesia, patient should be totally pain-free. So we should not allow the pain to occur and then give an analgesic. That itself is one of the confounding factors of problems in postoperative period, specifically in elderly patients.
Yes,
so I think you should go for more number of cases and give either nepopam immediately in a postoperative period before initiating the pain itself.
Yes, ma'am. Yes, ma'am. Okay. Yeah.
And what about the complications? Nepopam has the propensity of having hypertension or tachycardia. Once it is already, the pain has already been initiated, means the tachycardia has already been there.
Ma'am, but not.
Yes.
Ma'am, hello.
Yes.
Yes, ma'am. Yes, ma'am.
Yeah.
Ma'am, but after starting infusion, what we observed till then, it was actually more, ma'am. Like for about 12 to 13 minutes, we have observed more, like increase of plus 15, plus 20 also. And BP also became, like it was increased, ma'am.
Yes, yes. So that is not an ideal thing. We should not let the patient have tachycardia or hypertension.
Yes, ma'am.
Was this drug compared to any other drug?
No, ma'am, it was not a comparative study. No.
Was ethical committee approval taken?
Yes, ma'am, it was taken. We went ahead after taking one.
Yeah, well, these two issues I would like to mainly, you should consider that a pain should not be there and then you are giving analgesic. or
Yes.
any other weak NSCIDs you can use as a primary thing for that patient.
Yes, ma'am. Ma'am, that is why actually we expected, like we anticipated that the drug will act better, but then in 2.5 hours they started complaining of pain, and the moment they started complaining of pain, we ended the study, ma'am. We have started giving injection tramadol, and just that's why called, like we made it an observational study saying that it is not ideal to use in elderly patients because no many studies were there on elderly. We didn't know how it will act, so that was just pilot studies also were done, ma'am, in the beginning. But yeah, that was the conclusion. It is not good to use in the.
Okay, thank you.
Yes, thank you, ma'am.
We can go for next participant, please.
Good morning, respected teachers. I'm Dr. Vidya Patel, and my topic for e-paper presentation is comparative efficacy of two different doses of fentanyl on hemodynamic response to laryngoscopy and tracheal intubation. Laryngoscopy and tracheal intubation can cause adverse cardiovascular and cerebrovascular events. This response are due to intense sympathetic discharge. Various drugs and techniques have been used to prevent this. Fentanyl is highly lipophilic opioid. The ideal dose of fentanyl for prevention of this response is yet to be determined. The administration of this drug would provide rapid achievement of conditions suitable for endotracheal intubation. Primary objective is to study the effect of two different doses on attenuation of this response by measuring the following parameters. Secondary objective is to observe and treat an intraoperative complication. It's a prospective randomized controlled trial. Patient posted for elective surgery expected to last for more than 1 hour, belonging to age group 20 to 60 years of age. ASS status 1, 2, and 3, and Malampati airway assessment of grade 1 and 2 are included in my study, while those who refuse to give consent or have anticipated difficult airway are excluded from my study. My sample size estimation is done with the reference study Hosali Vinod et al., which gave a total of 60 patients. Ethical clearance was obtained, and CTRA registration number is as follows. After pre-anesthetic evaluation, anesthesia machine monitor was kept and checked ready. 30 patients were given fentanyl 2.5 microgram per kg, while the remaining 30 patients were given fentanyl 5 microgram per kg. After pre-medication, pre-oxygenation was priming dose of vecuronium and fentanyl 2.5 microgram per kg or 5 microgram per kg was given. And after 3 minutes of pre-oxygenation, induction was done using etominate and vecuronium. After intubating dose of injection vecuronium, laryngoscopy and tracheal intubation was performed. Hemodynamic parameters were noted at various time intervals. Patients were extubated once all the criteria for extubations were met. Complications, if any, were noted. Data analysis was done using MedCalc software. My results showed that both the groups have comparable demographics. In intergroup comparison, there was significant decrease in heart rate in group F5 as compared to group F2.5, while in intragroup comparison, there was no significant difference in heart rate as compared to baseline heart 2.5. Intragroup comparison, there was significant to group F2.5 after giving fentanyl, while in intragroup comparison, there was no significant difference in rate pressure product as compared to baseline rate pressure product. Group F5 had 15 patients who had only statistically significant hypotension. Now, fentanyl citrate is a potent opioid agonist, predominantly acts on mu receptors, which are found in cardiovascular regulatory centers, sympathetic nervous system, vagal nuclei, and adrenal medulla. Fentanyl inhibits pituitary adrenal response. This precise location of the receptors enables fentanyl to significantly blunt hemodynamic response to hypopharyngeal noxious stimuli. My results were in consonance with the study done by Vinod Hosali 2014 and Wiz Bloom, which showed that fentanyl 5 microgram per kg effectively blunts both the heart rate response and pulse rate response, but it has conflicting results with a study done by Vijayavan, which showed that fentanyl 5 microgram per kg cause increase in even fentanyl 5 microgram per kg cause increase in heart rate and blood pressure response. Hence, to conclude, fentanyl 5 microgram per kg is more effective hemodynamic stress response These are my references. Thank you.
Dr. Vedi, you had used 2.5 and 5 microgram per kg of fentanyl. Was the dose of etomidate kept same for both the groups?
Yes, ma'am.
Why was the means I would say why higher doses of fentanyl used when the effect is almost we can achieve the effect with 2.5 also? What was the idea behind using 5 microgram per kg?
Ma'am, 2.5 microgram per kg, there was slightly increased in blood pressure response 1 minute after intubation, ma'am. So
Yeah,
to
but
blunt,
it was not significant.
yes, ma'am.
Conventionally, we use that much dose always. In fact, 2 microgram per kg is a conventional dose which we are using.
Yes, ma'am.
Was there any change in the consumption of inhalational anesthetic agent or quality of means the intubation criteria, was it assessed along with the dose, efficacy of the dose?
Ma'am, sevoflurane was kept 2% after intubation for all the patients to remove any confounding factor, ma'am. It was kept same for all patients, ma'am.
Intraoperative, any decrease in exclusive decrease in heart rate or blood pressure? A significant decrease?
Not even with 5 microgram per kg, it was not observed, ma'am.
Okay. Was the use of inhalational anesthetic agent reduced with 5 microgram per kg?
Yes, ma'am. It was reduced. Yes, ma'am. It was overall reduced, but ma'am, that was not measured. That was the limitation of the study, ma'am. It was reduced, ma'am.
Yeah. Any complications in post-operative period noted?
Ma'am, with fentanyl 5 microgram per kg, nausea, vomiting incidents were higher, ma'am.
So the stress response optimization at the cost of some complications was the result of your study, I suppose.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Next presentation, please.
Neuraxial blockade. Regional anesthesia. The title of my e-paper is Regional Anesthesia Made Pleasant, Virtual Reality Used as an Adjunct to Peripheral and Central Neuraxial Blockade. Regional anesthesia is essential for the development of ambulatory surgery and yet can add to discomfort and anxiety to patients proceeding towards surgery. The possibility of hearing and seeing everything in the operating room can cause significant deal of anxiety and discomfort in the patient. Thus, the patient may receive pharmacological sedation to lessen this unpleasantness. Virtual reality was integrated into the medical education, rehabilitation, and management of pain to provide immersive experience that prevents the brain from processing acute pain. Distraction by a VR program includes visual and audio suggestions for relaxation and may achieve the intended goals of pharmacological sedation without drug-related side effects. Virtual reality is a state-of-art technology advanced system that allows the user to be transported into a virtual world and isolates them from the real world. There is lack of literature investigating the use of virtual reality in the perioperative setting in the Indian population. The current study aimed at investigating feasibility and benefits of using VR distraction during perioperative period in terms of patient satisfaction, anxiety, hemodynamic changes, and sedative consumption. This was a single-center randomized control trial conducted at Kali's Dr. Prabhakar Kore Hospital, Belgavi. After ethical clearance was obtained, the device used was the Oculus Go 4. These were the inclusion and exclusion criteria of the study. Or the study. The VR headset was mounted in the patient after in the Regional anesthesia was then administered to operative satisfaction was assessed, which was the primary outcome. The second outcome of the study were anxiety, mood changes, and consumption in terms of midazolam and propofol used. This is a snapshot of the virtual reality during the brachial plexus block, and these are the pictures of the virtual reality headset. These are satisfaction questionnaires and the patient's experience. The sample size was calculated based on power analysis, and the sample size formed.
Dr. Surbi.
Lunch menu.
Evidence was obtained. The device used was the Oculus Go 4. These were the inclusion and exclusion criteria of the study. A total of 110 patients were enrolled into the study. They were randomized into the VR group and the standard care group. In the VR group, the VR headset was mounted on the patient after attaching standard monitors in the operation theater. Regional anesthesia was then administered to both the groups. In the intraoperative period, patient satisfaction was assessed, which was the primary outcome. The secondary outcomes of the study were anxiety, hemodynamic changes, and sedative consumptions in terms of injection midazolam and propofol used. This is a snapshot of the virtual reality being used during a brachial plexus block, and these are pictures from the virtual reality headset. These are the satisfaction questionnaires and the patient's experience. The sample size was calculated based on power analysis, and the statistical analysis were performed as follows. Virtual reality distraction was linked with significantly higher post-operative satisfaction levels when compared to the standard treatment. The virtual reality group had lower median intraoperative anxiety scores, and the occurrence of intraoperative hemodynamic instability and the need of sedative was similarly lower. The current findings imply that virtual reality distraction could improve patient satisfaction while also reducing anxiety and improving hemodynamics. This is a graphical representation with the box diagram, and these are the tabular representation of the variables. The management of the patient's anxiety is critical in surgery performed under peripheral and central neuraxial anesthesia. Our findings suggest that distractive virtual reality could become a new standard practice and can widely be used as an adjunct to peripheral regional anesthesia. These are a few studies which suggested that distractive virtual reality headset could be used inside the operating room during surgical procedures performed under regional anesthesia, with benefits in terms of anxiety and sedative sparing effects, with benefits in terms of patient satisfaction and reduced perioperative anxiety levels, leading to greater hemodynamic stability during surgery with a reduced need of sedation during surgery. Our study did not report any complications. These are a few of the future perspectives of this study. Coming to the conclusion, implementation of virtual reality as an adjunct to peripheral and central neuraxial anesthesia effectively enhances procedural cooperation, patient satisfaction, reduced perioperative anxiety, and sedative consumption. Distractive technology can become a new standard practice and be widely accepted by patients undergoing ambulatory surgery under regional anesthesia with a pleasant perioperative experience and high acceptability. These are the references. Thank you.
Dr. Surbi.
Yes, ma'am.
Yes, it was a good study.
Yes,
And
thank you, ma'am.
You had done various kinds of regional anesthesia techniques.
Yes, ma'am.
I suppose. Yeah.
Yes,
So
yes, ma'am.
what was your experience in the drug requirement in these patients?
Ma'am, the drug requirement in terms of sedatives was comparatively lesser in the groups where we used VR, ma'am. The anxiousness level of the patients was significantly reduced. So we didn't have to administer midazolam or propofol intra-op, and the patient was satisfied with the virtual reality being used. They were very well distracted with the use of virtual reality.
Was there any problem during assessment of blocks?
No, ma'am. There was no problem during assessment of blocks because we were asked, like before the procedure started, we told the patients to indicate to us if they were feeling pain or if they had any problems in between. So they were thoroughly instructed about it. So as such, we didn't face any problems, ma'am.
Okay, thank you.
Thank you, ma'am.
Next presentation, please.
Good morning. Topic is comparative evaluation of ultrasound guided supraclavicular approach and subclavian perivascular approach to brachial plexus block for upper limb surgeries. Introduction. Well conducted regional anesthesia technique has its advantages over GA, such as remaining conscious, avoiding polypharmacy, better hemodynamic stability, and excellent post-op analgesia. Subclavian perivascular block aims to anesthetize 3 trunks of brachial plexus as they cross the first rib rather than a nerve root emerging between the scalene muscle seen in supraclavicular block. This is the point at which the brachial plexus is at its most compact. As a result, it is possible to block majority of brachial plexus with one injection and lowest volume of local anesthetic. At the level of first rib, the trunks are invested into a sheath formed from the anterior part of the middle scalene muscle sheath and posterior part of anterior scalene sheath, which also includes subclavian artery, hence the term subclavian perivascular. Objective was to compare the onset of sensory and motor blockade, block performance time, quality of block, and first rescue analgesia time. Materials and methods. It was a randomized controlled trial which happened in KLE Dr. Prabhakar Kore Hospital. 60 patient aged between 18 and 60 of ASA 1 and 2 undergoing forearm and hand surgery under regional anesthesia were concerned. Uncooperative patient infection at puncture site, any clavicular pathology and coagulopathy were in exclusion criteria. Sample size estimated were based on mean and standard deviation of block performance time, statistical analysis using chi-square, students paired and unpaired t-test. Ultrasound was used, high frequency linear probe, transducer, 13.6 megahertz. Drug used is 20 cc mixture of 2% lignocaine with adrenaline and 0.5% bupivacaine. Patient was put in supine position, head turned away from side. Transducer position in transverse plane immediately superior to the clavicle, approximately at its midpoint. Subclavian artery, pleura and first rib were visualized along with brachial plexus and subclavian perivascular brachial plexus identified by characteristic bunch of grapes appearance in parasagittal plane of clavicle. 23 gauge needle was introduced in in-plane technique used with lateral needle entry. In supraclavicular block, transducer was positioned in transverse plane immediately superior to the clavicle at approximately its midpoint. Subclavian artery, pleura and first rib were visualized along with brachial plexus needle placed in the brachial plexus sheath. Block performance time noted. Sensory blockade and motor blockade were assessed using needle prick method and 4-point scale respectively. Blockade evaluated every 3 minutes till onset and then every 30 minutes after surgery. Duration of sensory and motor blockade noted. First rescue analgesia are given when VAS score was more than 4 and time was noted. Results. Mean age, weight, gender and ASA grade of patient in both groups were comparable. Time to perform block was shorter in subclavian perivascular as depicted by the graph. Time taken for complete blockade to occur was shorter in subclavian perivascular than in supraclavicular block, although the onset of blockade was comparable in both the groups as seen by the table. Quality of motor and sensory blockade was better in subclavian perivascular than in supraclavicular group. Discussion. Ultrasound guided subclavian perivascular brachial plexus block not only ensures a high success rate but also decreases the incidence of complication such as vascular puncture and pneumothorax. Lesser volume of anesthetic drug is sufficed to provide a dense quality blockade. Time to perform block is significantly reduced as compared to supraclavicular block. In conclusion, ultrasound-guided subclavian perivascular block is more rapidly executed than ultrasound-guided supraclavicular block with similar duration of blockade. Hence, ultrasound-guided subclavian perivascular block is reliable and comprehensive anesthesia for upper limb surgery. Here are the references. Thank you.
Dr. Apurva, what was your basic aim? Was to compare two techniques or was to compare using USG?
Good morning, ma'am. Ma'am, the main thing was to compare the two techniques, ma'am, using ultrasound for both the techniques, ma'am. Mainly to compare the block performance time for both and if there was any change in the quality of blockade for the both, ma'am.
So what is your final inference?
The final inference being the block time in the case of subclavian perivascular group was shorter than in supraclavicular group, ma'am. And the quality of blockade, ma'am, was more dense towards the even throughout the surgery than in supraclavicular block, ma'am.
That means you want to say that the subclavian perivascular approach is more effective than the supraclavicular conventional approach.
Yes, ma'am.
Any complications noted with both?
No, ma'am. We didn't encounter any complication with both the procedures, ma'am. Because of the use of ultrasound, we had minimized the other complications also because the precision was more with the ultrasound.
Okay. Thank you.
Thank you, ma'am.
Ma'am, it was the last presentation.
Okay. Thank you so much.
Thank you, ma'am. So our next session is Jaipur Awards, and chairperson of Jaipur Award is Dr. Bhimeshwar, Dr. Sudarshan, and Dr. Neeta Gosai. Dr. Neeta Gosai is with us. Thank you, ma'am. Thank you for giving your precious. Our session name is Jaipur Awards, and chairperson is Dr. Nita Gosai. She is associate professor and department of she is associate professor of Department of Anesthesia, Gujarat Cancer and Research Institute since last 26 years. Our second chairperson is Dr. Sudarshan. I'm requesting the yes. So second chairperson is Dr. Sudarshan. He is consultant and head of Canadian Medical Center at Kuwait. And our third chairperson is Dr. Bhimeshwar. He is honorable president of ISNH. I would request our chairperson to introduce our speakers. Thank you.
Good morning to all. This session is for e-paper presentation and the topic is daycare anesthesia. Now start. First participant is Dr. Rukbe Das.
Hello everyone, a very warm regards to all of you. Now I am presenting my paper. The title of paper is the total intravenous anesthesia, TIVA with desmoidamidine versus nalbuphine in combination with propofol in upper limb orthopedic closed manipulation procedure, a comparative study in a tertiary healthcare center in Tripura. Now introduction. Manipulation under anesthesia is a closed, short, non-surgical procedure, but it demands a cool, calm patient with immobility and relaxation of body part to be manipulated. Thus, the role of anesthesia is vital for the success of the procedure. In the same time, it is a challenge for the anesthesiologist because immobility requires to be maintained, and these procedures are treated as minor, so muscle relaxant and intubation are avoided. Moreover, adequate analgesia, rapid and complete recovery and controlled sedation is essential to avoid hospital stay. In the recent years, propofol has been tried to achieve TIVA, but propofol is unable to provide analgesia, so propofol is used along with different analgesic. Desmoidamidine is an alpha agonist having sedative, anxiolytic, hypnotic, analgesic, and sympatholytic properties. And nalbuphine is a kappa opioid receptor agonist and a partial mu receptor antagonist. Now the objectives are to compare the effects: interprocedural mean arterial pressure, heart rate, respiratory rate, SpO2, recovery of orientation time, post-procedural pain, and sedation by desmoidamidine propofol versus nalbuphine propofol in upper limb orthopedic closed manipulation procedure in a tertiary healthcare center, and to observe any complication like nausea, vomiting, pruritus, respiratory depression among the study subjects in both the groups. Now the methodology. It was an observational analytical study with longitudinal design. The study was conducted in Department of Anesthesiology, Agartala Government Medical College. The study duration is 1.5 years. The study population was the patients of both sexes with normal BMI of age between 20 to 60 years undergoing upper limb orthopedic closed manipulation procedure, and the sample size is 60. Primary outcome measures: intraprocedural hemodynamic, that is mean arterial pressure, heart rate, respiratory rate, and SpO2, orientation time, post-procedural pain, post-procedural sedation, and the secondary outcome measures any complication like nausea, vomiting, pruritus, respiratory depression in both the groups. Pain is measured by FACES pain rating scale, and sedation is measured by Ramsay sedation scale. 60 opaque envelopes are divided into two halves, each half 30, and coded as group D and N. Both the groups are received uniform pre-medication with injection ondansetron 8 mg IV and injection omeprazole 40 mg IV. Group D was received injection propofol 1%, 1.5 mg per kg body weight, IV plus injection dexmedetomidine 50 microgram IV bolus, while group N was received injection propofol 1%, 1.5 mg per kg plus injection nalbuphine 10 mg IV bolus prior to the procedure. Now the results. Results comparison vitals 5 minutes after admission of drug. This is T1. Mean arterial pressure is lesser in DAS metropolitan group. P value is 0.002. Heart rate also lesser in DAS metropolitan group. P value is 0.012. And respiratory rate is a bit more in DAS metropolitan group. P value is 0.443. And there is no variation in SpO2. There is 100% in both the groups. After 10 minutes, the comparison of vitals after admission of drug. Mean arterial pressure is lesser in DAS metropolitan group. P value is 0.012. Heart rate is lesser in DAS metropolitan group. P value is 0.017. And heart rate and respiratory rate in DAS metropolitan is a bit higher. And no difference in SpO2. Comparison of recovery of orientation after admission of drug. There is a mean arterial pressure. Mean arterial pressure is much more lesser in DAS metropolitan group. And P value is 0.000. Comparison of pain rating scale scores just after completion of the procedure. In DAS metropolitan group, pain is less. After 60 minutes of the procedure, pain is lesser in DAS metropolitan group. After 120 minutes of the procedure, pain is lesser in DAS metropolitan group. Now the comparison of sedation. After completion of the procedure, less sedation in DAS metropolitan group. After 60 minutes, less sedation in DAS metropolitan group, and after 120 minutes, there is less sedation in DAS metropolitan group, and P value is 0.000. Then the comparison of vital the time of discharge, there is a bit less mean arterial pressure in DAS metropolitan group, heart rate, and in respiratory rate as well, but there is no variation in SpO2. Now the discussion part, it was observed that both the drugs have lowered the mean arterial pressure after 5 minutes and 10 minutes of admission, but none of them caused hypotension. The mean arterial pressure was significantly lower in DAS metropolitan group than nalbuphine group at both 5 minutes and 10 minutes point of time. Similarly, it was observed that both the drugs had lowered the heart rate after 5 minutes and 10 minutes of administration of drug, but none caused bradycardia. It was observed that mean heart rate was lower in DAS metropolitan group than nalbuphine group at 5 minutes and 10 minute point of time, and both were statistically significant. Thus, the present study has shown that there was no significant difference in vital parameters like respiratory rate, SpO2 at any point of time in both the groups. Mean time for recovery of orientation after admission of drug was significantly lower in DAS metropolitan group than nalbuphine group. No significant changes was observed in MAP, heart rate, respiratory rate, SpO2 among both the group at the time of discharge. This study has denoted that post-body pain was lesser after admission of DAS metropolitan than nalbuphine at all point of time. There is up to 120 minutes after the procedure, which was statistically significant. And similarly, it was observed that post-body sedation was lesser after admission of DAS metropolitan than nalbuphine at all points of time, which were also statistically significant. Now the conclusion part, DAS metropolitan is superior to nalbuphine in respect of recovery of orientation after admission of drug. DAS metropolitan is superior to nalbuphine in respect of pain control and sedation, control of sedation after the procedure. And DAS metropolitan is the superior to nalbuphine as it provides adequate analgesia and sedation without increasing mean arterial pressure and heart rate in the above said procedure. These are the references. Thank you all.
Thank you, doctor. So, what is your basic aim of this study?
Madam. Madam.
Yeah.
Yes, madam.
Yes. What is your basic aim, doctor, of this study?
Madam, DAS metropolitan and basic, so that we can discharge the patient the same day, and we are starting. Yes, DAS metropolitan and nalbuphine we are using in short spot procedure, that are orthopedic close manipulation procedure in a minority that we are doing in our hospital.
Okay. Have you observed any bradycardia? Incidence of
Not really bradycardia, madam, but decreased heart rate is there in desmodominating group. And here actually we are excluding the patient who are having heart rate below 60 or like that. We are excluding. That was the exclusion criteria.
And doctor, have you mentioned basal parameters, hemodynamic parameters in graph? Basal value of pulse, respiration.
Yes, it is, madam. We are actually taking the ASA grade 1, grade 2 patient, age between 20 to 60 years, and male, female, both sexes are included. And those who are, yes, madam, hemodynamically, those are stable. We are expecting this on those patients only. And if some patient, if having shock or hemodynamic unstable, then we are not considering in the study group of population.
Okay, thank you, doctor.
Thank you, madam. Thank you, madam.
Our next presenter is Dr. Sejal Sharma.
Everyone, myself Dr. Sejal Sharma, Assistant Professor at GCS Medical College, Hospital and Research Center. I am thankful to organizing committee of Isacon 2021 for giving me this opportunity. Today I am going to talk about efficacy of a novel dual channel LMA gastro with color coded tracer loss in daycare GI endoscopy procedure. Introduction. Anesthesia for ambulatory daycare GI procedures differ from anesthesia for surgical procedures in well-equipped operation theaters. Challenges are airway remains largely unprotected as it is a common field of work for surgeon and anesthetists. Maintaining spontaneous ventilation to avoid hypoxia. And endoscopic rooms are at remote location in major hospitals, so facility and quality of health is not same as operation theaters. Most commonly, endoscopic procedures are done under total intravenous anesthesia using propofol and fentanyl, and oxygenation is maintained with low-flow nasal cannula, which puts patient at risk of hypoxia due to unsecured airway. To overcome these problems, the LMA gastro or newer supraglottic airway device is developed specifically for GI daycare endoscopic procedures. This is a picture of gastro LMA which shows endoscope port in which enables an endoscope to be passed through it. Connector helps to maintain oxygenation. There is a white block that reduces the potential for damage to or obstruction of the airway tube or endoscope due to biting. It has silicone airway tube and cuff designed for smooth insertion and patient comfort. It has cuff pilot technology, which is an integrated color-coded cuff pressure indicator that constantly monitors cuff pressure and helps to avoid complications of cuff hyperinflation. Aim of the study is to evaluate the utility of LMA gastro for daycare GI endoscopic procedures for airway management and endoscopic intervention. Primary objective is to improve control of airway, and secondary objective is to prevent hypoxia to avoid need for intubation. Study design is a prospective observational study conducted after taking ethical committee approval and written informed consent were taken before procedure. Study population was 50 patients which were divided randomly into groups. Group N where oxygenation was maintained through nasal cannula, and Group G where oxygenation was maintained through gastroenterology. In both the groups, sedation was maintained with total intravenous anesthesia using propofol and fentanyl. Pre-procedural heart rate and SpO2. During procedure, lowest heart rate and lowest SpO2 were noted in both groups. Intraoperative adverse events like hypoxia, bradycardia, conversion to endotracheal tube were noted and treated properly. All patients were observed for post-operative 4 hours for any adverse effect and were discharged after assessing patient with modified Aldrich score system. This is modified Aldrich scoring system where the score of more than 9 was required before discharge. These are the inclusion and exclusion criteria. Now, observation and results. The data was collected in MS Excel dataset and statistical processing was done using SPSS software. Quantitative data were expressed as mean, median, or number. This table shows baseline demographic profile. Median of age of patients was 59 years, 23 were male and 27 were female, with median BMI of 22.95. This table shows clinical profile where 60 patients were of ASA grade 1, 25 were of ASA grade 2, and 9 were of ASA grade 3. Patients were having comorbidities like hypertension, diabetes, IHD, COPD, OSA, asthma, and tuberculosis. These are endoscopic procedural characteristics where 15 procedures were of ERCP, 7 were of UGI-scopy, 10 were of UGI with band ligation, 11 were UGI-scopy with biopsy, and 7 were UGI-scopy with colonoscopy. Median duration of procedure was 31.4 minutes. All patients were given propofol and fentanyl as anesthetic agents. Muscle relaxation was required in 3 patients and 1 patient required atropine. These are the patient parameters showing lowest SpO2 during procedure in gastroenterology group was 96% and nasal cannula group was 94%. Intraoperative SpO2 less than 92% occur in 1 patient in gastroenterology group and 2 patients in nasal cannula group, and all these 3 patients were required endotracheal intubation. Now coming to discussion, in a gastro-LMA group, 1 patient had intraoperative hypoxia, so endotracheal intubation was done. Patient had anticipated difficult airway due to obesity, so proper ventilation was not done in gastro-LMA. In other 24 patients in a gastro-LMA group, procedures were done successfully. No difficulty was encountered in insertion of gastro-LMA and ventilation. Gastrophysician did not find any difficulty in passing endoscope through LMA. In nasal group, 2 patients had intraoperative adverse event. 1 patient of ERCP, which went for longer duration, around 50 minutes, had bronchospasm and associated with hypoxia and bradycardia. Intraoperative SpO2 reached 75% and endotracheal intubation was done. Another procedure of diagnostic UGI-scopy in short neck and obese. Intraoperative hypoxia developed and endotracheal intubation was done. In postoperative observation, no any complication in both groups were observed. Turbulence NCS et al. Used gastro-LMA in 292 patients of ASA 1 and 2 and found it effective for maintaining oxygenation. Rane and Thiruvenkatrajan et al. Studied 64 ERCP procedures with gastro-LMA and only 1 patient required conversion to endotracheal tube because there was difficulty in negotiating endoscope through LMA. So the conclusion of this study is LMA gastro is a feasible tool for maintaining oxygenation and ventilation while providing sedation in day-care GI endoscopic procedure with the use of SAD. Deep sedation can be given with spontaneous breathing of patient without using muscle relaxation. Limitations are this is an observational study not including control group. Comparison with other airway devices are needed to evaluate risk and benefit of different airway devices. These are my references. Thank you.
Thank you, doctor. So, what is your primary objective in this study? Dr. Sejal?
Yes, ma'am.
What is your primary objective?
Madam, to secure airway.
To secure airway.
Yes.
And how will you decide sample size?
Madam, sample size is decided according to the UGS copies that are done in our hospitals, and it is decided by computer generated some software.
Okay. And what is the dose of propofol and fentanyl for sedation?
Madam, for fentanyl it is 1 to 2 microgram per kg, and for propofol it is, madam, 2 to 3 microgram per kg. If procedure is going to be longer, then we started propofol infusion. Otherwise, it is given IV state.
Okay. What are the contraindications for insertion of gastric element?
Madam, if there are, yes, madam, if there is any difficulty airway, like there is some growth at pharyngeal level, or there is a restricted mouth opening, at least 2 finger mouth opening is required for insertion of it. So if there are any airway difficulties, are restricted or difficult airway, then it is a contraindication for gastro LMA.
Okay. Have you observed any complications?
No, madam, not as such. Only no, madam, no, there were no any complication like sore throat or dysphagia in any patient in gastro LMA group. Only in intraoperatively in 1 patient we saw hypoxia because it was not able to set the LMA properly.
Okay. Okay. Thank you, doctor.
Thank you so much, madam.
Now, next presenter is Dr. Amina Azmi. Dr. Amina, please.
The title for my paper presentation today is to compare time and intraoperative hemodynamic changes of spinal anesthesia with general anesthesia for laparoscopic cholecystectomy. Myself, Dr. Amin Azmin from JN Medical College, AMU, Aligarh. Introduction. Laparoscopic cholecystectomy has become very popular after it was described in 1985 by Dr. Erich Müller in Germany and is considered as a procedure of choice for the management of symptomatic cholelithiasis since 1988. Surprisingly, in the era of minimally invasive medicine, regional anesthesia has not gained popularity and has not been routinely used as a sole method of anesthesia in laparoscopic procedures. Recently, it has been shown that laparoscopic cholecystectomy can be done successfully using low pressure carbon dioxide pneumoperitoneum under spinal anesthesia in healthy patients with symptomatic gallstone disease. Laparoscopic cholecystectomy is usually done in general anesthesia with tracheal intubation to avoid aspiration and respiratory complications secondary to induction of pneumoperitoneum, which is not well tolerated in patients who are awake during the procedure. Regional block anesthesia alone is done only occasionally, mainly in patients unfit to receive general anesthesia. Neuraxial techniques for a variety of surgical procedures resulted in decrease in mortality, venous thromboembolism, myocardial infarction, and several other complications. Both techniques have their own advantages and disadvantages. General anesthesia allows controlled ventilation and provides sufficient muscle relaxation. On the other hand, regional anesthesia is known to decrease surgical stress and post-operative morbidity. Aims and objectives. The primary objective is to compare intraoperative hemodynamic changes, mainly bradycardia and hypotension of spinal anesthesia, with general anesthesia for laparoscopic cholecystectomy. Secondary objective is to compare the time duration taken between spinal and general anesthesia. Materials and methods. It is a prospective randomized observational study conducted in General Jawaharlal Nehru Medical College, Aligarh. Study population of 70 patients with benign gallbladder disease undergoing laparoscopic cholecystectomy. Inclusion criteria: adult patient 18 to 50 years, patient who give consent for participating in the study, and ASA physical status 1 and 2. Exclusion criteria: ASA grade 3-4, acute cholecystitis, pancreatitis, cholangitis, coagulation and bleeding disorders, previous open abdominal surgery, contraindication for pneumoperitoneum, cardiovascular disease and circulatory instability, allergy to local anesthetics, and conversion from spinal to general anesthesia. After approval by the Board of Studies, Department of Anesthesiology and Institution Ethical Committee, 70 patients undergoing laparoscopic cholecystectomy after applying inclusion and exclusion criteria and taking informed consent were randomly divided into two groups. That is Group S and Group G. Group S is spinal anesthesia and Group G is general anesthesia, each with 35 patients. The patients were taken into OD, IV line secured, 500 ml ringalactate infusion started and monitors attached. In spinal anesthesia, the patients were premedicated with the injection on ondansetron 0.08 mg per kg intravenously. Patient was made to sit. 25 gauge squinky spinal needle was introduced in subarachnoid space at L3, L4 in the space. 0.4 mg per kg hyperbaric bupivacaine was injected intrathecally at velocity of 0.1 ml per second and made to lie in supine position. A segmental sensory block extending between T4 and L5 dermatomes without any respiratory distress was assessed. In general anesthesia, the patients were pre-medicated with injection on ondansetron 0.08 mg per kg, injection rezolam 0.03 mg per kg, and injection fentanyl 2 mics per kg. Pre-oxygenated for 3 minutes with 100% oxygen, induced with injection for 2 mg per kg, relaxed with injection vecuronium 0.08 mg per kg. Oral intubation was done with cupped endotracheal tube of appropriate size, maintain oxygen, nitrous oxide, isoflurane, intermittent vecuronium, and positive pressure ventilation. Laparoscopic cholecystectomy was performed using the same technique in both the groups with standard 4-trocar incision and pneumoperitoneum established using open Hazen technique with carbon dioxide and maximum intra-abdominal pressure of 14 mm of Hg. Hemodynamic parameters, pulse rate, systolic blood pressure, diastolic blood pressure, incidence of bradycardia, hypertension, and total time of study were compared. Hemodynamic parameters were recorded after spinal or intubation, before insufflation, during maximum insufflation, during gallbladder handling, end of surgery, and immediate post-op. A pulse rate less than 50 per minute was considered as bradycardia and treated with repeated dose of injection atropine 0.2 mg IV bolus till pulse rate reaches more than 60 per minute. PP fall of more than 20% below the baseline preoperative value was considered as hypertension and treated with directly or indirectly acting vasoactive agents. Statistical analysis was done in SPSS version 25.0 and the continuous variables were analyzed using t-test and categorical variables were analyzed using chi-square test. A p-value less than 0.05 was taken as statistically significant. These are the results that was attained. All the procedures were completed by the allocated method of anesthesia and there was no conversion from spinal to general anesthesia. Surgeries were uneventful except some cases which developed episodes of hypertension and bradycardia that was managed effectively. The incidence of hypertension was 17%, 40% and bradycardia was 11.4% and 2.8% in group S and group G respectively. The total time taken in group S was significantly less. The results were 38.9 minutes for group S and 46.7 minutes for group G. In our study, we had hypertension in 6 cases of spinal anesthesia. We could correct it with saline infusion and vasopressin. Sin et al. Noted the incidence of hypertension as 20.5% in their series. So, whereas et al. Found that intraoperative hypertension is a well-known adverse effect of spinal anesthesia, which was easily managed and did not affect the planned procedure. Bradycardia is an expected side effect due to rapid peritoneal stretch and vagal stimulation in laparoscopic cholecystectomy operation. Bradycardia is observed also in spinal anesthesia in most of the cases due to inhibition of T1 to T4 cardioaccelerated fibers and decreased right atrial filling. However, studies have reported that this condition can be prevented by fluid replacement and vasopressor addition. The Kistani et al. Reported that 8% of the spinal anesthesia group had bradycardia requiring atropine injection. We obtained similar results in our study. The total mean time under spinal anesthesia in previous studies ranged from 26.4 to 47.4 minutes. In our study, there was statistically significant difference in mean operative time between group S and G, suggesting that spinal anesthesia and laparoscopic cholecystectomy did not interfere with the adequate surgical view or access, and thus not prolonging the time. Lezar et al. Also found similar results. This study suggests that laparoscopic cholecystectomy done under spinal anesthesia is safe, maintain comparable hemodynamics, and is less time consuming than general anesthesia. However, further studies with a larger sample size may be conducted to support observations. Spinal anesthesia can be recommended as a sole technique of choice for day-care surgeries like laparoscopic cholecystectomy in developing countries where time and cost can be saved. These are my references.
Okay, thank you, doctor. So, what is your primary objective?
Good morning, ma'am. My primary objective is to combat the hemodynamic changes in spinal anesthesia and general anesthesia. Mainly, we saw the incidence of hypotension and bradycardia between the two.
Okay. It is prospective study. And before giving spinal anesthesia, have you preloading the patient?
Yes, ma'am. Before both general anesthesia patient and spinal anesthesia patient, we gave one 500 ml of ringalactate.
Okay. And after post-operative, when you give the first dose of analgesic as compared to GA and spinal, is there any difference?
Actually, ma'am, we have in my study, we did not take pain as a parameter in comparison. Our study is intraoperative. We compared everything intraoperatively.
Okay. What intraoperative analgesic you were given in general anesthesia?
In the beginning, we gave fentanyl 2 mics per kg, and usually the procedure lasted for GA 30-40 minutes, so that was sufficient. And in spinal anesthesia, among the 35 patients that we conducted, 4 patients developed shoulder pain. Out of this, 2 patients were managed by counseling, and 2 patients we had to give ketamine, 0.5 mg per kg dose.
Okay. So, what is your final conclusion?
In both spinal and general anesthesia, there were hemodynamic changes, but considering the time, cost, the post-op morbidity, the pain, post-operative nausea, vomiting, then the decreased surgical stress response, we can try considering spinal anesthesia in our hospital settings. Anyway, we also have a backup of conversion to GA whenever if it is needed. But in our case, we didn't have any requirement for GA conversion.
Okay, nice, doctor. Thank you, doctor.
Thank you.
Now, next presenter is Dr. Parmeshwaran. Dr. Parmeshwaran, please.
I'm Dr. Parmeshwaran from SRM Medical College. My study is comparison of 3 different sedation regimen for gastrointestinal endoscopic procedure, a randomized control trial. This is my CTR registration number. And coming to introduction, gastrointestinal endoscopic procedures are relatively invasive and unpleasant, which needs high level of patient cooperation and adequate experience of the endoscopist. The need for these procedures were increasing due to the increasing patient's awareness and better accuracy of tests for diagnosis. So, the sedating the patients outside the operating room is like a double-edged sword. Under sedation may lead to patient discomfort, poor coordination, and technical difficulties for the endoscopist. while over-sedation may lead to oxygen desaturation, hypotension, aspiration of gastric content, delayed recovery, and prolonged hospitalization. So coming to hypothesis, for UGI scopy procedure, midazolam is commonly used for sedation and has lesser side effect than other drugs. So the primary objective of my study is patient level of satisfaction at discharge, and the secondary objectives are time taken to reach observer assessment of alertness sedation score of 2 to 4 and satisfaction level of endoscopist and side effect encountered during and after the procedure. And after getting institutional ethical committee and clinical trial registration, it is a prospective randomized study, and sample size 30 patients in each group were enrolled in our study. So this is the formula for calculating the sample size. And then inclusion criteria: age of 18 to 60, ASA 1, 2, and patient undergoing endoscopic procedures. And exclusion criteria are age greater than 60 years, drug allergy, severe respiratory illness, difficult airway, and pregnancy. So 90 patients of age group between 18 to 60 undergoing ureoscopy are included in the study and randomized into 3 groups. In group B, propofol is used 1 milligram per kg intravenously, followed by 0.5 milligram per kg per hour as infusion. And in group D, dexmedetomidine is used as 1 microgram per kg intravenously infusion for 10 minutes, followed by 0.5 mics per kg per hour infusion. And in group FM, uses fentanyl 1 mics per kg plus midazolam 20 mics per kg intravenously, followed by fentanyl 0.5 mics per kg per hour infusion. An additional allowance of injection fentanyl 25 mics intravenously was given depending upon the requirement during the procedure. And the sedation level of patient is assessed by observer assessment of alertness by sedation score, and the response readily to name spoken in normal tone is 5, and lethargic response is 4. Response only after name is called is 3, and response only after mild prodding or shaking is 2, and does not respond to mild prodding or shaking is 1. So the time taken to reach OAA score of 2 to 4 is noted, and deep sedation is also recorded. And the patient level of satisfaction at discharge, the patient satisfaction was assessed using 10-point visual analog scale. So the satisfaction level of endoscopies is also recorded using visual analog scale. And 1 to 3 is considered difficulty in performing the procedure, and 4 to 7 is minor difficulty in performing the procedure, and 8 to 10 is no difficulty in performing the procedure. So the side effects were also noted, and the recovery profile, that is time taken to reach OA score of 5 was noted, and any complications after or during the recovery was also monitored and noted. So the statistical analysis, data were entered in MS Excel sheet, and ANOVA one-way test was used to compare proportions, and p-value of less than 0.05 was considered to be statistically significant. So coming to results, demographic data and duration of the procedure between the 3 groups were similar and statistically insignificant. There is a bar diagram showing the age, gender, weight, and duration of procedure. All these 4 are non-significant between the 3 groups. And the heart rate, mean arterial pressure, and oxygen saturations were lower in dexmedetomidine group and was statistically significant. So this is a line diagram showing the heart rate, mean arterial pressure, and saturation. In all these 3, the dexmedetomidine group has a lower heart rate, mean arterial pressure, and saturation. And the onset of sedation was earlier in group B, that is in propofol group, and the time to recovery, patient and surgeon satisfaction score, and maximum OA score, and requirement of additional fentanyl, incidence of gagging were similar in group D and P, that is in dexmedetomidine and propofol group. They have similar and was better than group MF, that is in midazolam fentanyl, which is statistically significant. So this is a bar diagram showing the time to recovery, patient and the endoscopy satisfaction score, requirement of additional fentanyl, maximum OA score, and complications. And in complications, the propofol had higher incidence of deeper sedation and desaturation. And coming to discussion, Marcus et al. Conducted a study with a 200 patient posted for the upper GI scopy, and then midazolam fentanyl was administered for one group, and the other group received propofol fentanyl. And level of sedation was assessed using observer assessment score and bispectral index. Under the patient and physician satisfaction score, recovery time and complications were noted. So the author concluded that OA score, deep sedation, and patient and physician satisfaction score were better in propofol fentanyl group than midazolam fentanyl group. And results were consistent with what we have observed in our study, although we have compared dexmedetomidine with the propofol and midazolam fentanyl. And we et al. Conducted a study comparing dexmedetomidine with the propofol for sedation, hemodynamic control, and patient and endoscopic saturation score. And the result of the study was that mean arterial pressure in a propofol group decreased during the procedure compared with the dexmedetomidine group. So the heart rate decreased after loading dose in the dexmedetomidine group, and there was a higher saturation score among the patients in propofol group, although the endoscopic saturation score was comparable between the two groups. In our study, the mean arterial pressure, heart rate decreased in dexmedetomidine group compared to propofol and midazolam group, but recovery time to reach OAA score 3 was better in propofol than other groups, and patient and saturation score were similar in propofol and dexmedetomidine group and was better than midazolam. Conclusion: in our study, the patient and endoscopy score were comparable in both dexmedetomidine and propofol group, and considering the decreased rate of complications in dexmedetomidine group, we conclude dexmedetomidine provides an overall better experience for the patient, endoscopist, and anesthesiologist than propofol and midazolam combination. Limitations: due to cost-effective and limited availability of bispectral index monitoring, we could not use this monitor for assessing patient's level of sedation. These are my references. Thank you.
Thank you, doctor. Doctor, is there any difference in discharge criteria in three groups? In dexmedetomidine group, in propofol group, is there any difference?
Actually, this is comparatively in discharge criteria. The propofol group had a deeper sedation. The recovery from the deeper sedation is more in propofol group compared to dexmedetomidine and the midazolam combination. So the patient with the propofol group had delayed time for discharge compared to other two groups.
Okay. Have you observed this in your study? Okay.
Yes, we are observing them. The discharging criteria, we are seeing them.
And have you observed total bolus dose of fentanyl? Total bolus, intermittent dose is given.
Okay. Initially, actually, it depends upon the procedure duration. Actually, for bolus, initially we'll be giving according to weight. According to weight of the patient, we'll be giving the bolus dose, and then we'll start with the infusion. And depending upon the duration of the procedure, we'll continue the interview.
What is your sample size?
Sample 30 in each group, ma'am. So three groups, 90 patients we are taken.
Okay. So what is your conclusion final? Dexmedetomidine is better.
Yes, ma'am. We have concluded that dexmedetomidine group as better than other compared to propofol and the midazolam combination. Because in propofol group, we see complications.
Okay. Any bradycardia in any patient?
Bradycardia in dexmedetomidine group, we had decrease in BP vitals, that is heart rate and blood pressure compared to other two groups, but that was not significant. Not the patient had not went for brady, but the heart rate are comparably less.
Okay. Thank you, doctor.
Thank you.
Thank you. Now, our next presenter is Dr. Shruti. Dr. Shruti, please.
Myself, Dr. Shruti K. Title: to assess the effect of dexmedetomidine nebulization on propofol requirement for induction in laparoscopic tubal ligation, patient state index, guided general anesthesia. Coming to introduction, laparoscopic tubal ligation is one of the most commonly performed sterilization procedure, offering advantages like a high success rate and early return to normal activity. Most anesthetic studies focus on postpartum tubal ligation, but in our hospital, such procedures are done either as elective interval procedures or following medical termination of pregnancy. Nebulized dexmedetomidine administration may allow rapid drug absorption through nasal, respiratory, and buccal mucosa. The patient state index is a parameter of electroencephalography used to assess the depth of anesthesia, and value of 25 to 50 indicates hypnosis. Coming to objectives, primary objective: to assess the effect of dexmedetomidine nebulization on consumption of propofol under general anesthesia. Secondary objective to assess patient recovery profile. It's a randomized controlled double-blind study. Sample size calculated based on study conducted by Ola M. et al., considering the amount of propofol consumption between the two groups. The minimum required sample size is 20, hence sample size in each group is 20. This is my inclusion criteria. This is my exclusion criteria. Coming to grouping, institutional ethical clearance and informed written consent were obtained, registered in Clinical Trial Registry of India. Patients were randomly allocated into one of the two groups, that is Group D and Group S, using numbers generated from randomizer.org. This is my grouping technique. Coming to blinding, Group D patients received dexmedetomidine nebulization 2 mg per kg diluted in 0.9% normal saline made up to 3 ml given 30 minutes prior to surgery. Whereas Group S patients received saline nebulization 3 ml of 0.9% normal saline given 30 minutes prior to surgery. Steady. Both patients and observer were not aware of the study drug. In the preoperative room, monitors connected and baseline values of NIBP, heart rate, SpO2 recorded. IV access established and 18-gauge IV cannula secured and infusion of ringer lactate was started. All patients were kept fasting overnight. Patient advised to take tablet pantoprazole and alprazolam on the previous night of surgery. Both groups received allocated drug through jet nebulizer with a continuous flow of 100% oxygen at 6 liters per minute over 30 minutes before induction. Ramsey sedation scale was assessed at 10 minutes interval before shifting to operation theatre. In the OT, ECG, SpO2, NIBP, patient state index, ETCO2 connected and monitored. All patients were pre-medicated with injection, midazolam and fentanyl. After pre-oxygenation for 3 minutes with 100% oxygen, patient in each group was induced by propofol in titrated dose based on patient state index values in the range of 25 to 50 and consumption of propofol and mean time induction of anesthesia was noted. Anesthesia was maintained with oxygen, nitrous oxide, sevoflurane mixture with MAC of 1. Rescue doses of propofol if required given in titrated dose. Laparoscopic tubal ligation performed under GA with spontaneous ventilation using iGel and patient was given 100% oxygen after completion of procedure. PSA monitored throughout the procedure and patient shifted to post-op room after attaining PSA of 100. Post-operatively patient were monitored for sedation using Ramsey sedation scale. These are the parameters measured. These are the side effects observed and treated accordingly. Coming to statistical analysis, data was entered in MS Excel and analyzed using SPSS 22 version software. P-value less than 0.05 considered as statistically significant. Coming to demographic, 40 patients were taken up for the study. There was no dropout. Demographic data were comparable in both the groups. On comparing the duration of surgery between the two groups, there were no significant difference and were comparable in both the groups. Coming to preoperative Ramsey sedation scale, there was no significant difference in the Ramsey sedation scale in both groups. Coming to a comparison of propofol consumption, in group D, amount of consumption of propofol is 55 milligram, whereas in group S, 89 to 90 milligram. There was significant reduction in propofol consumption in group D compared to group S at induction. Time for induction of anesthesia, the mean time required for induction of anesthesia was significantly less in group D compared to group S. On comparison of heart rate, there was significant difference in heart rate preoperatively, intraoperatively, and postoperatively up to 8th hour in group D, which is statistically significant, but no incidence of bradycardia was observed. On comparing systolic blood pressure, there was significant difference in SBP, both preoperatively, intraoperatively, and postoperatively up to 2nd hour between the groups. The SBP was found to be lower in the group D and was statistically significant. On comparing diastolic blood pressure, there was significant difference in the DBP preoperatively, intraoperatively, and postoperatively between the groups. The DBP was found to be lower in the group D and was statistically significant. On comparison of MAP, there was significant difference in the MAP preoperatively, intraoperatively, and postoperatively between the groups. The MAP was found to be lower in group D statistically, not leading to hypotension. On comparing patient state index, there was significant difference in mean PSA between two groups, and the amount of propofol required to attain PSA of 25 to 50 was less, and group D patients achieved early rate, whereas compared to group S. Post-operative Ramsey sedation scale, there was significant difference in the first hour of post-operative period in the group D, and patient was tranquil. On comparing side effect, there is no significant difference between the two groups. Coming to discussion, in one of the Zhang et al., he concluded that intranasal administration of dexmedetomidine 2 mg per kg reduces perioperative anesthetic requirement with better recovery profile. Similarly, we also found that consumption of propofol reduced by 40 to 50% in group D compared to group S. In one of the study conducted by Morgan, he found that preoperative administration of dexmedetomidine reduces requirement of both propofol and remifentanil during induction maintenance and in post-operative period. In our study, we also found a significant reduction of propofol consumption in group D. However, we did not evaluate the consumption of of fentanyl requirement as the duration of surgery was within 25 minutes. Soleil M and Kuch M et al. Concluded that both PSA and BIS monitors predicts the depth of propofol anesthesia with similarity and sufficient highly probability. Hence, we used PSA monitor to assess the depth of anesthesia. In one of the Indian study, which is conducted in the pediatric population, they found that nebulized dexmedetomidine as a pre-medication at a dose of 3 mg per kg provides better parental separation and mask acceptance. Whereas we also found that sedative and anxiolysis effects were more in group T with 2 mg per kg of dexmedetomidine nebulization. In one of the study conducted by R.R. Kumar and his associate, they found that using dexmedetomidine nebulization as a pre-medication yields stability in BP and heart rate during surgery with no adverse effect. In our study, even though the heart rate, SBP, DBP, MAP decreased significantly in group D, there was no incidence of hypotension or bradycardia requiring intervention. Coming to conclusion, preoperative nebulization with 2 mics per kg dexmedetomidine accelerates faster attainment of PSI value of 25 to 50, reduce the propofol requirement during induction. These are my references. Thank you.
Okay. Thank you, doctor. So your conclusion is consumption of propofol and hemodynamic stability.
Hello, ma'am.
This study is double blind or single blind?
Double blind,
Double
ma'am.
blind or single blind? Okay.
Double blind, ma'am.
And double blind study. And dose of propofol requirement is decreased in dexmedetomidine group.
Yes, ma'am.
Okay. Have you observed any side effects?
Side effects, as
Any
such,
side
there are
effects?
no side effect. No, ma'am. When compared to like a group D, there was a significant reduction in the heart rate and SBP, DPP hemodynamically. Whereas in group S, there was not much decrease in the hemodynamic parameters, ma'am.
And have you observed IGL insertion time? Total insertion time of IGL. IGL insertion time.
Yeah, ma'am. Time for induction of anesthesia have observed, ma'am. It was less in group D. It is about like 52 seconds, whereas in group S, it was almost 80 seconds, ma'am.
Okay. Okay. Thank you, doctor.
Thank you.
Thank you. Now, next presenter is Dr. Spandana. Please.
Hello everyone, I'm Dr. Nandam Spandana from King George's Medical University, Lucknow. My topic for today's paper presentation is comparison of wanted anesthesia care using dexmedetomidine with spinal anesthesia using ropivacaine in daycare varicose vein surgery. Coming to the introduction, varicose vein surgery is usually performed on an ambulatory basis because it typically causes minor surgical trauma and low post-operative pain. There are several anesthetic methods including general anesthesia, regional anesthesia, and peripheral nerve blocks. Wanted anesthesia care with local anesthesia is other option for patients undergoing vein stripping. In our study, we aim to compare the safety and efficacy of MAC using dexmedetomidine with spinal anesthesia using ropivacaine in terms of patient satisfaction for anesthesia, ambulatory time post-surgery, and time of discharge. Coming to the methods, this randomized prospective control study was conducted in Department of Anesthesiology in collaboration with Department of General Surgery in King George's Medical University, Lucknow, from August 2020 to July 2021 after obtaining Institutional Ethical Committee approval and written informed consent from all the participants. 64 patients were randomly divided into 2 groups of 34 each. Group 1 wanted anesthesia care with dexmedetomidine where fentanyl was given as rescue analgesia. Group 2 spinal anesthesia with ropivacaine. In the MAC group, a loading dose of 1 mic per kg of dexmedetomidine was administered over 10 minutes, which was followed by a maintenance infusion beginning at a rate of 0.6 mics per kg per hour. Sedation state was assessed by Ramsay sedation scale and the infusion rate of the drug was titrated to 0.2 to 0.7 mics per kg per hour. For reducing the pain response, fentanyl 1 to 2 mic per kg IV was used as rescue analgesia. The infusion of the dexmedetomidine was stopped at the beginning of the elastic band dressing. In the spinal group, preload of 1 liter crystalloid was given. Then spinal anesthesia was performed using 10 mg of 0.5% isobaric ropivacaine, which was injected intrathecally by a midline or paramedian approach at the L3, L4 or L4, L5 interface using a 27 or 25 Gauss squinty spinal needle. Level of the sensory block was assessed by spirit swab and motor blockade was assessed by modified Gomez scale. Parameters studied. Sedation of MAC group was assessed by Ramsey sedation scale. In the spinal group, motor blockade was assessed by modified Gomez scale and sensory block was assessed by spirit swab. Patient satisfaction to anesthesia was assessed by verbal numerical rating scale. Ambulatory time after surgery was assessed by measuring the time since the patient was shifted to PACU to patient start mobilizing. Discharge time post surgery was assessed by measuring the time since the patient got shifted to PACU to patient got discharged from hospital. Inclusion criteria. Patients giving written informed consent aged between 18 to 60 years, ASA grade 1 and 2. Exclusion criteria, refusal of patients, patients undergone general anesthesia within 7 days, patients with coagulopathies, ASA grade 3 and 4, known drug allergies, patients with serious renal or liver disorders. The sample size was calculated on the basis of the difference in the change of the systolic BP from baseline to after 5 minutes of infusion. Considering any dropouts, we had enrolled 32 patients in each group. Statistical analysis. Randomization and allocation was done by using randomly generated computer numbers. Statistical analysis was done by using SPSS version 21.0 statistical analysis software. Results were presented in a number percentage and mean plus or minus standard deviation. P-value was calculated by using student's t-test. P-value less than 0.05 is considered as statistically significant. Coming to the results, demographics of both groups were comparable. Significantly higher verbal numerical rating scale for patient satisfaction to anesthesia was observed in patients of group 1 as compared to group 2 with p-value 7.523 and p-value less than 0.001. Ambulatory time was significantly earlier in group 1 as compared to group 2. Range of ambulatory time in group 1 was 2 to 5 hours, while that in group 2 was 4 to 6.5 hours with p-value minus 22.379, p-value 0. less than 0.001. Time to get discharged from hospital after surgery was early in group 1 as compared to group 2, though statistically not significant. We can see the tabular and graphical representation of between group comparison of the verbal numerical rating scale and tabular and graphical representation of comparison of the ambulatory time post-surgery. Coming to the discussion, dexmedetomidine is a highly selective alpha-2 receptor agonist. It produces dose-dependent sedation, anxiolysis, analgesic and narcotic sparing effect, and enables patients to respond to verbal stimuli during surgery without significant respiratory depression. Ropivacaine is a long-acting amyl local anesthetic agent. Ropivacaine is less lipophilic than bupivacaine and is less likely to penetrate large myelinated motor fibers, resulting in a relatively reduced motor blockade with greater degree of motor sensitive differentiation, which will be useful when motor blockade is undesirable. In our study, we aim to compare the safety and efficacy of monitored anesthesia care using dexmedetomidine with spinal anesthesia using ropivacaine in terms of patient satisfaction to anesthesia, early ambulation, and early discharge. Using Moon et al. Conducted a similar study comparing MAC with dexmedetomidine and spinal with bupivacaine in varicose vein surgery. Their study concluded that MAC using dexmedetomidine in combination with ketamine may be an alternative anesthetic technique for varicose vein surgery with regard to patient's preference and medical condition. Mosing et al. Conducted a study comparing ropivacaine and bupivacaine for intrathecal anesthesia during outpatient arthroscopic surgery. Their study concluded that isobaric ropivacaine 15 mg provided a higher sensory block level and shorter sensorial onset and offset times than did 7.5 mg of isobaric bupivacaine. In our study, there is better patient satisfaction to anesthesia in MAC group with early ambulation and early discharge. As walking after varicose vein surgery prevents clots from forming in legs and also promotes good circulation, MAC with dexmedetomidine provides early ambulation. Also, patients undergoing spinal anesthesia will have more anxiety, apprehension to technique, and sometimes failed spinal or multiple attempts will create more discomfort to patient, and spinal complications are also an important concern to consider. Although spinal with ropivacaine provides lesser motor blockade as compared to spinal with bupivacaine, promoting some degree of early ambulation and being more cardiostable than bupivacaine, spinal anesthesia-related complications can always happen. MAC with dexmedetomidine will counteract all these by providing a conscious sedation to patients with physiological sleep-like state. Limitations: cost of dexmedetomidine is more. Future studies should extend this model of research to large number of patients. So we conclude that MAC using dexmedetomidine is better alternative for daycare varicose vein surgery as there is better patient satisfaction to anesthesia, early ambulation, early discharge when compared to spinal anesthesia with ropivacaine. These are my references.
Okay. Thank you, doctor. What is the bolus dose of dexmedetomidine and infusion dose of dexmedetomidine you have used?
Good morning, ma'am. Ma'am, loading dose is 1 mic per kg.
over 10 minutes, ma'am. After that, the maintenance doses, ma'am, we started at 0.6 mic per kg per hour, and depending upon the sedation, we it was titrated from 0.2 to 0.6, ma'am.
Okay. Have you observed total dose of rescue analgesia?
Ma'am, rescue analgesia was mostly the varicose surgery was completed in most of the patients within 45 minutes, ma'am. So in most of the patients, rescue analgesia was not needed. Only in few patients it was needed, and we have given 1 mic per kg of fentanyl, ma'am.
Fentanyl.
Yes, ma'am.
Okay. Any sedation observed postoperatively?
Sedation,
In
no, ma'am.
dexmedetomidine group?
No,
No sedation.
no, ma'am. Before shifting the patient to OT immediately after the surgery only, we have assessed the Ramsay sedation scale, and we shifted the patient in Ramsay sedation scale 1 and 2 score, ma'am.
Okay. And in pain score analgesia?
No, ma'am. We didn't consider pain in our study, ma'am. Our main criteria.
Analgesia?
Ma'am, we didn't assess the
Hemodynamic
pains.
sedation. Okay. Thank you, doctor. Thank you.
Thank you.
Next presenter is Dr. Neha.
Good morning. Efficacy of combined epidural general anesthesia and laparoscopic cholecystectomy criminals, a prospective randomized study. Laparoscopy is a well-known surgical procedure which is associated with creation of pneumoperitoneum. Pneumoperitoneum leads to cardiorespiratory effects which needs to be attenuated. There are several methods for attenuation, use of drugs and use of anesthesia techniques. Practice of preemptive epidural activation of laparoscopic procedures are rarely used. We aim to evaluate the combination of epidural and general anesthesia with preemptive activation for its efficacy on hemodynamic parameters and post-op analgesia in comparison with standard general anesthesia and laparoscopic cholecystectomy cases. Primary objective was to compare hemodynamic variables such as blood pressure, heart rate during pneumoperitoneum. Secondary objectives were to compare the consumption of drugs, post-operative analgesia, post-op sedation, and adverse effects. This was a prospective single-blinded study. Sample size of 90 was required with 45 in each group. Institutional Ethical Committee clearance was obtained. Written informed consent was achieved from billing patients. Inclusion criteria was as follows. All patients posted for elective lab or open procedures cholecystectomies were enrolled. ASA physical status 1 and 2, age group 20 to 60 years, males and females, and Boswell mass index of 18 to 30. All patients with contraindication to neuraxial techniques, allergy, cardiovascular and respiratory diseases, obesity, pregnant patients were excluded from the study. All patients were randomly allocated to Group G and Group GE. Patients in Group G received standard general anesthesia, and patients in Group GE received epidural along with the standard general anesthesia. All patients were preloaded with 500 ml of ringalactate. All patients were administered pre-medication with injection midazolam and injection fentanyl. All patients were monitored as per the requirement. In Group G, general anesthesia was induced with propofol and relaxant atracurium was used. In Group GE, epidural was placed at T12 and L1 and injection ropivacaine 0.2% ropivacaine was used to achieve sensory level of T6 before induction of general anesthesia. Data was recorded during intubation period, post-intubation, pneumoperitoneum period. Hypotension was managed by means of administering of bolus fluid. If severe, was managed with injection mefenterine. Hypertension and tachycardia was treated with bolus doses of propofol and fentanyl. Bradycardia was treated with atropine. Intraoperative data that were collected are SPP, DVP, MAP, heart rate, ETCO2, and drug doses. Postoperative period data was Ramsay sedation score, VAS score, adverse events, shoulder pain, and residual analgesia. Data was analyzed by SPSS version 17. Appropriate tests were applied. P-value less than 0.05 was considered statistically significant. There were no demographic differences noted between Group G and Group GE. Coming to hemodynamic parameters, heart rate, significant difference was noted only in the post-intubation period, with Group GE recording lesser heart rate than Group G. There were no differences observed in the post-intubation as well as in the pneumoperitoneum period. Blood pressure changes. Systolic blood pressure changes were noted in both groups. There were no difference observed in the baseline values. However, the difference in the SPP changes were recorded in the post-intubation period and in the pneumoperitoneum period. There was a significant difference which was observed between the two groups. In two groups, both continued to record lower SBP, systolic blood pressure than the baseline values. Diastolic blood pressure followed similar pattern of systolic blood pressure. There was no difference in the baseline value, but there was significant difference observed between the groups in the post-intubation and in the pneumoperitoneum period. The difference was also significant within the group. Mean arterial pressures, there was significant difference observed between the groups in the intubation period, post-intubation period, and also throughout the pneumoperitoneum period. Group GE recorded lower blood pressures than Group G. There were no difference observed in oxygenation and end-tidal carbon dioxide. There was higher consumption of opioid, propofol, and inhalation in Group G, whereas Group GE, lesser consumption of opioids, relaxants, and propofol and induction agents. Hypertension incidence was high in Group G, whereas hypotension incidence was high in Group GE. Severity of surgical pain was assessed in the postoperative period. The severity of pain was low in both groups. However, the significant difference in the severity was also observed in postoperative period after 4 hours. Group GE recorded lesser intensity of pain. Shoulder pain incidence was high in Group G, whereas it's less in Group GE with less severity. Duration of analgesia lasted longer in Group GE. Postoperative sedation was found in both groups. There was no difference in the sedation with both groups recorded low levels of sedation. Our study proved the usefulness of combined epidural general anesthesia for laparoscopic surgeries over conventional GA in attenuating hemodynamic responses. Preemptive epidural activation provided hemodynamic stability during pneumoperitoneum. CEGA technique also reduced the need of intravenous drugs by providing longer duration of post-op analgesia. Epidural drug administration leads to sympathetic block by means of reducing catecholamine levels. Panvayas et al. Compared combination of epidural with GA in retroperitoneal laparoscopic surgeries. The hemodynamic effects were compared along with measures of catecholamines. It was found that the levels of catecholamine were low in combination group. Epidural also reduces the requirement of intravenous as well as inhalational agents. Bandeva et al. Studied the requirement of inhalational and induction agents along with hemodynamic stability in combination of epidural technique with GA technique. It was found that CEGA group had better hemodynamic stability, lesser requirement of drugs, and prolonged duration of analgesia. Intravenous drugs are associated with prolonged sedation, adverse effects, and side effects. Lucchetti et al. Compared TIVA with CEGA. Both techniques were effective in maintaining hemodynamic stability, attenuating stress response. However, the recovery was faster in CEGA with better post-op analgesia. Epidural anesthesia leads to sympathetic block and a parasympathetic activity takes place. Because of this, the tone of the gut changes. Varsha et al. Compared the efficacy of CEGA in laparoscopic surgeries. Along with the hemodynamic changes, the operative conditions were also studied. It was found that in CEGA group, the operation conditions were marked as excellent along with better attenuation of stress responses. Epidural and spinal is associated with hypotension. This was compared by Calvo et al. Who compared spinal and epidural along with GA for laparoscopic surgeries. Though both groups recorded incidence of hypotension, severity of hypotension was higher in spinal group, but recovery was faster in epidural group. The results of our study match with studies by Pan et al., Bandeva et al., Lucchetti, and Varsha. We differ from Calvo et al. Calvo et al. Used higher concentration of ropivacaine, whereas in our study we used 0.2% of ropivacaine, which led to milder degree of hypertension compared to Calvo et al. We did not record any incidence of nausea, vomiting, prolonged sedation, cardiac events, or neurological deficits. We recorded limitation as that we did not record the speed of recovery and we have not conducted cost-benefit analysis. In future, studies can be performed to compare the effects of pneumoperitoneum by means of measuring inflammatory mediators. To conclude, combination of epidural with general anesthesia and laparoscopic surgeries will provide hemodynamic stability and perioperative analgesia. These are my references. Thank you.
Thank you, doctor. So
Thank you, ma'am.
What is your primary objective?
Was to compare the heart rate and mean arterial pressure changes, especially during the pneumoperitoneum.
Okay. Have you observed the time when you give the epidural drugs to pneumoperitoneum?
Actually, we did not observe because it took time, especially after we waited for 8 to 10 minutes to induce GA. But the recording of pneumoperitoneum started only once the surgeons have adjusted the levels and checking of that setup. So we recorded the pneumoperitoneum period, but we did not record the time for the onset of pneumoperitoneum period.
Okay. Have you observed any difference in intraoperative analgesic requirement in epidural group as compared to other group?
Ma'am, epidural patients in epidural group require lesser analgesics, ma'am. Only other than what was used during induction. We did not give any other opioids in the intraoperative period, in the post-op period as well. Whereas in group G, as the patient had presented with hypertension and tachycardia, extra doses of fentanyl and propofol were used. So there was a significant difference we observed with the opioid requirement between the groups, ma'am.
Okay. Thank you, doctor.
Thank you, ma'am.
Now, next presenter is Dr. Meghna. Dr. Meghna, please.
Good morning, everyone. Myself, Dr. Meghna from Safdarjung Hospital, New Delhi. My topic is comparison of the self-selected music and prefix music on reduction of perioperative anxiety in adult patients undergoing laparoscopic surgeries under general anesthesia. Anxiety is a phenomenon commonly noticed among hospitalized patients. It is estimated that the incidence of the preoperative anxiety can be as high as 80%. Anxiety during perioperative period can produce excess catecholamines, causing hemodynamic changes, impair immune function with increased susceptibility to infection and delayed healing. Perioperative anxiety reduction can be done by pharmacological and non-pharmacological methods. Pharmacological methods often cause excessive sedation, hemodynamic changes, and respiratory depression. Time of recovery and thus time of discharge might get prolonged due to the interaction of pharmacological agents and drugs administered during anesthesia. Therefore, non-pharmacological measures are being explored to reduce anxiety. Music is a non-invasive, non-pharmacological, non-expensive mode of anxiety reliever, and it has an effect on anti-stress system of the body, which acts by increasing the release of endogenous opioids. Aim of our study was to compare the effects of self-selected music and prefix music in reducing perioperative anxiety in Indian adult patients undergoing laparoscopic surgeries under general anesthesia. Primary objective was to compare the effects of the self-selected music and prefix music on reduction of the perioperative anxiety. And the secondary objective was to compare the impact of the self-selected music and prefix music on hemodynamic stability, serum cortisol levels, post-operative nausea and vomiting, and post-operative pain. Materials and methods. Institutional ethical committee approval was taken. Informed consent of the patient was taken. Our study was a prospective randomized comparative study. 90 adult patients aged 18 to 65 years of either sex having ASA 1 or 2 undergoing elective laparoscopic surgeries under general anesthesia were included. Patients with any neuropsychiatric disorder with ear-related diseases on beta blocker therapy and pregnant patients were excluded. The patients were randomized into 3 groups. Group SS patient had listened to music of their own choice. Group PF patients had listened to soft instrumental music. Group C control group. Methodology. PSA of the patient was done. Concept of listening to music for 20 minutes prior to the surgery till the end of the surgery was explained to patient. Consent was taken 1 day prior to the surgery. All patients were asked their favorite playlist for about 20 minutes. T1 baseline study variables were taken in pre-operative room. Then music was started for 20 minutes in the pre-operative room. Patient was shifted to OT. Standard ASM monitors were attached. T2 study variables were noted. IV cannula was secured and sample for serum cortisol was taken. Pre-oxygenation with 100% oxygen for 3 minutes done. Injection fentanyl 2 mg per kg. Injection propofol 2 mg per kg. Followed by which checked ventilation was done. Injection vecuronium 0.1 mg per kg was given. Face mask ventilation for 3 minutes done. Definitive airway was secured. After 10 minutes of the induction, T3 study variables were noted. Reversal of anesthesia was done with the injection neosegment 58 mg per kg and injection glycopyrrole 10 mg per kg. Patient trachea was extubated. After 5 minutes of the extubation, T4 study variables were noted. Headphone was removed from the patient after reversal of the anesthesia. Patient was shifted to recovery room. T5, T6 study variables were noted at first and second hour after surgery respectively. Maintenance of anesthesia was done with the nitrous oxide and oxygen ratio 1:1. Inhalational agent isoflurane was used 0.5 to 1%, and intermittent maintenance dose of the injection vecuronium bromide 0.02 mg per kg was given. Intraoperative analgesia was supplemented with the infusion paracetamol 20 mg per kg and injection morphine 75 mg per kg before incision. Injection ondansetron 0.15 mg per kg was given around 3 minutes prior to closure. Local infiltration of the incision line with a 0.25% bupivacaine was administered by the surgeon before the skin closure. Outcome measures. The physiological parameters, heart rate, systolic blood pressure, diastolic blood pressure, and arterial pressure were measured at different times. Preoperative anxiety was taken, T1 and T2. Serum cortisol levels were sent in preoperative period after listening to 20 minutes of music and 1 hour after the surgery. POME score and pain score were taken 1 hour and 2 hour after the surgery by other resident doctor unaware about the group allocation. Anxiety was measured by the visual analog scale, and the pain was also measured by the visual analog scale. POM was evaluated on 4-grade scale. The patients who felt pain and VAS of greater than 4 in the post-operative period injection, diclofenac sodium was given in intravenous infusion. In patients with persistent feeling of the nausea, intravenous injection, metoclopramide was given. There's no significant difference was seen in the distribution of the age in years, gender, assay grade among the groups. Parameters measured at T1 were comparable among the groups. At T2, the reduction in the anxiety score was higher in SS compared to the PF. There was statistically significant difference in anxiety score between the SS and PF. After music intervention, heart rate T2 was significantly reduced in SS and PF, but there was no significant difference in heart rate T2 between SS and PF. At all other times, the systolic blood pressure was statistically lower in SS and PF, and there was statistical difference between the SS and PF. At T6, DBP was lower in SS in comparison with the group PF and C. There was statistical significant difference in DBP at T6 between group SS and group PF. At T5, the postoperative nausea and vomiting score was lower in SS and PF than C, but there was no statistical difference between the SS and PF. At T6, the postoperative nausea and vomiting score was lower in SS and PF than C, but again, the same thing, there was no significant difference in postoperative nausea vomiting score between SS and PF. At T5, the post-operative pain score was less in SS and PF compared to the C, and there was significant difference in post-operative pain score between SS and PF. And this is a graph showing the anxiety score before the music intervention and after the music intervention. Discussion. Our results showed that there was a significant reduction in the VAS-A score following intervention in group SS and group PF, while VAS-A score in group C significantly addressed. This is similar to the previously reported findings by the Wang et al. A significant reduction in the anxiety score, systolic blood pressure, diastolic blood pressure was observed in intervention group when compared to the control group, but insignificant difference in heart rate in the study conducted by Abouzar Mohammadi et al. The findings of this study are consistent with our study except the heart rate and diastolic blood pressure, which can only be explained by trait-related individual responsiveness of the sympathetic system. In our study, results showed that listening to the music reduced the severity of the POME after the laparoscopic surgery when compared to the control group. Listening to self-selected music reduced the severity of the post-operative nausea vomiting score in more number of the patients than prefixed music, both at the first hour after the surgery and second hour after the surgery. The results were similar to the study by Funda Setinkaya. The patients who had listened self-selected music had low VAS score compared to the patients who had listened prefixed music and patients who hadn't listened music at both times, first and second hour after the surgery. The findings are similar to the study conducted by the Nielsen et al. Conclusion. Self-selected music was more effective in reducing the anxiety than prefixed music. Self-selected music enabled to maintain stable hemodynamic parameters throughout the surgery compared to the prefixed music. POME scores were comparable between the self-selected music and prefixed music groups. Self-selected music was more efficient in providing pain relief than prefixed music. These are the references. Thank you.
Thank you, doctor. So you have measured serum cortisol level at particularly pre-operative, after music. At what point you have measured serum cortisol level?
Good morning, ma'am. Good afternoon, ma'am. Ma'am, pre-operative serum cortisol levels were comparable among all the groups, but post-operatively, the serum cortisol levels were increased in all the groups. But the percentage increase in the control group was more compared to the prefixed group than compared to the self-selected group, ma'am. But there was no significant difference among the groups with respect to serum cortisol.
And what is the average duration of surgery?
Ma'am, average duration of the surgery was 90 minutes to 110 minutes, ma'am.
Okay. So what is your final conclusion?
Ma'am, final conclusion, in my study, the strengths were, every step was followed in methodology, and we had used appropriate study tools like headphones we had used, which gave two benefits, ma'am. That gave the intervention simultaneously and also blocked the conversation, which usually will happen in the OT. And we had used VAS-A score for anxiety and VAS score for the pain. But the limitation of our study was depth of anesthesia was not monitored since it was not available in during that study time. So this can be explored in the future by applying this, since it has implication on the stress response. And mainly I'll conclude that, ma'am, self-selected music provided better awakening in the patients, and they had less post-operative nausea vomiting score and post-operative pain in the post-operative period.
Nice, doctor. Thank you, doctor.
Thank you, ma'am.
Next presenter is Dr. Bhumika. Dr. Bhumika, please.
Hello everyone. I am presenting a study of comparison of recovery characteristics between spinal 2 chloroprocaine 40 mg and low dose bupivacaine 10 mg in spinal anesthesia for short duration surgeries. Under guidance of Dr. Sunaina ma'am, who is my PG guide and working as associate professor in Government Medical College, Surat. In present era, many gynecological, orthopedic, and general surgeries are performed under short duration anesthesia. The primary aim of the short duration surgery anesthesia is to allow for early recovery of the patients so that they can return to their familiar home environment earlier. Ideal intrathecal agent for short duration surgery should have a rapid onset of motor and sensory blockade, predictable regression within an acceptable time frame, and low incidence of side effects. So here we are comparing shorter injection chloroprocaine 40 mg with low dose bupivacaine 10 mg. Aims and objectives of the study are: primary objectives, comparison of total duration regression of sensory and motor block, comparison of time to ambulation and micturition. Secondary objective is to study hemodynamic parameters and side effect during spinal anesthesia. Methodology. In methodology, there is a prospective observational study. After taking approval for ethical committee, we have studied 60 patients, from which 30 patients received injection chloroprocaine, while 30 patients received injection bupivacaine. Patients who were giving consent for spinal anesthesia or study were included in the study, while any contraindication of spinal anesthesia, allergy to any local anesthetist, any coagulopathy, localized infections were excluded from the study. Patient's pre-anesthetic checkup was done a day before surgery. The procedure is to be done, explained to relatives and patient himself, and informed written consent was taken. In pre-operative room, patient was preloaded with injection ringalactate and pre-medicated with injection midazolam, while spinal anesthesia was given with injection bupivacaine or either chloroprocaine with 25 gauge twin piece spinal needle in L3, L4 or L2, L3 interspace. Intraoperative heart rate, systolic blood pressure, diastolic blood pressure, saturation was recorded at regular interval, and sensory and motor blockade was assessed by pinprick method, and motor blockade was assessed by modified Bromage scale. Statistical analysis was done by using Microsoft Excel and paired t-test. The difference was considered to be statistically significant when p-value is less than 0.05, highly significant when p is less than 0.001. Out of 60 patients enrolled of the study, 30 were included in group A and 30 were in group B. Mean age was 39.3 years in standard deviation 11.6 in group A, while 48.3 with standard deviation of 11.8 in group B. Majority of patients below was belong to male gender, and peak block height was achieved in group A was 7.8 meter, while in group B it is around 7.03 meter. This is the table showing comparison of both the groups. Total regression in group A was 140 minutes, in while group B was 117 minutes. It's called sensory duration, while Bromage 0 means total motor blockade was 133 minutes in group A, while 103 minutes in group B. While time for maturation was in group A 170 minutes and group B was 139 minutes. Time to assisted ambulation was mean of 148 plus 148 minutes in group A, while 121 minutes in group B. We have observed that in 97% of cases of group A, and total duration sensory effect was more than 100 minutes, only one case, so total duration between 70 to 90 minutes. 86% cases of total duration of sensory effect was lesser than 100 minutes. Only 14% cases showed that total sensory duration more than 400 minutes in group A. These are the references. Its study was result was similar to our study. This is graph showing mean duration of regression to S2 level means complete sensory regression. This is showing complete motor regression. Motor block was assessed by modified Bromage scale. Dr. Ram Nivas was study of injection chlorprocaine, lidocaine, bupivacaine, where he has observed total duration of motor block was 96 minutes in injection chlorprocaine, 115 minutes in lidocaine, and bupivacaine group has total duration of motor blockade was 200 minutes. This is mean time of comparing assisted ambulation. This is time of successful maturation. In our study, we observed that 3% of group A was able to walk and void before 100 minutes, and these 29 patients could walk and pass urine after 100 minutes. While in group B, 86% could ambulate without any support within 100 minutes of giving spinal anesthesia, and maximum duration of ambulation was within 130 minutes. Small number of patients in the study should be taken, and the large number will confirm the study. Future scope, the quest for the searching newer and safer anesthetic agents for shorter duration procedure surgeries have always been in primary medicine anesthesia practice, and clinically, 2 chlorprocaine with superior pharmacokinetic profile. Chlorprocaine has been observed to be well tolerated in regional anesthesia technique than bupivacaine. This is our conclusion. There are references we have taking in consideration. Thank you.
Thank you, doctor. Thank you. So, what is total volume? Volume of bupivacaine in this group when you give us?
Yes, ma'am.
Total volume.
Total volume we take 2.5 ml, ma'am. With 2 ml bupivacaine, we added 0.5 ml sterile normal saline.
And in chlorprocaine?
Chlorprocaine we have 40 milligram, ma'am. 4 cc volume we have taken.
Okay. So, what is your primary objective?
Ma'am, our primary objective was to comparison of sensory and motor regression duration between both the groups.
Okay. And is there any difference in discharge criteria in both groups?
No, ma'am, we have not mentioned any discharge criteria, but we compare time for assisted ambulation and voiding before discharging patient from post anesthesia care unit to respective patient ward.
Okay. Thank you, doctor. Thank you.
Thank you, ma'am.
Our next presenter is Dr. Tag Thomas.
Ma'am, we haven't received anything from Dr. Taj, so it was the last presentation of the session.
Okay. Okay. Thank you. Okay.
You can conclude the session.
Okay. Thank you very much to all. Thank you very much.
पांच की इधर दीजिए ना। हाँ वांदो हाँ
બરાબર. હા.
Hello.
Hello.
Am I audible?
Yeah.
Yes, sir, we are going to start the session very soon, and the chairperson has joined. Will join.
Yes, we are going to start the session. The chairperson of the Dr. Mukesh Vakil, Dr. Das Gupta, Dr. Navin Chandra, and Dr.
The chairperson hasn't joined yet.
Dr. Mukesh Vakil is present physically.
Okay. Should I play the CV?
Yeah, we can play.
Hello.
Dr. Mukesh Vakil is HOD and HOD Department of Anesthesia and Pain Management at Sal Hospital, Ahmedabad. He is teacher and examiner for DNB and pain specialist since 1984. He had experience in published book which title is My Anesthesia Cut, and his interest is published innumerable number of articles in national and international journals. He is awarded by 100 drawings in COVID time. So thank you, Mukesh sir, for giving your precious time to us.
Thank you for introduction. Can you start the session, please? Dr. Das Gupta. Hello.
Technical team to request the session start. Dr. Das Gupta, he is past president in ISA, director of anesthesia, Jaslok also, and research center, Pedder Road, Mumbai. Now I would request to tech team that please play the video. Okay, we have one more. Dr. Manpreet.
Oh, we have a presentation of Dr. Manpreet Singh.
Yeah.
Okay.
He is the first presenter.
Yeah, I'm online. Good afternoon, everybody.
Yes, sir. Dr. Manpreet Singh.
Yeah. So,
yes, sir.
This video will be played now.
Yeah, it seems so.
Yeah. Yeah.
Yes, sir. I'll play the video. First, introduce Dr. Manpreet Singh by your side. Na?
Yes, I am Dr. Mukesh Vakil.
Yeah. Good afternoon, sir.
Good afternoon. And I think the session will start now. So the IT section will start the session. Can we start the first session, please? Please start.
Just give me, sir, 1 minute.
Okay. Correct. Yes, sir, please.
I
Yes,
think
sir.
there is some technical itch. They must be playing the video right now.
Some technical issue.
Yes, sir, there is a technical issue. Just give me 2 to 4 minutes, sir.
I see. Okay.
The chairperson requested to take to the live the video or play the video.
Dr. Manpreet Singh, you can start.
Sir, there is some technical glitch with the video. I'll play after the another video.
Oh, I see.
Okay. So we can start with the video of Tanmay, Dr. Tanmay, and he's also there in the meeting. So sorry for the inconvenience, person.
Yes, Dr. Tanmay Tiwari, welcome. Due to some technical reasons, the time is delayed. So you can start straight away.
Good morning, everyone. Greetings from King George Medical University, Lucknow. First of all, I will take this opportunity to thank the organizing committee of Isacon 2021 for providing me the opportunity for presenting a topic on inhaled nitric oxide, the current concepts. Not wasting much of the time, I would directly come onto the topic. As we all know, nitric oxide is an odorless, colorless gas, first identified by Joseph Priestley in 1774. It was first described to be toxic and was labeled as a pollutant. But in 1987, by the efforts of Palmer and colleagues, it was published and recognized as endothelium-derived relaxing factor. And for this, they achieved Nobel Prize later. Inhaled nitric oxide's utility in the modulation of pulmonary vasomotor tone is proven and is a part of standard clinical practice for pulmonary hypertension, especially in the pediatric age group. The use of inhaled nitrous oxide for the treatment of ARDS is one of the most widely studied pharmacological intervention in the past 3 decades since its determination in 1987 by Palmer and colleagues. And inhalation of nitric oxide is now recognized as a successful and innovative therapy that has been used to treat an estimated 5 lakh Americans. So a bit of biochemistry I would like to tell. As NO is a gas that is colorless and odorless. It is at room temperature and is relatively insoluble in water. It is highly reactive molecule with other free radical species and possesses an extremely short half-life. Endogenous nitric oxide synthesis inside the body is dependent on nitric oxide synthetase. They are of 3 types. I'm not going in much details about them. The ability of nitric oxide to elicit vasorelaxation is due to the property of increasing the intracellular level of cyclic GMP. And the atmospheric concentrations of nitric oxides typically range between 10 to 500 parts per million, but may reach 1.5 parts per million in heavy traffic and up to 1,000 parts per million in tobacco smoke. You can see the biochemistry at the cellular level on the given diagram. What is the fate of an inhaled nitric oxide? Once the nitric oxide is dissolved, it gets dissolved in the airway lining fluid. It reacts to form peroxynitrate, which is a powerful oxidant that can further decompose to yield nitrogen dioxide and hydroxyl radicals. Therefore, nitric oxide can be cytotoxic. Nitric oxide inhalation may lead to formation of methemoglobin and nitrate on reaction with oxyhemoglobin, which predominates in the pulmonary circulation. And almost 70% of inhaled nitric oxide is excreted as nitrate in the form of urine within 48 hours. This is the fate of the biochemical fate of inhaled nitric oxide in the alveolar capillary membrane. So what are the classical physiological actions which are seen with nitrogen oxide inhalation? As NO is delivered via inhalation, it will preferentially directed to ventilated alveolar capillary units. The consequence of this is selective pulmonary vasorelaxation, which results in reduced pulmonary artery pressures, pulmonary vascular resistance, and right ventricular afterload. The varying improvements in systemic arterial oxygen tensions are likely with ARDS, but who and which patients may be benefit may require further studies to determine the actual patients which will be benefited by the therapy. Brisk withdrawal of inhaled nitric oxide when administered at clinically significant concentrations can lead to rebound pulmonary hypertension. So the withdrawal should be gradual and it should not be sudden withdrawal. The rebound hypertension can be minimized by gradual weaning and use of 5-phosphodiesterase inhibitors like sildenafil, which can prolong the effect of cyclic guanyl monophosphate. In presence of a bit discussion about the toxicity, in presence of high concentration of inspired oxygen, nitric oxide is oxidized to nitrogen dioxide as peroxynitrate, which may lead to impaired surfactant production. So it may lead to be cytotoxic. In order to protect against nitric oxide toxicity, inhaled nitric oxide should be administered with the lowest possible oxygen concentration, and nitric oxide and nitric dioxide concentration should be monitored and exhaled gas should be scavenged. The Occupational Health and Safety Administrations, the OSHA, permit the permissible exposure limit for nitric oxide for employees at the workplace to 25 parts per million over a period of 8 hours. Nitric oxide, as mentioned earlier, produces methemoglobin, and therefore methemoglobin measurement is required during the use of this therapy. As we all know, methemoglobin shifts the oxyhemoglobin dissociation curve to the left and thus prevent the unloading of oxygen. At up to 15% concentrations, it is asymptomatic. And if the concentration increases up to 15% and beyond 70%, it can lead to coma and death. The levels monitoring of the titrated the use of nitric oxide should be titrated depending upon the methemoglobin levels. The most common route of administration of nitric oxide to adults is by inhalational, as it is mentioned, and it is preferably given to patients by receiving mechanical ventilation, but it may be also given with the help of face mask or nasal cannulae. We should try to avoid the mixing of nitric oxide with high concentration of oxygen. And by doing this, we should also limit the mixing by providing the nitric oxide at the inspiratory lip of the ventilator tubing as near to the patient as possible, or we can synchronize the injection with inspiration to further reduce the adverse effects. Electrochemical analyzers are used to monitor the concentrations of nitric oxide and nitrogen dioxide in the inspired gas mixture to an accuracy of 1 parts per million. And chemiluminescence monitors can detect nitric oxide in parts per billion. Up to 40 parts per million of inhaled nitric oxide administered clinically should not cause methemoglobin in adults until and unless the patient is suffering from methemoglobin reductase deficiency. The dose-response relationship, the early clinical experience suggests that higher doses are required to treat pulmonary hypertension than to improve oxygenation. No radiological or physiological variables currently are present to predict a response to inhaled nitric oxide in patients with acute lung injury or ARDS, and the response varies over the clinical course. Theoretically, a response is defined as 20% increase in oxygenation with nitric oxide, 30% decrease in pulmonary vascular resistance during the inhalation of nitric oxide in a dose of 10 parts per million for 10 minutes has been used to identify an association with vascular responsiveness to agents that can be helpful. So what are the current clinical uses? Where is the drug most commonly used? So as I earlier told, it is used in the pediatric population in the it is approved by FDA in 1999 for the use in pediatric age group. The FDA approval of nitric oxide clearly states the safety and efficacy of INO has been demonstrated in term and near-term neonates with hypoxic respiratory failure associated with evidence of pulmonary hypertension. And persistent pulmonary hypertension of the neoborn remains a significant problem occurring in 1 to 2 per 1,000 live births with a high mortality of up to 20%. The current recommendation suggests that INO can be started in term or near-term neonates when the oxygen index exceeds 25 or when the PaO2 is less than 100 millimeter of mercury when the patient is receiving oxygen at 100% of IO2. Inhaled nitric oxide at a dose of 20 parts per million and wean as tolerated. Risk of methemoglobin is high, so close monitoring is required in pediatric age group. Coming on to the adult age group, the utilization of inhaled nitric oxides to treat patients suffering from ARDS dates back to its invention in 1987. And one of the benefits of inhaled nitric oxide is based on the fact that unlike intravenous therapies, it selectively targets the pulmonary vasculature and lung units with varying degrees of ventilation. Systemic therapies worsen oxygenation due to counteracting the body's hypoxic pulmonary vasoconstriction. Inhaled nitric oxide instead preserves the HPV and augments the partial presence of oxygen. Over the last 2 decades, the potential therapeutic role of inhaled nitric oxide remains unclear in these patients. And the current recommendations in 2016 by the Cochrane Library has been suggested that inhaled nitric oxide should not be routinely used in the treatment of patients with ARDS. It seems reasonable to consider inhaled nitric oxide in patients with refractory hypoxemia, knowing that it may not improve the long-term outcomes. The mortality benefits have not been observed, but it may serve as a bridge of sort to other therapies or to allow for therapeutic benefit from other therapies. So the current evidence is insufficient to support INO in any category of critically ill patients with the AHRF. And INRO results in transient improvement in oxygenations, but does not reduce mortality and may even be harmful as it may lead to renal impairment. Use in sickle cell disease and acute chest syndrome. INO has only been used in isolated cases of mechanically ventilated patients with acute chest syndrome, and there have been no RCTs to assess the benefits and risk of this treatment. In case reports, concentrations of INO ranging between 20 to 80 parts per million. And in most patients, there was a dramatic improvement in oxygenation and drop in pulmonary vascular resistance. But no consensus has been achieved. But people are using in sporadic cases at case reports, and yet an RCT has been planned to be done. In post-cardiac arrest, Kida and colleagues observed that breathing nitric oxide beginning 1 hour after returning of spontaneous circulations markedly improved the neurological and myocardial functions, as well as survival at 10 days without causing hypertension. So this is an interesting study which leads to and paves path for next development of studies or RCTs, the use of nitric oxide for post-cardiac arrest patients. And it will be interesting to see how things develop in the coming years, as the AHA guidelines routinely change every 5 years. We might see the inclusion of INO as a treatment option, but it is quite early to say. But yes, there have been promising case reports which have been you can find on the net, and this is one of the things which I got on the net published in 2014. People have also used during the COVID-19 pandemic, and there are many articles people have used in case reports. I could not find an RCT, but there was an interesting study on 7 patients, and it was published in May this year, which showed that retrospective analysis of arterial oxygenation and pulmonary vasoreactivity in 7 COVID-19 patients receiving 20 parts per million of INO for 15-30 minutes. They found that it provided immediate help and delayed the respiratory deterioration in COVID-19 induced moderate to severe ARDS. So people have also used during the COVID-19 pandemic, and the most common indication for such diseases of use of inhaled nitric oxide is the pulmonary selectivity of the drug, which causes pulmonary vascularization relaxation and produces marked improvement in the PaO2 values. Similarly, use in lung and heart transplantation, there are no RCTs, but Moreno et al. Demonstrated a decreased incidence of primary grass dysfunction and expression of inflammatory mediators in patients receiving inhaled nitric oxide. And similarly, this can be a pave study for the coming ages of transplantation as it is peaking up. So we can see more and more literature coming up, and so with our knowledge with inhaled nitric oxide will improve over time. So at the end, I would conclude, inhaled nitric oxide has demonstrated itself to be a novel and a versatile molecule without significant side effects. It has managed to work its way into daily clinical practice as a complementary therapy for a myriad of cardiopulmonary disorders. The recent emergence of data demonstrating organ protections for niche patients such as organ transplantation, cardiopulmonary bypass, and COVID-19 is meaningful and needs further studies to comprehend them. And there are multiple areas of new research in selected patients and further focused translational and clinical investigations regarding inhaled nitric oxide seem warranted. Thank you. Namaskar. Jai Hind. Jai Isai.
Any question on the topic? It seems there are no questions. So we pass on to the second. Ready?
Yes, sir. Yes, sir. Ready. Dr. Manpreet Singh. I'm playing the video.
Okay, please. Thank you.
Thank you. Hello, everybody. I am Dr. Manpreet Singh, professor in the Department of Anesthesia and Intensive Care at Government Medical College, Chandigarh. And my topic is Xenon, a future in anesthesia. What's in the future now? If you see that we have artificial intelligence, robotics in anesthesia, then we have newer drugs, then nanotechnology, and then we have computers in anesthesia, even space anesthesia, aggressive pain management. But let's talk about the inhalational anesthesia. What is we have in your future with Xenon? What's different in Xenon? Let me talk about that. Inhalational agents have been used in practice of anesthesia for centuries, but diethyl ether and nitrous oxide, sevoflurane, desflurane, you all know about these inhalational agents. But Xenon is studied for its anesthetic properties because it's odorless, non-pungent, non-toxic, non-explosive, and environmentally friendly. If you see the chart of inhalational agents with the classification, there are gaseous and volatile liquids, these type of inhalation anesthetics, and Xenon is that comes into the gaseous form. Inhalationally, the goal of the inhalational agents is to aid in the induction or maintenance of anesthesia, and we are searching still with the ideal anesthetic agents, that is rapid induction, adequate analgesia and amnesia, which produces depression of the autonomic nervous system, which causes muscular relaxation. Then rapid emergence should be there, and avoidance of undesirable side effects. Let's talk about the pharmacokinetics and dynamics of inhalation anesthetics. They produce the anesthesia by interaction with the specific receptors in the central nervous system, that is GABA receptors or NMDA receptors. And the inhaled anesthetics, they act in the spinal cord and they produce the immobility, particularly with the dorsal horn, and they are depressed afterwards. There is a property of inhalational agents, that is Mayer's-Overton rule. This rule states that the action of general anesthetics is proportional to their partition coefficient in lipid membranes. Let's understand now the concept of the noble gases which are incorporated in this inhalational agents. This is approximately 117 elements are there, out of which 94 occur naturally on Earth. And in the group 18 or group 8, somewhere it is written in the periodic table, or it's also called as group 0, you will find in the corner you will find helium, neon, argon, krypton, xenon, and radon. These are the noble or inert gases. Now, because these are the stable ones, that's why they are kept on the last of the periodic table. Let's know some facts about the xenon. Its discovery was made by the repeated fractional distillation of noble gas, that is krypton, when it was, and xenon with a name is a Greek word which means stranger. Naturally, it contains 9 isotopes, and it is most abundant of which is xenon 132. It was discovered in 1898 by Sir William Ramsay and Maurice W. Travers. These were both were the chemists, British chemists, and they found it after the fractional distillation. Xenon is xenon is a naturally occurring element and comprises of 0. You can see 5 zeros and 86% or 0.05 ppm of the air. Now manufactured by the fractional distillation of liquefied air, and it is used as various in the lasers, high intensity lamps, flash lamps, bulbs, then X-ray tubes, and in the medicine. It is not a pollutant or an occupational hazard gas, and it is contributing to the global warming or green gas effect. Why is xenon in anesthesia? Why do you want to put this in the anesthesia? Because xenon has many properties of ideal inhalational agents. It is odorless, non-pungent, non-toxic, non-explosive, environmentally friendly, and unlikely to undergo biotransformation because it is a stable one. And xenon has a rapid onset of action, analgesic properties enormous, a lack of arrhythmicity, and it is a cardiovascular stable, and also maintains the autoregulatory mechanism in the CNS. It has a quick emergence profile. If you see the journey of xenon in anesthesia, 1898 it was discovered. 1939 the anesthetic properties were defined by Benkes and Yorburg, and then 1946 Lawrence found in its narcotic property, its specific narcotic property in mice. 1951 the Cullen and Gross found that it is a complete anesthesia. The xenon gives the complete anesthesia without any changes in the vital signs. And later on, the MAC of xenon at 0.71 or 71% was given by Eager, and it indicates that it's a highly potent inhalational agent. In properties, the symbol is Xe, you all know, and physical form, it is a colorless gas, and boiling point is minus 108.09. And then if you see the compare with the other inhalational agents, you will find that xenon has 71% of MAC, and as per nitrous oxide, which is 104, and the blood gas coefficient is 0.115. This is very important because all the properties are related to the blood gas coefficient of xenon, and it is the least one in all the inhalational agents. If you see that this chart and this graph, you will see that xenon is 1.45 times more effective than nitrous oxide in depressing the gross purposeful movement to the noxious stimuli such as skin incision. The pharmacokinetics and dynamics of xenon, it has a blood gas coefficient of xenon is 0.115, and this depicts its speed of onset, how faster the onset is there and how faster is the emergence time. And because of this inert property of xenon, once it is turned off, it washes out quickly. After about 25% of it is exhaled in the first pass by the lungs. How does this xenon act? The xenon basically, it seems to have no effect on the GABA receptors, but it acts by the blocking the excitatory NMDA receptors in the central nervous system. And its analgesic activity effect is due to inhibition of the NMDA receptors in the CNS and by inhibition in the dorsal horn of the spinal cord. Then another fact is that clinically 1.5 MAC is accepted as lower limit of the surgical anesthesia, and this can hardly be reached as at least 25% of gas used in the anesthesia should be oxygen. So xenon cannot be used as sole anesthetic agent. If you see, the stages of anesthesia was also learned in 1993, that it has a 4 stages. When the 70% of xenon and 30% of the oxygen was given, then in the first stage there was a stage of paresthesia or hypoalgesia. Second stage was stage of euphoria. Third stage was stage of analgesia and partial amnesia. And fourth stage was stage of surgical anesthesia. So if the patient goes into the fourth stage, then a degree of muscle relaxation is also there with the pronounced diaphragmatic breathing. And in the emergence, as the emergence is concerned, the patient start to regain consciousness and initial disorientation is seen, but patient wakes up within 2 minutes and fully conscious within 4 minutes, and pain is also there. Threshold is back by 10 to 12 minutes of stopping the xenon anesthesia. So you can see that how quickly it causes the anesthesia and how quickly the emergence is there. Further, the properties of analgesia, I have already told you that the NMDA receptors are blocked, and anti-nociceptive effects of nitrous oxide are dependent on opioid receptors, particularly in the periaqueductal gray area of the brain. Then in the medical science journal or the Lancet, there was a section of medical science where it was the safety was given that in the double-blind comparison of efficacy, there is the potency of xenon versus nitrous oxide. It was compared, and it was told that xenon is more effective than nitrous oxide at maintaining the hemodynamics. This is the cardiovascular system with the xenon, it is very important that to note that cardiovascular system does not vary with when xenon is given. That's why it's called as cardiostable. There are other articles also which show that it is very stable and inert gas. And the xenon, it does not cause any variation in the blood pressures and the pulse rate. So therefore, it is in the animals, it has been found that little is known about the cardiovascular effects of xenon in the diseased heart. But in fact, most of studies published are the animal studies, because most of studies are on the healthy heart. It's not on the diseased heart. But they have found on the animals that it hardly causes any significant alteration in the blood pressure, heart rate, cardiac output, and systemic vascular resistance, or CVPs. So further, it was also shown in 2001 that xenon was found to decrease the mean
अभी जेरॉन चल रहा है, वो बलजीत
cardiac
सिंह ने ज्वाइन नहीं
output
किया
and
था।
systemic
अब उसने
vascular
ज्वाइन
resistance,
किया
but it
तो
was
उसने
very,
मेरे
very
लेक्चर
less
से पहले उसका लेक्चर कर लें।
insignificant as far as comparable to the
45 minutes later.
Marx et al. In 1997 in the British Journal, they published that there are cardiovascular effects of xenon is in varying concentrations versus the total intravenous anesthesia on pigs, and they found that the xenon was an inhalational agent with little influence on the cardiovascular system. Xenon is a cardiovascular anesthetic, cardiostable anesthetic, good inotrope preservation. Then there is a less stress-induced sympathetic stimulation. On the respiratory system, it causes central depression, slowing of the respiratory rate. Then there is a compensatory increase in tidal volume. This means the minute ventilation remains the same. And on the other hand, if you see, it has a high density, 3 times the nitrous oxide, and high viscosity, 1.5 times of the nitrous oxide. In the Lushman et al., they showed in 1993 that there was only slight deterioration in the lung mechanics, and suggested that it can be safely used in older patients and patients with the chronic lung disease. Then Calazia et al. Also showed that, interestingly, they showed that the diffusion hypoxia is very less with the xenon rather than it was more with the nitrous oxide. So they compared both the two, and they said there is a lesser diffusion potentially in the hypoxic situation of with the xenon. Then xenon has a with radio labeling, when it was used, it acts as a marker to investigate the central perfusions. And it has a neuroprotective qualities of xenon are also mentioned by in 2009, 2003, and they have been published so many papers, and they showed that it has prevents the auto regulation and maintains it of the auto regulation of the ICP, and it was not increased, and it was always maintained with the xenon anesthesia. If you see the neuroprotective qualities of xenon, it is seen that whenever there is a brain, you can see the diagram, whenever there is a brain insult, it acts on the NMDA receptors, and there is increase in cytoplasmic calcium. But what happens further with the process, you can see that it causes the cell death. So what happens with xenon is it prevents the NMDA receptor, so it prevents the cell death, and this is the main mechanism of the which acts as a neuroprotective quality of xenon. It also xenon enhanced CT scanning is safe if hyperventilation is employed to protect any rise in the ICP. In endocrine and neurohumoral effects, it was shown by the Boomsma. They studied in 1990 that it changes in the level of the changes in the level of plasma adrenaline, NOR-ADR, or cortisol prolactin growth hormone. This is all in the xenon. It is very maintained in the xenon and nitrous oxide, but the decrease or increase is alterations are very less in the xenon anesthesia. And plasma NOR-ADR and prolactin levels increase in both the groups, but ADR, while adrenaline and cortisol increase only in nitrous oxide group, not in the xenon group. Then in the toxic and non-toxic effects of xenon, if you see in the details, it causes the prolonged anesthesia. Used when it was used in prolonged anesthesia, it showed that it does not cause any deterioration in hematological, coagulatory, or biochemical variables. It does not impair the hepatic or renal function. It is excreted by lungs, and in ICU setting, it maintains the blood pressure, and it can be used safely in the sepsis or shocks. It does not cause any malignant hyperthermia. Environmental issues with xenon anesthesia is that it is more possibility is that it causes greenhouse gas effect, and it is very eco-friendly, and it can be used easily. Economic aspect makes it more disadvantageous. What happens is it is quite expensive, and it has been seen that over the studies, it has been seen that the cost is very much high when xenon is used. That's why it doesn't get any gained any importance over that. And the important thing is we should reduce the cost of a xenon anesthesia, and we should reduce the manufacturing cost. You can use the semi-closed or fully closed systems. Then we can use very low flow volumes, that's systems, then it can be done. Then there can be balanced circle system that can be used. Undiscovered sources are there. It has been found that there is another aspect or thought that xenon is somewhere missing also in the environment, and we have to search more on the basis of research that where is that xenon which is present in the air, because in air it is very less amount which is available. So the manufacturing of the xenon becomes very high costed, and the cost is the main factor. The system is very much high, the resources are very less. That's why it makes it less useful for the anesthesia routinely. Other applications are in the illuminations and optics, in lasers, in images, and it has an advantage of rapid. I have already told you rapid induction emergence, so that's why you can use the xenon for the anesthesia. Disadvantage, sometimes it has been found there can be high incidence of post-operative nausea, vomiting, and there can be ability to diffuse into the closed spaces like nitrous oxide. It can also be diffused, and that's why it has to be taken care of in cases of gas embolism or pneumothorax or ileus. And in xenon also increases pulmonary resistance due to greater density and increases the work of breathing, and further it causes the in the cases of severe COPD or other morbid obesity. So conclusion is xenon is being considered as ideal anesthetic agent. Rapid induction emergence is there with it. It has a profound analgesia and hypnotic effect with 30% oxygen. There is an absence of metabolism, non-inflammable, and it is a non-explosive natured element, inert gas. It has low toxicity potential. It's devoid of tetragonic effects. Environmental friendliness is always there with xenon. It produces a highest regional blood flow under anesthesia, so dangers of tissue hypoxia is greatly reduced. It has an organoprotective effect, and it is the only limiting factor of it not using it routinely is the high cost of the gas. And with continuing research and technological advances in research in future, its routine use will be a real possibility. I think this is an ideal anesthetic agent for clinical practice in future. Thank you so much. Thank you so much, sir. Any questions?
So you're not audible. You have to turn on your mic, Dr. Mukesh, sir. You have to turn on your mic.
Yes, yes. Now, is it okay? Yes, sir. It should be audible now.
Yeah.
What is the, you did not mention anything about the delivery system during anesthesia.
No, it is delivered through the basically cylinders, and it's of the light gray colored cylinders, and that can be easily done. But also there are some cylinders with the green caps on the neck that is also manufactured. So routinely, actually, the people are not using it in the anesthesia much because of the high cost. That's why this is the thing. And it is available. It is our 18, it comes around 1840 1840 rupees per kg. So it's very high cost as the availability is very less in the places, and the manufacturing itself causes a high cost because of the less availability in the environment also. So from the air, you take out nitrous oxide, you take different gases, oxygen also, but xenon has very less, 0.0018% is only the xenon. So from there, the overall abundance is very less. That's why the manufacturing becomes less, and that's why it comes into the cylinder forms, and it is in the cylinder form, which is transferred from one place to the other.
You told about ICU setup. In the ICU, you can use it in ICU setup. Which are the situations where we use it?
In ICUs, it is not much in use because inhalational agents we routinely do not use in the ICUs. There are certain ventilators where you can attach the vaporizers in the various different inhalational agents, but that is not of much use, which we have seen over the years in the ICUs.
Thank you very much. Very nice.
Thank you so much. Thank you so much, sir. Thank you so much.
Very much informative. Thank you.
Obliged, sir. Thanks to the organizers also. Thank you.
Can we go to the next session? The team.
Next presentation is by Dr. Mayank.
Please start. Dr. Mayank, please start.
Hello, all my friends and my senior colleagues. I am Dr. Mayank Prasad, Senior Consultant Anesthesiology and Critical Care at CHL Hospital, Indore. In the next 15 to 17 minutes, we are going to discuss about all the important points that are related to the spine surgery, specifically the corrective spine surgeries. So let us start by sharing the screen and go to slides. So, anesthesia for corrective spine surgery, pulse of wisdom. The topic will be covered under the following headings. First, the types of the spine surgeries. Secondly, the organ systems which are affected by the spine disorders. How to prepare, that is preoperative management of the problems. Intraoperative precautions that are to be taken during surgery. And finally, the postoperative management of spine surgery patients. There are various types of spine surgeries that have been done. Minimally invasive disc removals, spine fixations for traumas, correction of a spine, example kyphoscoliosis, and pedicle screw fixation for spondylolisthesis correction. Spinal conditions that require surgery, you could very well make out over here. There is a disc. Over here, vertebra has slipped forward on the vertebra below, and bone defect which causes spondylolisthesis. Spinal stenosis, over here it is lumbar canal. There is a collapsed vertebra which is D12. This is scoliosis. And kyphosis, there is a normal curvature at the level of the thoracic as well as at the level of the lumbar spine. But if there is a lateral curvature of the spine, it is called as scoliosis. And if there is convexity of the spine, it is called as kyphosis. And when both are combined together, it is known as kyphoscoliosis. Laminotomy is there, where we just remove a small portion of the disc and lamina. Laminectomy is there, where we can remove the complete lamina. And discectomy is there, where we remove the extruded disc. We can perform fusion and fixation of the spine. This is pedicle screw fixation. Over here, this is a demonstration of the lumbar spine fixation. Now, correction of the spine surgeries is basically related to the kyphoscoliosis. Now, The kyphoscoliosis could be idiopathic, it could be congenital, paralytic, neurofibromatosis is one of the causes, and mesenchymal. Now, it is extremely important to know what is the corpse angle. We take a PA view X-ray of the affected patient and we draw a line which is perpendicular to the upper border of the vertebra from where the scoliosis has started to the lower border of the vertebra where the curvature ends. These two perpendicular lines are intersected and then we measure the angle. And corpse angle in thoracic spine, if it is less than 30 degrees, they will have less progression. More than 30 degrees will progress by 19 degrees during lifespan. More than 50 degrees, we will progress by 1 degree per year. And angle between 40 to 50 degrees will always require any kind of spine correction surgeries. What are to be remembered before we proceed for the surgery? We go ahead with the airway evaluation, where we see the temporomandibular joint. There could be rheumatoid arthritis, ankylosing spondylitis. Restriction of the leg movements can be there due to the kyphoscoliotic condition. There can be traction or braces in the cervical spine injury. We have to check the stability of the cervical spine also if it is a trauma patient. Now let's talk about the corpse angle again. Over here, you can very well see the corpse angle. This is kyphoscoliosis. It is a restrictive kind of a lung disease. Corpse angle more than 50 degrees will definitely affect the respiratory system. The greater the number of vertebrae involved, more the respiratory system will be affected. Where is the uppermost vertebra located? The higher it is, it will affect more. Patient age. At a younger age, less. As soon as the patient approaches the age of puberty, approximately 14, and still there is kyphoscoliosis and the correction has not been done. Till the age of 18 years, they will have definitely restrictive kind of lung disease. As the thoracic curvature increases, PaO2 decreases, vital capacity decreases, FeV1 decreases, and FVC decreases. When the forced vital capacity is less than 35%, it is a relative contraindication for surgery. We should always postpone the surgery for 4 to 6 weeks for proper recovery of the respiratory function. Cardiac system can be involved because of congenital disorders like cardiomyopathy, congenital heart diseases. There will be cor pulmonale. Why? Because hypoxic pulmonary vasoconstriction is there that will have an effect on the right ventricle, and following that there will be cor pulmonale. Mitral valve prolapse can be there. Patient can be hypertensive. In the case of trauma patient can be diabetic, correction of the spine surgery, and in the case of thoracic trauma, lumbar trauma, when they are doing spondylolisthesis in old age patient, there could be hypertension, diabetes, and coronary artery diseases. Always the neurological system should be examination should be proper. It should be recorded to prevent medical legal complications. In the case of kyphoscoliosis, we have to look for meningomyelocele, spina bifida, muscular dystrophy patient. If there is a muscular dystrophy, we have to look out for bulbar paralysis because these patients have very high chances of aspiration. In preoperative preparation, respiratory system can be optimized by using bronchodilator therapy, adding an antibiotic if there is a suspected respiratory infection. Incentive spirometry exercises should be started 4 weeks prior to the surgery. Patients should be counseled about specifically the wake-up test. I'm going to talk about it. They should be informed about the post-operative ventilation, X-ray of the cervical spine with flexion and extension view if we are going to operate on the cervical spine, and we know that there is a fixed stability. If there is a trauma patient, this is not indicated. We just have to take the X-ray, the neutral position. 12-lead ECG, echocardiography, as I said, in the old age patient, X-ray chest, if required, we can do a CT scan. All this CBC should be there, in which we have to stress upon the platelet count as well as the total leukocyte count and hemoglobin in order to arrange the blood. Clotting parameters should be clear because these patients can be on blood thinners if it is a old age patient. LFT, RFT, serum electrolytes, calcium is important, specifically neoplastic diseases. Sometimes these are chronic patients who are bedridden, so there can be electrolyte abnormalities. Psychological preparation of the patient is extremely important for any kind of surgery. And these patients are in extreme pain if they have trauma. So if there is immense pain in degenerative diseases and cervical spine is not involved, there is no difficulty airway, then we can go ahead with opioids. Otherwise, sparingly use opioids in the case of difficult airway patient. It can lead to respiratory depression. Monitoring to peripheral lines should always be there, large bore. If there is a requirement, then we can place the CVP, as well as core pulmonary is there, we can go ahead with pulmonary arterial catheter monitoring. Always there should be 5-lead ECG monitoring, intra-arterial monitoring of blood pressure, urine output monitoring with the help of Foley's. Temperature monitoring should always be there in the case of prolonged surgery, and we should take adequate measures to prevent hypothermia. Intraoperative somatosensory evoked potential and motor evoked potential monitoring should be there. Capnography, because some of the patients are in prone position, and we should have proper monitoring of the tube position. Anesthesia technique, we can choose the induction technique by deciding upon the patient's medical condition, depending upon the cervical spine stability in the case of trauma, and the airway of the patient if there is temporomandibular joint ankylosis or anything. We can go ahead with inhalational or IV technique. Muscle relaxant, again the same. Succinylcholine or non-depolarizing muscle relaxants can be used depending upon the patient's medical condition and the airway of the patient. There could be a risk of aspiration, and we should always have intraoperative monitoring in place. Anesthesia technique can be, sorry, patient can go for awake or a sleep technique. Awake intubation, there is always a risk of aspiration. We should always have a proper neurological assessment for unstable cervical spine, and neck stabilization devices like halo traction should always be available if we are going for an awake technique. If we know that airway is good and we can open the mouth, then by using the manual inline stabilization or heart collar with the help of McCoy blade or with the help of video laryngoscope, we can achieve normal direct laryngoscopy and intubation. Fiber optic is indicated if there is involvement of upper thoracic spine, where the patient will be very difficult to lie down, specifically in kyphoscoliosis, where there is tremendous damage at the atlantoaxial joint in cervical spine, and patient is wearing stabilization devices such as halo vest, and for purpose of anatomical reasons, for example, limited mouth opening and microagnosia. Anesthesia technique continued, we should always position the patient nicely, check the airway always, maintain a stable anesthetic depth, avoid sudden changes in the anesthetic depth of blood pressure because it can affect the neurological assessment of the patient intraoperatively. We should maintain a constant depth of neuromuscular blocking agent because the patient is in a prone position most of the time and it is a fixed position. We should maintain a MAC of 0.5 for inhalation anesthetic agent, whichever we are using, isoflurane, halothane, sevoflurane, desflurane. We can even use continuous infusion of propofol or continuous infusion of remifentanil or fentanyl with midazolam and following bolus opioids. Controlled hypotensive anesthesia, I'm going to talk about it later. Patient should always be made supine before reversal. We should perform a proper suctioning. Oxygenation should be there. Then we should give the reversal. Extubation can be done on table if the patient is having fully awake and GCS is with full motor power at 15/15 GCS. Or we can put the patient on post-operative ventilator support in the ICU and slowly wean off the patient on ventilatory support. After emergence, the patient should be able to maintain his or her airway, should be fully awake, and should be responding to commands. Now, this is a small algorithm regarding the intubation technique to be followed. Cervical upper thoracic surgery proposed, spine is stable, spine is unstable. If the spine is unstable, direct laryngoscopy is impossible without neck manipulation. Directly go for awake fiber optic bronchoscopy. Direct laryngoscopy thought to be possible without neck manipulation. Consider direct laryngoscopy with manual inline stabilization or a sleep fiber optic bronchoscopy, or we can go ahead with intubating element. If the spine is stable, Direct laryngoscopy, again, we have to be considered whether it can be difficult, risk of aspiration, yes, awake, no, consider fiber optic, awake, a sleep technique and intubating element. Direct laryngoscopy expected to be easy. Go ahead with whether there is any risk of aspiration or not. Yes, succinylcholine is the induction agent of choice with direct laryngoscopy. No, IV induction with the help of non-temporizing muscle relaxant and direct laryngoscopy. Prone position. Most of the patients are performed in prone position. Sometimes we can have to apply, in the case of supine position also, we have to apply head traction in cervical spine and lateral position of the head. Occasionally, it could be a sitting or lateral decubitus position or for the purpose of attractoaxial joints. This is usually the position. You could see if the patient is on pins. Induction and intubation is always in supine position. We should require people to shift the patient as a log of wood into prone position, at least 4 people. Place the neck in neutral position, as well as head should be turned to the side if required, to the normal range of motion or face down on a cushioned holder. Arms should always be at the sides in a comfortable position. We should avoid excessive abduction at the shoulder and elbow should be flexed. Chest rolls should always be placed on parallel rolls or foams or special support to facilitate ventilation. Abdomen is clear, otherwise it will result in high airway pressure. All the endotracheal tubes as well as the connections and attachments should always be checked. Bilateral breath sounds should be checked. What are the problems that we face? Edema of the upper airway in prolonged cases. Sometimes endotracheal tube can kink or get dislodged. There could be occlusion of the arterial or venous vessels. Femoral vein can be kinked because of marked flexion and there could be thrombosis that could result. We should take precautions for DVT in prolonged surgery, like DVT pumps. Because of increased abdominal pressure, there will be higher chances of bleeding because of epidural venous pressure. There could be pressure necrosis of the elbow joints in the case of breast in the case of females, genitalia in the case of males, nose and ear. Monitor disconnections as well as endotracheal disconnections and dislodgements are also extremely common, and we should always carefully manage them before proceeding with the surgery. We should always use Jackson table or Wilson frame. Eyes should be padded and covered. Adequacy of ventilation with the help of abdomen free should be checked. Preformed headrest and pillows are the best under the leg. Now, blood loss depends upon the number of vertebrae that are fused, the surgical time, if the bone graft is taken from the hip or not, if there is increased abdominal pressure, as I said, epidural, and there could be consumption of the coagulation factors because of hypothermia. We can reduce the blood loss by modification of surgical technique, reducing the surgical time. Proper prone position that will reduce venous congestion. We can use techniques like hypotensive anesthesia, autologous blood transfusion, as well as acute normovolumic hemodilution. Or we can use cell saver. We can use epsilon aminocaproic acid, and we should avoid fluid administration at very high level till instrumentation is complete. In autologous blood donation, the patient donates 2 to 4 units of blood preoperatively, and it is stored in the blood bank and given to the patient at the time of surgery after the instrumentation. This will reduce the risk of HIV as well as blood-borne infections. In normovolumic hemodilution, blood is removed from the patient in the operative room and replaced with the help of colloid or crystalloid. 3 ml for the purpose of colloid and 1 ml for the purpose of blood. 1 ml for the 1 ml of blood, 3 ml of crystalloid for 1 ml of blood, and a desired post-hemodilution hematocrit that is achieved is approximately 30%. The venous blood is returned to the patient at the end of surgical procedure. Controlled hypotensive anesthesia, it is the elective lowering of the arterial blood pressure. Why it is used? To minimize the loss and for proper visualization. What are the techniques? Proper position, positive pressure ventilation. The best drugs that are being used right now are sodium administered like sodium nitroprusside, nitroglycerin, infusions of propofol. We used inhalational agents like halothane, isoflurane, desflurane, sevoflurane, dexmedetomidine, beta blockers. What is the safe level in healthy young individuals? It is 50 to 60 millimeters of mercury, mean arterial pressure, which is well tolerated. But in the case of chronically hypertensive patients, they have altered autoregulation of cerebral blood flow, and mean arterial pressure should not be less than 25% of the baseline. If there is a transient ischemic attack history, we should not use this technique. Relative contraindication are severe anemia, cerebrovascular disease, uncontrolled glaucoma, renal and hepatic insufficiency, and atherosclerotic vascular disease. Now, complications that can occur are kidneys can be affected, tubular necrosis, brain can be affected, cerebral thrombosis leading to hemiplegia. There could be heart, myocardial infarction, cardiac arrest, retinopathy, which is retinal artery thrombosis, or ischemic optic neuropathy. What are the monitoring techniques? ECG, 5 leads, ECG monitoring, CVP monitoring, measurement of urine output, monitoring of neurological function. Intra-arterial blood pressure is the gold standard for monitoring of controlled hypotensive technique. There could be injuries to the eye in the form of aberrations, corneal, orbital edema, or postoperative visual loss. Postoperative visual loss is a very devastating complication. Common causes ischemic optic neuropathy, central retinal artery occlusion, and in some 6% of the cases, it is unknown. Wake-up test is a very important test. This was first developed by Stagnara wake-up test with the help of anesthesiologist M.M.E. Bazule. It is the gold standard, oldest method, and how it is done, and why it is done. It is done to evaluate the gross functional integrity of the motor pathway. We do a lighting of anesthesia at appropriate point during the procedure, and the anesthetic requirements that we use are a continuous infusion of propofol technique can be used, as easy and as rapid to institute as possible. Waking should always be smooth. No pain should be tested. There should be psychological preparation of the patient preoperatively that you will be woken up. There will be no recall, and it will be immediately. Patient should be put under deep sleep. How can we do it? Volatile-based anesthesia by using sevoflurane, midazolam-based anesthesia, infusion, remifentanil or propofol-based anesthesia. It requires patient's cooperation, poses the risk of falling from the table and extubation. It requires practice. It prolongs the duration of surgery, provides information at the time of wake-up only, and never will assess the sensory pathway. This is very important. Somatosensory evoked potential. It is the most common neurophysiological method of monitoring. How it is done? Stimulus applied to tibial or ulnar nerve. The recording electrodes are placed in the cervical region or scalp or epidural space during surgery. Always a baseline data is obtained after the skin incision, and the responses are recorded intermittently during the surgery, which is considered significant reduction in amplitude by 50% or increase in latency by 10%. But it will test only the dorsal column function and not the motor function. Rarely, postoperative neurological deficit will present despite preservation of SSEP because it is not monitoring the motor pathway. Indications for this are spine instrumentation like pedicle screw fixation, scoliosis correction, or spinal cord operations like tumors. Satisfactory monitoring of early cortical SSEP is possible. We have to keep the back of sevoflurane, isoflurane, or desflurane at 1. Nitrous oxide will definitely potentiate the depressant effects of volatile anesthetics. Intravenous anesthetists will not affect SSEP, but they affect less. Etomidat and ketamine increases cortical SSEP. Clinically unimportant changes in SSEP latency and amplitude after administration of opioid. This is a very important line. Now, implications, how can we improve it? Eliminating nitrous oxide is a very good thing. It has been shown to improve cortical amplitude sufficiently. SSEP latency will take 5 to 8 minutes to stabilize after the step changes in volatile anesthetic concentration. Adding etomidat, propofol, or opioids is preferable to beginning nitrous oxide or increasing volatile anesthetic concentrations when the anesthetic depth is inadequate. If a volatile anesthetic is nevertheless needed rapidly, sevoflurane permits faster SSEP recovery after the acute need for volatile anesthetics has been resolved. So the anesthetic of choice with SSEP volatile is sevoflurane. We should always avoid sudden changes in volatile anesthetic depth or bolus administration of intravenous anesthetics. Surgical manipulation that could jeopardize the integrity of neural pathways being monitored. Motor evoked potential is stimulated by electrical or magnetic means, neurogenic responses, peripheral nerve or spinal cord, and biogenic responses also. Inhalation anesthetic will definitely suppress motor evoked potential in a dose-dependent manner. Paired pulses or train of pulses cannot overcome the suppressive effects. Nitrous oxide appears to be less suppressive than innate agent. Moderate doses up to 50% of nitrous oxide have been used successfully to supplement other agents. Fentanyl, ethominate, ketamine have little or no effect on biogenic evoked potential. Benzodiazepine, this is a bad news. Benzodiazepines, barbiturates, and propofol also produces marked depression of biogenic MEP. However, successful recordings have been obtained during propofol anesthesia by controlling serum propofol concentration and increasing stimuli rates. Now, propofol is the best agent for IV use. Over there is inhalation anesthetic agent sevoflurane. Now, biogenic MEPs will definitely affected by the neuromuscular blockade. We can adjust the continuous infusion of muscle relaxant so that 1 or 2 twitches or train of 4 can be achieved. Motor stimulation can elicit movement and this can interfere with the surgery in the absence of neuromuscular blockade. Temperature, systemic blood pressure, PaO2 and PaCO2. All these 4 factors will definitely affect somatosensory evoked potential as well as motor effect potential, and they should be controlled during intraoperative recordings. Now, spinal cord injury can occur after surgery. It depends upon the spinal cord perfusion pressure. As I said, it is extremely important to maintain 60 millimeters of mean arterial pressure. What is the pathology of the spine? How much duration we have taken in the surgical procedure, and whether there is any pressure on the neural tissue during surgery or not. Neurological damage can occur during the surgery, and anesthesia is not limited to site of injury. There has been report of paraplegia and quadriplegia because of poor positioning. There are reports of patients with spinal diseases who have suffered neurological damage either at levels remote from the site of injury or during surgery. Neurological damage is more likely at or near the site of surgery on the spine. Conditions of increased risk, we are using induced hypotension, inadvertent cord compression, Luke rods, ligation of segmental arteries. We are using spinal distraction techniques or sublaminar wiring. Hypothermia. It is important to maintain a temperature of 37 degrees as it will prevent coagulopathy, bleeding, and proper monitoring of SSEP. Risk factors for post-operative airway compromise are amount of blood transfusion, obesity, operations of more than 4 cervical levels or involving C2, duration of the surgery. Conclusions are: understand and appreciate the anatomy and physiology of the spinal cord. Communicate with your surgeon. It is a team effort. Always explore new techniques, and we should use those techniques to maintain the proper perfusion and monitoring of the patient. Now, post-operative pain management is a very important component. Intravenous PCA with morphine at a loading dose of 0.05 to 0.1 milligram per kg in the background, and infusion of 0.01 to 0.02 milligram per kg per hour has been recommended. Side effects: pruritus and post-operative nausea and vomiting can be easily controlled. Epidural analgesia, dexmedetomidine is now a gold standard for purpose of post-operative pain management. Ketamine as an infusion of 10 milligram per hour has been definitely used. Intrathecal opioids applied at the time of surgery with the help of injection morphine. Gabapentin preoperatively, acetaminophen, high doses of ketorolac to be avoided, because specifically in the case of cancer patients. Continuous wound infiltration with the help of local anesthetic, single dose of dexamethasone and erector spinae block have been used. Regarding a word about the post-operative ventilation, we can keep these patients on post-operative ventilatory support, and as soon as they can recover, then we can extubate them. Thank you so much for pleasant listening.
Thank you very much. Very nice and informative article, your presentation. Any question? Okay. Now we go to the next topic. Dr. Geeta.
Thank you so much, sir. Thank you so much, Vakil, sir. And thank you so much to the organizing team. Thank you.
Thank you very much. Can you start, Dr. Geeta?
Yes, sir.
Okay.
I think
It will play now, sir.
Greetings from MS Ramaya Medical College, Bangalore. I'd like to thank the organizers for this wonderful opportunity. I also would like to congratulate them for bringing forth this hybrid conference, which is one of its kind to us all. I'll be talking about simulation-based anesthesia training. Dealing with these headings, to err assume was a report or an article written in 1990 by the US Institute of Medicine, which reported that 98,000 patients died every year due to preventable medical errors. And these preventable medication errors was medication errors, procedural errors, identity errors, and in fact, in some knowledge deficits as well, which was very alarming. And Hippocrates, whose oath we swear on, stated that first do no harm, which kind of emphasizes on minimizing medical errors and increasing patient safety. The traditional learning has always been see one, do one, and teach one. However, there's been a paradigm shift to teaching medical education, which says that observe some, practice several, and then perform. All this in the background of team approach to improve patient care and patient safety. Talking about history of medical simulation, Mrs. Chase was the doll developed by Chase Hospital in 1911. Was the first simulation doll where we used it. But however, it's Lardell's Risa Sani, that's the most famous one. Then there have been a lot of additions to it. And in 1986, a comprehensive case, anesthesia case, which is a comprehensive anesthesia simulation environment, was set up by Dr. David Gaba, who's pioneered the advances of simulation in anesthesia training. And then ever since then, there's been a lot of innovations and technologies that's been put forth. And the recent Lardell simulation and Simman 4G is as close to human as possible. And in this context, we must mention about Joseph Lindy in 1920. He set up an anatomy clinic with a protocol-based teaching of anatomy, which kind of improved the performance of regional anesthesia technique in the students. And also Jeffrey Cooper emphasized on minimizing human errors, which led to the formation of Anesthesia Patient Safety Foundation, which has conferences every year, comes out with recommendations to decrease these non-medical errors. And about simulation in medical education, in the 1980s, anesthesia educators, that is Dr. David Garba and his colleagues, extensively studied the simulation in aviation industry. And in fact, aviation industry was the first to kind of adapt or incorporate simulation in them. And they used crew resource management, and they kind of worked on it and used the same thing to train and for anesthesia training, and renamed it a little, calling it the anesthesia crisis resource management. And this led to kind of transform the healthcare education system. And it is simulation, in fact, is a technology for the future for competency testing and also continued education. There are various types of simulation. We've always used sometimes a standardized patient, which has been used in the FRCA exams. Then there's a screen-based computer, but this is very one-dimensional, and partial task simulator, which kind of uses examples of pericardiocentesis or CVP or intubation mannequins, which kind of hones your skills, and these still have a place. In addition to that, we have the high-fidelity mannequin simulator and virtual reality, which is the way to go in future. These high-fidelity mannequins are mannequins with electrical and pneumatic functions given by a computer. Lardell and Metty are the most common, the most famous one that we use. And there are adult, pediatric, child, and in fact, there's some mom as well. to use the obstetric care, and it can perform every physiological function that's there in the humans. And it also allows you to do every possible procedure that you could do on the patient. And virtual reality is an advanced form of human-computer interaction which allows humans to work in the computer world, but it is experimental, mostly used in some private sectors. And we have one of its kind about the intubation thing. And you have various apps that's there, and this is virtual reality as well. And when it comes to anesthesia, it's a very hands-on specialty, probably the most hands-on kind of specialty of all the medical practice. And various tasks of patient care is performed. And in fact, the anesthesia work is, very famously, some of us surgeons joke with us, calling hours of boredom with moments of terror. But it is in these moments of terror that we need exceptional skill and vigilance. And it may not be possible to experience all the crisis situation. And that is the reason why simulation gives you a safe environment, impossible to imagine in real life, to kind of improve patient care and safety, and also teach the trainers, trainees. So, and in this regard, anesthesia has been the forefront in using simulation training. Benefits of simulation is that the patients are not exposed to complete novices. It's a safe environment where you can do mistakes and you can learn from them. Complexity can be altered based on the needs of the patient and what you want to test. And self-efficacy can be built, and students can repeat it as often as they can, and they learn at their own pace and also express their fears and difficult questions in certain situations. When it comes to hierarchy of learning, supervised clinical practice and feedback is on the top. But however, it's not possible to create every critical incident or to experience every critical incident. And that is the reason why learning and simulation with feedback forms the next best thing that's available to train at your own skills to the trainees. In adding, it's just not the technical skills that should be learned. It is the non-technical skills that are as important as the technical skills. These involve the interpersonal skills like communication, teamwork, and leadership, and also cognitive skills like situational awareness and decision making. And in fact, Atul Gawande, in his novel Complications, he analyzes the adverse incidents, and he said the majority of them were non-technical skills like communication failure, team failure, and poor leadership. And what does this tell us? It tells that the teams that are going to work together should practice together, should have something known as to who does what instead of a chaotic situation being there. And that is the background of teaching simulation. And this communication skills is normally in the crew. This is what I was talking about. The aviation industry uses SBAR technique of communication, which is situation, background, and assessment and recommendation. And this has been used in anesthesia crisis management as well with great success. Application of simulation is in the education, training, and research. For education, it can improve knowledge and conceptual understanding. In fact, it can be used in the undergraduates as well, because it's a very novel field to them, and it is just very abstract if you're trying to teach. So in preclinical, you can teach them about applied physiology and pharmacology. Clinical basic anesthesia can be taught, and patients with various illness, it's just not pertaining to, focused on anesthesia as well. You can use it for any field. And particularly for training of postgraduates in anesthesia, it can be used about introduction to anesthesia, and patients with various degree of illness and various type of critical situations that can occur, they can be taught as to how to deal with it. Training, it enhances performances, and it has got something for everybody. For a novice resident, you can teach the basic airway management and routine abnormality. and they should learn to call for help, which is a great thing, to know. And this is what we've been talking about when we were just asking clinical scenario-based questions, and this we actually see what they do in a critical situation. Experienced residents can have advanced airway management and also the anesthesia crisis resource management, give a full-fledged critical incident. For the experienced anesthesiologist, it can get a hands-on training of the effect of the new drug, familiarity and safety of using it, use of new monitors and new skills. It can be used for research as well. You can have research coming out on simulation, that is testing or improving techniques, technologies. Research that uses simulation as a tool to study the human performance, clinical cognition. This is to test the non-technical skills. And in fact, it can be used as a method to see improved methods of debriefing. We'll talk about it later, about what debriefing is, different methods of debriefing, and methods of simulation scenarios as well. And this is something which, assessment, this is something which many of the medical schools and the residency programs have adapted it. In fact, USMLE, the Canadian Board of Certification, and the Royal College of Anesthetists have used simulation-based scenarios to assess trainees. And what about RNMC? In fact, we're getting there. This NMC is mandated setting up of skills lab in every medical college. And it, in fact, has become a big NC if they do not have a skills lab. And I think we're getting there that about 50% or more than 50% have set up some kind of skills lab. And now with the CBME, that is the competition-based medical education being adopted, and the undergraduates have already reached phase 3, and CBME curriculum is going to be adapted in postgraduate teaching as well from the coming year. So this skills lab setting up and scenarios, teaching them about it or training them based on this before letting them out to practice on patients is the way to go in future. And what about how skills lab look like? This is an ideal skills lab where, it's a huge area. We may not have the full area to do, or at least a simulation room with a debriefing room should be there. And about the structure of fusion simulation scenario, you should have the trainers, that is us. Trainers should have some kind of a training to go as to how to conduct simulation scenario. So you should have a pre-briefing, then actual scenario, then the debriefing, which is the reflection with highest potential for learning. This occupies the majority of the simulation training technique. Debriefing is in fact the heart and soul of simulation-based training. It is facilitated guided reflection in the cycle of experience and learning. This is the highest form of learning. This is not a fault-finding session. It is about what they have done, what could have been better, and where did they lack, and why was that lack there. And so kind of try to fill in the gaps in their knowledge deficit. Do we have evidence that simulation works? Yes, there has been a screen-based anesthesia simulation which have shown that residents who participated in these exercises outperformed their counterparts who did not. And the simulation can be an effective replacement for live practice of some skills. And team behavior can be affected by focus simulation experiences as well. This has been proven beyond doubt. And to conclude, I would say that anesthesia encompasses all three, and in fact, any medical knowledge would say knowledge, attitude, and skills. All three domains can be taught with simulation, which may or may not be possible in without simulation. You can talk about patient care, improve their medical knowledge, practice-based learning, interpersonal and communication learning, and in fact, it can be used as a mode for assessment, which will make it more uniform and is a way to go in future. And this will also increase professionalism. And it is just not for the students. It can be for the experienced anesthesiologists as well, because there's always scope for learning. And I would like to end saying that by the famous quote by Confucius, who said, I hear, I forget, I see, I remember, what I do, I understand. This kind of is very appropriate to describe the modern educational school of simulation. With this, I end my talk. Thank you for the opportunity once more to the organizers. And if there are any questions and comments, I'll be able to take them.
Thank you, Dr. Gita. Very informative.
Thank you.
Very
Sir.
nice.
Thank you. Sir.
Any question from anywhere? Can I ask one question, Dr.
Yes,
Gita?
sir.
How much
Sure,
cost? How costly it would be for the institute to apply this?
Sir, if you're looking at the ladle Simman that we have, I think setting up the place and the Simman itself would cost about 2 crores, I think, sir.
Okay.
The whole thing.
Okay. Right. Thank you.
Thank you.
Thank you very much.
Thank you, sir.
Can we go to the next article? Next presentation.
Hello everyone, I am Dr. Poonam Ghorki. At the outset, I would like to thank Team Isacon for inviting me here today to speak upon supraglottic airway devices in upper GI endoscopies. Although endoscopies are considered as daycare procedures, there are quite a few deaths reported in these procedures, thereby making the anesthetic management critical. The most common cause of death in GI endoscopies is the hypoxemia. This hypoxemia could be because of insufficient ventilation from the airway obstruction. It could be from hypoventilation due to indiscreet use of sedation, or it could be from aspiration. In that case, it becomes fatal. And therefore, the goals of anesthetic management going for these cases should be as follows. First of all, the airway patency should be maintained, which is very, very important. Secondly, if possible, one should be able to provide positive pressure ventilation. And lastly, from the surgical point of view, the device that the anesthetist is using should not intervene with the procedural space. Although the topic given to me is supraglottic airway devices, I thought why not just have a brief overview of all the devices that avoid airway intubation in these procedures. Techniques such as apneic insufflation, oxygen by cannula, or HFNO are also techniques used for anesthetic management or providing oxygenation in these cases. And most of the devices that are there have been modified to suit the need and avoid the intubation. What are these airway devices? So we will have a quick overview of these devices. The bite blocks. There are various bite blocks that are being used for these procedures. For example, the Godras bite block, the RESPA oxygen delivery bite block, and the OxyShield. So these bite blocks are modified to have a channel for the introduction of the endoscope. At the same time, oxygenation is possible. Then there are certain face masks that have been developed and modified for the use in endoscopies. So these are the procedural oxygen masks, which can be improvised by just adding the non-breathing face mask, thereby improving the oxygenation. Then there are the DAS endoscopic masks or the BBM endoscopic masks. So these endoscopic masks that not only are used for endoscopies, they can also be used for procedures like fiber optic bronchoscopy or even TEE. You can see how the face mask is applied, and simultaneously, while doing the endoscopy, one can also give positive pressure ventilation in these cases. Then the airway. Here we are going to talk of the nasopharyngeal airway. This is the technique that I use most commonly in procedures, not only for supraglottic airway devices, but in certain cases where I would like to avoid intubation. So here the nasopharyngeal airway and an assembly is created so that positive pressure ventilation can be given anytime it is deemed necessary. So here you can see the patient is being put upon a nasopharyngeal airway, and the endoscopy can be carried out, and you can also attach the EtCO2 monitor. You can see the graph also comes very well with such kind of assembly. So coming to the main topic, which is supraglottic airway devices, we are not going to have a debate upon which supraglottic device is superior to the other, although the conventional supraglottic airway devices have also been used in endoscopies. The success rate has been very, very low. So today we are going to focus upon these two main supraglottic airway devices which have been developed and modified specifically for the use in endoscopic procedures. The first one is the gastrolaryngeal tube and the second is the LMA gastro airway. We all know about the laryngeal tube as a supraglottic airway device. Having said that, laryngeal tube should not be classified as a supraglottic airway device because it does not sit upon the glottis like our LMA does. It is rather an extraglottic airway device. So GLT, that is gastrolaryngeal tube, is a modification of this laryngeal tube. So here, as you can see, the laryngeal tube has a blunt distal end that goes into the esophagus. It is kind of a shortened or a modified combi tube. So this is the anatomical placement of the laryngeal tube. And the oxygenation is carried out through the main opening or the channel through the ventilation ports that sit above the larynx. So this has been modified to form the gastrolaryngeal tube as this. So now through the main channel through which the oxygenation was carried out is now dedicated to the endoscopy, and oxygenation is carried out through an additional oblique lumen, which is this, the ventilation lumen. So from this, the gases or the oxygen will enter and exit through this ventilation holes that lie in front of the larynx. And now instead of the blunt end, this is opened up for the facilitation of the endoscope to pass through. So here also there are two cuffs. There is an inbuilt bite block. So this is the GLT in use. The endoscope is passed to the main channel and oxygenation is carried out here. And from here, the ventilation will be done. And this is the exit port. This is how it is done in the lateral position. What are the features of GLT? Like I mentioned earlier, similar to laryngeal tube, this is also an extraglottic airway device. There is a dedicated channel for endoscopy, and it permits the passage of 13.8 millimeters of endoscope. However, because it is an extraglottic airway device and a little bit intervening, there is incidence of sore throat that occurs with GLT similar to that with the laryngeal tube. The second is the LMA gastro. Now, as can be seen in this picture, the familiarity of this device itself is an advantage. It is quite similar to the LMA that we use. So the structure is the same. Instead, there are now two channels. So just like how we have the double lumen tube, this is a kind of double lumen LMA. So these two channels run in parallel. So now this is the endoscope device will be inserted to this channel. And here we have the oxygenation channel. So they lie in parallel. So this is the anatomical position. It is placed in the similar fashion as we do our classical LMA. So this is where it is placed, and the endoscope will pass through the channel, will exit here. Again, there is a bite block, and this is the oxygenation port. What I want you to focus upon is this cuff over here. It is very classical for the LMA gastro. We will be discussing this cuff in detail. What are the features of the LMA gastro? So this is how it is positioned anatomically and is being used. So it is a dual channel airway. The endoscopic channel is wider. It will permit 16 millimeters of endoscope to be passed through. There is the cuff pilot technology. So this is the cuff pilot technology. This technology enables constant visualization of the pressure inside the mask cuff. So there is a black line over this cuff pilot. And in ideal situations, when the pressure is around 40 to 70 centimeters of water, the black line is supposed to be in the green zone over here. If it is in the yellow zone, it indicates a lesser pressure, less than 40 or 20 centimeters of water. And if it is in the red zone, it indicates a high pressure, more than 70 centimeters of water. So this is very typical and peculiar in the LMA gastro that increases its safety. What are the advantages of LMA gastro? First is, like I mentioned, it is structurally similar to the classical LMA, so it becomes more user-friendly. Insertion of this LMA is possible in lateral and prone position. There has been an inbuilt bite block that is present in this LMA. It has a dynamic flexibility. So once inserted, also the patient can be shifted to lateral position or even prone position for carrying out the procedure. And as we discussed in detail, it has the cuff pilot technology. So this is in short summary about the devices that are being used other than the intubation. So right from HFNO to the bite blocks to the face mask and the nasopharyngeal airway, what we discussed here in detail were these two, the gastrolaryngeal tube and the LMA gastro. Certainly there are advantages towards the other devices. The only limitations could be Like for any other supraglottic airway device, this would require general anesthesia or deep plane of anesthesia for insertion. So to summarize my topic, one has to know that the main cause of death during GI endoscopies is from hypoxia and hypoventilation. Therefore, the anesthesia core management has to be very crucial. The anesthetic technique could extend from a safe sedation and monitored anesthesia care to securing the airway with intubation. So you have an array of possibilities for providing the anesthesia to these procedures. Supraglottic airway devices are distinct to be used in endoscopies, and putting them is both an art and science because you have to be skillful enough to put in the SGD. At the same time, you have to have a knowledge about the airway physiology. And lastly, whatever technique you are using, caution should always be observed. Thank you so much for your patient hearing. And again, I would like to thank Team Isacon for inviting me here today. Thank you so much.
I think there's been some problem, no? There's some issue.
Maybe
Yes, ma'am, the relay has been stopped.
with the chairperson joining us. We'll connect with them.
Okay, I think there's been some very nice talk, Poonam.
Thank you, ma'am. You also enjoyed all the talks today, actually.
Yes, it was. Congratulations. I think if there isn't anything, I think there's one more talk, no?
Yeah, actually, there was one talk even before my lecture. I don't know. Mine started just suddenly.
Okay. Technical team, are you there?
Yes, ma'am.
Yeah, I think there was one more talk and the chairperson's communication has been.
Yeah, ma'am, we are communicating with them. We are trying to get them.
All right, okay.
Dr. Mukesh, are you there?
Hello.
Sir, you left somewhere in the presentation. So should I play the presentation from the starting?
No, no. Can you from the halfway?
Okay, sir. Okay. Just tell me where to start. From where to start?
But I can't see.
One second, sir.
So you can start from the halfway. Yes, yes. No, even beyond that. Still beyond. Okay, okay. Fine, fine, fine.
What are the features of GLT? Like I mentioned earlier, similar to laryngeal tube, this is also an extraglottic airway device. There is a dedicated channel for endoscopy, and it permits the passage of 13.8 millimeters of endoscope. However, because it is an extraglottic airway device and a little bit intervening, there is incidence of sore throat that occurs with GLT, similar to that with the laryngeal tube. The second is the LMA gastro. Now, as can be seen in this picture, the familiarity of this device itself is an advantage. It is quite similar to the LMA that we use. So the structure is the same. Instead, there are now two channels. So just like how we have the double lumen tube, this is a kind of double lumen LMA. So these two channels run in parallel. So now this is the endoscope device will be inserted to this channel. And here we have the oxygenation channel. So they lie in parallel. So this is the anatomical position. It is placed in the similar fashion as we do our classical LMA. So this is where it is placed, and the endoscope will pass through the channel, will exit here. Again, there is a bite block, and this is the oxygenation port. What I want you to focus upon is this cuff over here. It is very classical for the LMA gastro. We will be discussing this cuff in detail. What are the features of the LMA gastro? So this is how it is positioned anatomically and is being used. So it is a dual channel airway. The endoscopic channel is wider. It will permit 16 millimeters of endoscope to be passed through. There is the cuff pilot technology. So this is the cuff pilot technology. This technology enables constant visualization of the pressure inside the mask cuff. So there is a black line over this cuff pilot. And in ideal situations, when the pressure is around 40 to 70 centimeters of water, the black line is supposed to be in the green zone over here. If it is in the yellow zone, it indicates a lesser pressure, less than 40 or 20 centimeters of water. And if it is in the red zone, it indicates a high pressure, more than 70 centimeters of water. So this is very typical and peculiar in the LMA gastro that increases its safety. What are the advantages of LMA gastro? First is, like I mentioned, it is structurally similar to the classical LMA, so it becomes more user-friendly. Insertion of this LMA is possible in lateral and prone position. There has been an inbuilt bite block that is present in this LMA. It has a dynamic flexibility. So once inserted, also the patient can be shifted to lateral position or even prone position for carrying out the procedure. And as we discussed in detail, it has the cuff pilot technology. So this is a short summary about the devices that are being used other than the intubation. So right from HFNO to the bite blocks to the face mask and the nasopharyngeal airway, what we discussed here in detail were these two, the gastrolaryngeal tube and the LMA gastro. Certainly there are advantages towards the other devices. The only limitations could be, like for any other supraglottic airway device, this would require general anesthesia or deep plane of anesthesia for insertion. So to summarize my topic, one has to know that the main cause of death during GI endoscopies is from hypoxia and hypoventilation. Therefore, the anesthesia core management has to be very crucial. The anesthetic technique could extend from a safe sedation and monitored anesthesia care to securing the airway with intubation. So you have an array of possibilities for providing the anesthesia to these procedures. Supraglottic airway devices are distinct to be used in endoscopies, and putting them is both an art and science because you have to be skillful enough to put in the SGD. At the same time, you have to have a knowledge about the airway physiology. And lastly, whatever technique you are using, caution should always be observed. Thank you so much for your patient hearing. And again, I would like to thank Team Isacon for inviting me here today. Thank you so much.
Thank you, Dr. Poonam. Very nice article. It seems that the supraglottic device that you described, the principle is to pass the endoscope through the device.
Yeah, right, sir.
Right. So the endoscopists may have to be acquainted with that because usually they are not acquainted.
Right.
So that is a good one, a good thing. Thank you.
Yeah, it does not interfere with their procedure, so they should be happy with it rather.
Right. Thank you. Very
Thank you. Thank you, sir.
Can we start the next presentation, please? Dr. Anchal Kakkar, yes, please.
Hello, everyone. I'm Dr. Anchal Kakkar. I'm Associate Professor in ABVIMS and Dr. RML Hospital, New Delhi. Today, the topic of my talk is autoflow ventilation in laparoscopic surgeries. So the objectives of my presentation over here are what are the physiological changes which are caused by laparoscopy and why we are so concerned about the ventilation in these surgeries? What are the common modes which are used for ventilation? What are the ventilatory protective strategies and why they are used? And lastly, but not the least, autoflow ventilation, its definition, how it works, and what are the advantages. So if I have to tell you that laparoscopy has probably invaded all kind of surgeries nowadays, starting from thoracic surgeries to gynecological, GI surgery, urology, even some vascular procedures and bariatric surgery. So what happens is there is insufflation of gas into the cavity. If it is peritoneal cavity, then gas is insufflated under pressure. It separates the abdominal wall from the visceral organs. The insufflation of this gas is initially started at 4 to 6 liters per minute and then maintained at 200 to 400 milliliters per minute. The usual intra-abdominal pressure in adults, which is maintained during the procedure, is 12 to 14 millimeters of mercury. However, in certain individuals where lesser pressures are demanded, it can be reduced up to 10 millimeters of mercury. So this insufflation actually brings about physiological changes. That is why these laparoscopic surgeries sometimes becomes very challenging. So what are the physiological changes? These can be broadly divided, the causes of physiological changes can be broadly divided in 3 categories. First one is because of the insufflating gas, that is carbon dioxide. Second one is pneumoperitoneum, that is increased intra-abdominal pressure. And third one is because of the patient positioning. So let me just tell you that carbon dioxide is the commonest gas which is used for laparoscopic abdominal procedure. So what are the physiological changes caused by this insufflating gas? We all know it is hypercapnia. What is hypercapnia? It is increase in the partial pressure of carbon dioxide in the arterial blood. Why does this happen? It happens because there is an increased absorption of carbon dioxide from the peritoneal cavity where it is inflated, which is there. Why the CO2 gets absorbed? Because it has a high diffusibility and solubility coefficient. It is highly diffuse. It is very high in diffusion. Larger the area of peritoneal cavity, more is the absorption of carbon dioxide. More the perfusion of the wall of the abdominal cavity, more of the CO2 is absorbed. Hence, both the things causing higher PaCO2 and hence hypercapnia. Also, ventilation perfusion mismatch is happening because of the insufflation, because abdomen is distended, and patient positioning sometimes also hampers the ventilation perfusion. Second is the pneumoperitoneum. Pneumoperitoneum per se actually has its effects on almost all the systems of the body. But because we are talking about the ventilatory strategies, I will just talk about the respiratory system. So in respiratory system, when the pneumoperitoneum happens, what happens? The diaphragm is pushed up. This pushing up of the diaphragm, it has multiple effects. It decreases the thoracopulmonary compliance by 47%. It decreases the functional residual capacity by 30 to 50%. It increases the chances of atelectasis. It increases the peak airway pressure up to 50%. It increases the plateau airway pressure up to 80%. So all this actually causes increased chances for hypoventilation and hypercapnia. This FRC, we all as anesthetists are aware that FRC is of great importance to us. A word about it is FRC is the amount of air remaining in the lung after normal expiration. So this amount of air actually maintains it's a reserve of oxygen in our body. And there is closing capacity. What is closing capacity? It is the lung volume at which the smaller airway begin to close, preventing further expulsion of gas from the alveoli and exchange of gas. So normally FRC is more than closing capacity. But if FRC decreases due to certain causes like laparoscopic pushing up of diaphragm, then FRC can actually become less than closing capacity. This change can cause hypoxemia. So CO2 absorption causes hypercapnia. This fall in FRC because of the pneumoperitoneum can lead to hypoxemia. Third thing which causes physiological changes is the position. Most of the procedures are done in Trendelenburg position. This position is steep head low position. This further pushes up the diaphragm, decreases the functional residual capacity, total lung capacity. It decreases the pulmonary compliance. It increases the chances of atelectasis and further enhancing the chances of hypoxemia. This position also increases the peak airway pressures. So all in all, in nutshell, if I can say and summarize that what are the respiratory changes, pulmonary changes caused by laparoscopic surgery, it is decrease in FRC, decrease in total lung volume, decrease in pulmonary compliance, increase chances of atelectasis, and increase in peak and plateau airway pressure. So what I have to do? What is my plan of anesthesia? So the choice of anesthesia is balanced general anesthesia with endotracheal intubation and controlled ventilation. This is the safest and recommended way in inpatient, especially for long laparoscopic surgeries. For shorter laparoscopic surgeries, this endotracheal intubation can be replaced by the supraglottic airway device, but for longer duration, endotracheal intubation is the choice. Now, I have intubated the patient. How do I ventilate these patients? Because I'm aware that laparoscopy is going to cause changes which can initiate hypercapnia and hypoventilation. So there are three modes, usually rather two modes: volume control mode of ventilation and the pressure control mode of ventilation. Third one is the newer mode, which is auto ventilation with control volume. We all are very familiar with the volume control mode. In this, there is a fixed tidal volume which is being delivered. The pressures, airway pressure, if you set a pressure limit, if that pressure limit is achieved, the volume, the breath is discontinued, whatever tidal volume. If you are trying to achieve more than that, it can cause barotrauma. Also, in this, flow is constant. Now, what happens when we use volume control mode in laparoscopic surgery? We all know diaphragm is pushed up. So volume, if we are setting up the volume, for that volume, the higher peak airway pressures are achieved. Sometimes the volume is delivered, we are not able to deliver the volume. And if we are trying to avoid atelectasis and adding PEEP, the peak airway pressure further increasing, causing high incidence of barotrauma. So this graph also tells you that there is a constant flow to deliver the tidal volume, and the pressure keeps increasing to deliver a fixed tidal volume. So this mode, though commonly used, is not the ideal mode for ventilation in laparoscopic surgeries. Coming to the next mode, which is the pressure control mode. In this, pressure is the constant. Okay, you have set a pressure and that pressure you try and achieve the adequate tidal volume. So volume which is delivered is variable, and there is a decelerating flow. So this pressure mode of ventilation is better than the volume mode because the flow is decelerating. The pressures are maintained constant, trying to achieve tidal volume, lesser chances of barotrauma. But the disadvantage is sometimes there is hypoventilation, and because volume delivery is variable, if the lung compliance decreases, the volume is not delivered and the pressure required to deliver adequate tidal volume may be very high. So chances of hypoventilation is there. Now coming to the third mode of ventilation, autoflow mode of ventilation. Now what is this? This is an advanced mode in volume control modes. In this, you have to actually choose autoflow ventilation. This is in combination with controlled volume control modes only. In this, you can say that these are kind of dual volume, pressure variable and volume, fixed volume modes are there. In this, inspiratory flow is in accordance with the tidal volume and lung compliance. The tidal volume is given at a minimal possible pressure. A decelerating flow pattern is there, which actually reduces the peak pressure also. So autoflow is you can say that tidal volume is guaranteed with adjusted flow and inspiratory preset. So an inspiratory pressure to start the breath is there, which is high, pressure is high and the flow is high. High in the sense it is fixed there. When the breath is started, during the continuation of the inspiratory phase, the flow starts decelerating. Because the flow decelerates, the pressure also decelerates and a minimal pressure is being attained at which the adequate tidal volume is being delivered. So this may sound confusing to you, but I will explain it with an example. If you're trying to insufflate the balloon, you try to blow air into the balloon. To initiate the full filling of the balloon, you require a higher flow, a larger pressure. Once that balloon starts inflating, then the flow which you are required to blow into the balloon decreases and the pressure also decreases and the balloon insufflates. It is the same principle used in the autoflow ventilation also. Initial pressure is high, initial flow is high, then there is deceleration of flow and hence the pressure also. So a tidal volume is achieved. You attain that the target of delivering the adequate tidal volume with autoflow, but at the same time, you don't worry about the pressures. Peak airway and plateau airway pressures are maintained on the lower side. So how do you select? You have already selected IPPV mode. Then you go into this I am talking about the dragger machines. In those touch screens, you have to go and select the extra settings. In the extra setting, you have to select for the autoflow and confirm it with the rotatory knob. Along with that, you have to set the other conventional parameters, which are the respiratory rate, T-inspiratory, tidal volume, peak airway pressure limit and tidal volume limit. Low tidal volume limit is also required and the high tidal volume limit is also required to avoid any kind of hypoventilation as well as hyperventilation. So when you see the parameters, you don't have to actually select, you don't see the flow parameter when you select the autoflow ventilation mode. What do we monitor? We actually have to monitor, we have to be vigilant because it's a dynamic mode. Our ventilators have become smart with the time and technology. They have very fine microprocessor chips which can detect small activities, changes in the pressure or compliance of the lung, and they have algorithms to actually I can say they have algorithms to actually come up to to meet up to the deficiencies which are caused. Like there is a certain leak, then the microprocessor will detect the leak and will enhance the tidal volume to actually meet the delivery of the adequate tidal volume. So what do we monitor? We monitor the peak pressures, which decrease with the flow. So peak pressure is achieved, when the flow decelerates, the peak pressure decreases. P inspiratory, it adjusts as per the compliance of the chest. The inspiratory flow pattern, it also alters. That is, the inspiratory flow may be lengthened as compared as compared to the when you see the flow in the volume control mode, and when you see it in the auto flow ventilation mode, the flow pattern of the inspiratory phase may be lengthened. Tidal volume, if not delivered adequately, the low tidal volume alarm will come up. Spontaneous breathing activity can be seen by these crests, and the pressure volume loops on the screen will definitely show you the improved pressure volume relationship. So if I may explain these loops and graphs, you can see the spontaneous the control ventilation initially, and then the spontaneous ventilation. In the control ventilation, there is a flow, there is a high flow, and once the high flow has initiated the breath, it starts decelerating and the adequate tidal volume is achieved. Similarly, on the pressure side, you see after the PEEP, there is a pressure, a peak airway pressure, which is reduced. P inspiratory is there. The T inspiratory time may appear to be lengthened, and adequate tidal volume is achieved at the lower pressure. Then spontaneous breaths are also seen as small crest over there. So peak pressures decreases with decelerating flow. I have emphasized enough that this autoflow ventilation actually helps in achieving the adequate tidal volume at a lesser peak and plateau airway pressures. So to summarize, autoflow ventilation is a continuous pressure adjustment to deliver desired tidal volume at a reduced airway pressure, especially in variable lung compliances, and it also reduces the use of sedation and muscle relaxant. Coming to the advantages, I've already told that if you achieve adequate desired tidal volume, according to the lung compliance at a lower airway pressure and with decelerating flow, then there are lesser chances of hypoventilation and hypercapnia. So reduced peak and mean airway pressures are there. It is less invasive, less mechanically controlled by a ventilator. It recognizes and auto-compensates the leaks because it has microprocessor, very fine microprocessors. Hence, there is less requirement of sedation and muscle relaxant. If used in ventilators, the weaning over autoflow ventilation modes are much more smoother. And of course, we have lesser knobs to adjust and lesser alarms to actually manage in autoflow ventilation. Then this mode of ventilation is more physiological because it actually enhances the spontaneous breathing in patients. It is a synchronous mode because flow and volumes are adapted according to the patient needs. It is automatic, and it actually incorporates the weaning therapy also in many ways. It is simple with less control knobs and less alarms, and evidence actually proves that this autoflow ventilation autoflow with controlled volume control ventilation has all the benefits of BiPAP in it. So all in all, once we laparoscopic surgeries, we are very much concerned about the ventilation because of the insufflating gas, pneumoperitoneum, and the patient position. This autoflow mode of ventilation in volume control mode helps us in overcoming the hypercapnia, hypovolemia, hypercapnia, hypoventilation, and avoiding atelectasis. Thank you so much.
Thank you very much. So nice presentation. I have one question. Is it only with the Traeger anesthesia machines, or is the mode available with other anesthesia machines also?
Sir, due to some reasons, maybe ma'am
Okay.
has joined.
Okay, no problem. Thank you.
There was some.
Thank you. I think the session ends. Thank you very much.
Yes, sir. Yes, sir. You can conclude the session.
Okay, bye. Thank you very much.